history determines interpretation. Example, positive pregnancy test, pain, raises suspicion for miscarriage, ectopic pregnancy, molar pregnancy. So if someone comes with pain, then they've got a positive pregnancy test. This raises suspicion for miscarriage, ectopic pregnancy, molar pregnancy. Else, if there is no pregnancy positive test, it could be PID or some other pelvic lesions, abscesses, for instance. So, the clinical correlation in gynecology, the history, heavy menstrual bleeding, ultrasound, fibroids, the diagnosis, symptomatic fibroids. So, history, infertility, ultrasound, hydrosalpinx, possible tubal infertility. So, history, postmenopausal bleeding, ultrasound, endometrium, that is 10 millimeters, possible, that's highly suspicious of endometrial cancer. Clinical correlation, abdomen. So, patient with fever, ultrasound, hypoechoic liver lesion, possible diagnosis, liver abscess. Patient without symptoms, same lesion, possible hemangioma. Clinical history changes everything. So, clinical correlation in breast, patient age 24, oval lesion, parallel orientation, likely a fibroadenoma. Patient age 68, same lesion, needs greater suspicion, age changes interpretation. Thyroid ultrasound, neck swelling, ultrasound, multinodular goiter, history, hyperthyroidism, management changes. Because now, history, there's hyperthyroidism, then management will change. Unlike if it's just a goiter without hyperthyroidism. Doppler findings require clinical context. Absent ovarian blood flow, history, sudden severe pain, so it could be ovarian torsion. Absent flow, large postmenopausal ovary, possible necrotic tumor, differential diagnosis. So the common mistakes that are made: ignoring the history, scanning too quickly, reporting incidental findings only, missing symptoms, not asking about previous surgery, ignoring laboratory findings, failing to communicate urgent findings. So the case study 1, clinical history, 28 years, pain, positive pregnancy test, previous ectopic, ultrasound, empty uterus as you can see there, adnexial mass as you can see there, free fluid, diagnosis. This is suspected of a ruptured ectopic pregnancy. Without history, the diagnosis may be delayed. So case 2, history, heavy menstrual bleeding, ultrasound, large fibroid, hemoglobin 6 grams per dl, diagnosis, symptomatic fibroid causing severe anemia, requires urgent management. Case number 3, history, fever, right upper quadrant pain, elevated WBC, ultrasound, complex liver lesion, diagnosis, pyogenic liver abscess, not a hemangioma, not a hemangioma. So, communication with referring clinicians. Always communicate urgently when findings suggest a ruptured ectopic pregnancy, ovarian torsion, placenta abruption, deep vein thrombosis, abdominal aortic aneurysms, testicular torsion, appendicitis. Good communication always saves lives. So the structured reporting. An ideal report contains clinical history, pelvic pain, and positive pregnancy test. The findings, detailed ultrasound observations, impression, highly suspicious for ruptured tubal ectopic pregnancy. Recommendation, urgent gynecology review is advised. So the tips for better diagnostic accuracy: read the request form carefully, speak with the patient, review previous imaging, compare laboratory results, scan systematically, correlate symptoms findings, avoid premature conclusions, and discuss difficult cases. The diagnostic pills. These are the diagnostic pills. Treat the patient, not just the image. So you're dealing with the patient, not just the image. A perfect image without history can mislead. A modest image with excellent clinical correlation often leads to the correct diagnosis. Ultrasound is both an imaging science and a clinical art. Take note of that. Ultrasound is both an imaging science and a clinical art. So the final summary, clinical history transforms ultrasound from a descriptive imaging tool into a powerful diagnostic instrument. By integrating patient symptoms, past medical and surgical history, laboratory data, and image findings, sonographers and clinicians can reduce diagnostic errors, improve report quality, prioritize urgent conditions, and enhance patient outcomes. The most valuable ultrasound examination is not necessarily the one with the clearest images. It is the one interpreted within the correct clinical context. So the key take-home messages to you, ladies and gentlemen, always obtain a focused clinical history before scanning. Tailor your examination based on the patient's symptoms and risk factors. Correlate ultrasound findings with laboratory and clinical information. Recognize when similar ultrasound appearances have different meanings depending on the patient's history. Communicate agent findings promptly and provide clinical relevant recommendations. High quality ultrasound practice combines technical skill with sound clinical reasoning. Ladies and gentlemen, I think the message is so clear to all of you. Some, they think that ultrasound is only about images and their interpretation, but there is something that is beyond the images, the history of the patient, the communication that we have with the patient. At times, the patient is not so free to talk to the referring clinician. They can be free to give you more information to you that they didn't provide to the referring clinician that can help narrow down the diagnosis. Thank you so much. Don't forget to comment, share, and like. And also, if you've got questions, feel free. You can ask anything in the comment section. Then I assist you accordingly. Thank you so much.
Welcome, colleagues. How are you? So, what I am giving you now, this is the gold of first trimester ultrasound scan. I am giving you diamond fields of first trimester ultrasound scan for free. These are the diamonds, not emeralds. These are the diamonds. So, this is the atlas of first trimester pregnancy failure. This is the atlas. So below are representative ultrasound appearance of the most common types of first trimester pregnancy failure. So number one, that's a normal pregnancy for comparison. So a normal pregnancy, you are supposed to see the decidual array sign, the double decidual sign, that ring that we have. And if you zoom it, you can see the yolk sac there. The yolk sac is present there. So the yolk sac is present there. So this is the standard normal ultrasound scan that you all know of. But that is so good when it is like that. But it doesn't always follow like that, that you're going to see the normal. It is the abnormal that is now a going concern. So let's talk about the abnormal one. So the unembryonic pregnancy, the blighted ovum. So here you can see there, we can't see the gestational sac, neither can we see the embryo. There is nothing there. So there's nothing there. So sagittal view of an empty gestational sac or blighted ovum. So you can see there's nothing there. But we said you don't just jump and say this is a blighted ovum without measuring the mean gestational sac to be equivalent to or above 25 millimeters. As long as it is below 25 millimeters, you give it the benefit of the doubt. You can rescan it after a week or 2 weeks to see if the embryo start to develop. So this is the hallmark of a blighted ovum, an embryonic pregnancy. There is nothing. Yet the mean sac diameter is above 25 millimeters. So the embryonic demise, which is the so-called the missed abortion, the embryonic demise. So you can see here there is an elongated echogenic something that is here, that is echogenic and elongated. There is it's shrunken. So that is the dead embryo. So the embryos died there. The embryos died. You can see there. You can see the dead embryo there. The dead embryo. If as long as it is above 7 centimeters and there is no cardiac activity, then you are confident that you are dealing with a case of what? Of a missed miscarriage or a dead embryo. So you must see an embryo inside with no cardiac activity on condition that that same embryo is got a diameter that is above 7 millimeters. I hope this is percolating well and you are getting it nicely. Okay. Inevitable miscarriage. Inevitable. Inevitable. It means that it can't be stopped. It can't be stopped. So when you see that the pregnancy is now inside the cervix, is on its way out, that is an inevitable miscarriage. You cannot save that. So when the os is closed, is open, and the vaginal canal is now the cervical canal is now open, you are supposed to know that we are in the highway out. So that's an inevitable miscarriage. So now, incomplete miscarriage. So when there is an incomplete miscarriage, there are episodes, there are periods in the first trimester that someone comes, they were pregnant, they started bleeding, then they come for the sonar. You can see retained products. So returned products, they appear like that. You see that there's an echogenic endometrium thickened like that, and then you can see there is hyperemia or hyperperfusion or enhanced myometrial perfusion due to the retained products of what? Of conception. So you must not just rush to say everything that you see is a RPOs or is an incomplete miscarriage. It might be endometrial hyperplasia, it might be endometrial cancer. So the history is very critical. Was someone pregnant? Were they bleeding? Then you can talk of an incomplete miscarriage. A complete miscarriage. So complete spontaneous abortion. So you can see there that the endometrial is there and it's thin. There are no retained products inside. So this is a complete miscarriage. So do not confuse a complete miscarriage with a normal period, because with a miscarriage we must have a history of pregnancy first before someone can miscarry. Otherwise it's a period or it's another type of bleeding, abnormal PV bleeding. So now we also have got what is called the subchorionic hemorrhage. So the hemorrhage on this on the other side of the chorion, there on the other side of the chorion there is what is called the subchorionic hemorrhage. So you can see here the gestational sac there, but you can see that there's another anechoic space there, that ring that you're seeing there. So this is a hemorrhage. That's the bleeding in the subchorionic space. So the hemorrhage in the subchorionic space there, there's hemorrhage in the subchorionic space. You can see uh, in here it seems as if the gestational sac is detached, and then there's a hemorrhage all over here. So you must take note of a subchorionic hemorrhage and the threats that it can pose to the existing pregnancy. So please, this atlas will help you. it will help you to identify those soft markers of pregnancy failure. So the irregular gestational sac. So an irregular gestational sac that is not circular and all that is another sign of a pregnancy failure. You can see this is an elongated gestational sac. Don't see this and see that it is normal, and then you record that is normal, and then you try to measure the mean sac diameter like that. No, you see how it is like. Look, this is an irregular sac. Look how it is like that. Look how it is enlarged gestational sac like that. You see this one. So what we have here, guys, now is another sign of pregnancy that is failing. So it's an irregular gestational sac like that. So also an abnormal yolk sac. You see, look at this calcified yolk sac that we have there, a calcified yolk sac there, and then you can see this calcified rim of the yolk sac there, and which is also irregular. This is also another sonographic feature of a failing pregnancy. The yolk sac is also an indicator of a pregnancy that is likely to fail or that is going to fail. So you must look at the anatomy, the architecture of the yolk sac itself, if it is regular or well outlined at the same time without calcifications. So do you guys do that? Do you really check the yolk sac and analyze it for any sign of pregnancy failure? Yes, probably 19% do, probably 15% do, probably 10% do, probably 5, probably even 1% do. Do not leave these markers. These are the silent markers. That's why you say that I did a sauna today. Then someone comes after a week, they're bleeding, they're already miscarrying. Say, what happened? The pregnancy was very normal, because you overlooked these soft markers. You did not check them nicely. So when the patient comes, then they are now bleeding and all that. Then you say, I did my job, everything was fine. You understand? That kind of stuff. You understand? It is because of that. It is because of this. So the foundation is always very critical. Without the foundation, we cannot have structures. So pregnancy of unknown location. I have discussed about this. A pregnancy of unknown location is not a pathology. It is not a diagnosis. It is a condition, a transitional condition. It's a condition that is happening, but it's just like when you wash your clothes, they are still wet. It's a transition. When they dry up, they will not be wet anymore. Or if you keep soaking them in water, they will keep on being wet like that. You understand? So the condition, we don't know where the pregnancy is. You understand? That's a condition. But after some time, you know, it was an ectopic. Oh, it was just there in the endometrial cavity. I did not see it nicely. I did not use a TV, so I just used a transabdominal. You know, negligence, incompetence, use of outdated equipment, lack of experience are all confoundings when it comes to the diagnosis of some of these pregnancies of unknown origin. So the due diligence is to repeat. There's power in repetition. So the patient comes again, you check again, the pregnancy test is done again, they confirm the beta ECG if there are changes, you understand, to make sure that it was indeed not a pregnancy, it was a false positive pregnancy in the first place. You understand? So that's how we will get a definitive. When we get the definitive answer, now we are out of the phase where we say that this was a pregnancy of unknown. Now we know it was never there, or it was an ectopic pregnancy, or it was just an early pregnancy that was here to develop. Now it's there. I hope I'm making sense. So ectopic pregnancy mimicking pregnancy failure. So we can have an ectopic pregnancy that can also mimic pregnancy failure. There you can see there it will mimic. An ectopic pregnancy is not always a pregnancy failure because it can be a viable pregnancy, but it can pose risks. You understand? An ectopic pregnancy is not a pregnancy failure. It is a pregnancy outside the uterus. So it can, in the abdomen, if there's enough space and the attachments are fine, it can just reach term. I've seen one case where we monitored an abdominal ectopic pregnancy until the baby delivered, a healthy baby in the abdomen, outside the uterus. It's very possible. So do not confuse an ectopic pregnancy for a failed pregnancy. But though it poses far-reaching consequences when it's not diagnosed as well, it's life-threatening. I hope I am making sense. So now, early twin pregnancy with a single fetal demise, vanishing twin. So this is another manifestation of pregnancy failure. You can have one fetus normal in a twin pregnancy, then the other one is vanishing or is dying. So this is another case of a failed pregnancy. We are not saying both failed, one failed, you understand? Then the other can make it. So in vanishing twin, the remaining or the residual twin just can make it nicely, you understand? So it's a partial pregnancy failure where one fails and the rest continues. So if you are not careful, you do a sonar, you see the twins, you tell your patient that these are twins, but later on when they come, you see that's one. So you are going to be seen like someone who's incompetent. You must know that there is what is called the vanishing twin syndrome, a sign of pregnant failure. Then the other one may be probably vanished. That's what a professional does. So now, this collection covers the major ultrasound appearance encountered in first trimester pregnancy failure and is well suited for teaching case discussions or ultrasound training. So this is fundamental. It is very key. Those who are teaching, those who are doing case discussions, those are training. Please, this it is looks like not big like the Rumag box, but this is the summary of the epitome of first trimester ultrasound scan. I don't know how to express it better than that. So the key diagnostic ultrasound criteria, the finding a crown ramp length above or equal to 7 millimeters with no cardiac activity is a definitive pregnancy failure diagnosis. Mean sac diameter above or equivalent to 25 millimeters with no embryo, thus an unembryonic pregnancy. Thus an unembryonic pregnancy. Mean sac diameter above or equivalent to 25 millimeters with no embryo, thus an unembryonic pregnancy. So the empty uterus after previous confirmed pregnancy. So that's a complete miscarriage. Empty uterus after previous confirmed pregnancy. That's a complete miscarriage. Then the heterogeneous vascular tissue in uterus. So that is a retained product of conception. The heterogeneous vascular tissue in the uterus, that's a sign of retained product of conception, RPOCs. So gestational sac in the cervix. So inevitable miscarriage or abortion in progress. So that's an abortion in progress. Gestational sac in the cervix. So inevitable miscarriage and abortion in progress, or alternatively a cervical ectopic pregnancy. Enlarged or irregular yolk sac, suspicious for impending pregnancy failure. Enlarged or irregular yolk sac, suspicious for impending pregnancy failure. So it's a marker that the pregnancy might fail. So you must document like that. Irregular or collapsed gestational sac. So this is a poor prognostic sign when the gestational sac is irregular or collapsed. You must take note of that, guys. It's a poor prognostic sign. So the empty uterus with a positive beta HCG, empty uterus with a positive beta HCG. So that's a pregnancy or unknown location until proven otherwise. So if you have an empty uterus and the pregnancy test is positive, this is a pregnancy of unknown origin until proven otherwise. Ladies and gentlemen, besides your images or your pictures on your walls, your grandfather's pictures on your walls, I urge you to add the images of this atlas in the walls of your bedroom, so that each time you sleep, you are going to see these things over and over and over and over again, so that you don't miss anything. Someone who trained ultrasound in 1983 might have forgotten now that the abnormal yolk sac or a calcified yolk sac might be an indicator of pregnancy failure, and they've done several thousands of first trimester sonars, and most or some of the patients, they came back after a week or 2 weeks after having miscarried, and then you said everything was normal. You understand? Learning is on a continuum. Learning has to take place every time and every day. I thank you so much for your time. Please share this educational content with your colleagues and your friends. I urge you to do that for the sake of the patient. Thank you so much. Welcome, colleagues. How are you? So, what I am giving you now, this is the gold of first trimester ultrasound scan. I am giving you diamond fields of first trimester ultrasound scan for free. These are the diamonds, not emeralds. These are the diamonds. So this is the atlas of first trimester pregnancy failure. This is the atlas. So below are representative ultrasound appearance of the most common types of first trimester pregnancy failure. So number one, that's a normal pregnancy for comparison. So a normal pregnancy, you are supposed to see the decidual array sign, the double decidual sign, that ring that we have. And if you zoom it, you can see the yolk sac there, the yolk sac is present there. So the yolk sac is present there. So this is the standard normal ultrasound scan that you all know of. But that is so good when it is like that. But it doesn't always follow like that, that you're going to see the normal. It is the abnormal that is now a going concern. So let's talk about the abnormal one. So the unembryonic pregnancy, the blighted ovum, So here you can see there, we can't see the gestational sac, neither can we see the embryo. There is nothing there. So there's nothing there. So say the view of an empty gestational sac or blighted ovum. So you can see there's nothing there. But we said you don't just jump and say this is a blighted ovum without measuring the mean gestational sac to be equivalent to or above 25 millimeters. As long as it is below 25 millimeters, you give it the benefit of the doubt. You can rescan it after a week or 2 weeks to see if the embryo start to develop. So this is the hallmark of a blighted ovum, an embryonic pregnancy. There is nothing. Yet the mean sac diameter is above 25 millimeters. So the embryonic demise, which is the so-called the missed abortion, the embryonic demise. So you can see here there is an elongated echogenic something that is here, that is echogenic and elongated there. It's shrunken. So that is the dead embryo. So the embryos died there, the embryos died. You can see there, you can see the dead embryo there, the dead embryo. If as long as it is above 7 centimeters and there is no cardiac activity, then you are confident that you're dealing with a case of what? Of a missed miscarriage or a dead embryo. So you must see an embryo inside with no cardiac activity on condition that that same embryo is got a diameter that is above 7 millimeters. I hope this is percolating well and you are getting it nicely. Okay. Inevitable miscarriage. Inevitable. It means that it can't be stopped. It can't be stopped. So when you see that the pregnancy is now inside the cervix, is on its way out, that is an inevitable miscarriage. You cannot save that. So when the os is closed, is open, and the vaginal canal is now the cervical canal is now open, you are supposed to know that we are in the highway out. So that's an inevitable miscarriage. So now, incomplete miscarriage. So when there is an incomplete miscarriage, there are episodes, there are periods in the first trimester that someone comes, they were pregnant, they started bleeding, then they come for the sonar. You can see retained products. So retained products, they appear like that. You see that there's an echogenic endometrium thickened like that, and then you can see there is hyperemia or hyperperfusion or enhanced myometrial perfusion due to the retained products of what? Of conception. So you must not just rush to say everything that you see is a RPOs or is an incomplete miscarriage. It might be endometrial hyperplasia, it might be endometrial cancer. So the history is very critical. Was someone pregnant? Were they bleeding? Then you can talk of an incomplete miscarriage. A complete miscarriage. So complete spontaneous abortion. So you can see there that the endometrial is there and it's thin. There are no retained products inside. So this is a complete miscarriage. So do not confuse a complete miscarriage with a normal period, because with a miscarriage we must have a history of pregnancy first before someone can miscarry. Otherwise, it's a period or it's another type of bleeding, abnormal PV bleeding. So now we also have got what is called the subchorionic hemorrhage. So the hemorrhage on this on the other side of the chorion, there on the other side of the chorion, there is what is called the subchorionic hemorrhage. So you can see here the gestational sac there, but you can see that there's another anechoic space there, that ring that you're seeing there. So this is a hemorrhage. That's the bleeding in the subchorionic space. So the hemorrhage in the subchorionic space there, there's hemorrhage in the subchorionic space. You can see uh, in here it seems as if the gestational sac is detached, and then there's a hemorrhage all over here. So you must take note of a subchorionic hemorrhage and the threats that it can pose to the existing pregnancy. So please, this atlas will help you. It will help you to identify those soft markers of pregnancy failure. So the irregular gestational sac. So an irregular gestational sac that is not circular in all that is another sign of a pregnancy failure. You can see this is an elongated gestational sac. Don't see this and see that it is normal, and then you record that is normal, and then you try to measure the mean sac diameter like that. No, you see how it is like. Look, this is an irregular sac. Look how it is like that. Look how it is enlarged gestational sac like that. You see this one. So what we have here, guys, now is another sign of pregnancy that is failing. So it's an irregular gestational sac like that. So also an abnormal yolk sac. You see, look at this calcified yolk sac that we have there, a calcified yolk sac there, and then you can see this calcified rim of the yolk sac there, and which is also irregular. This is also another sonographic feature of a failing pregnancy. The yolk sac is also an indicator of a pregnancy that is likely to fail or that is going to fail. So you must look at the anatomy, the architecture of the yolk sac itself, if it is regular or well outlined at the same time without calcifications. So do you guys do that? Do you really check the yolk sac and analyze it for any sign of pregnancy failure? Yes, probably 19% do, probably 15% do, probably 10% do, probably 5, probably even 1% do. Do not leave these markers. These are the silent markers. That's why you say that I did a sauna today. Then someone comes after a week, they're bleeding, they're already miscarrying. Say, what happened? The pregnancy was very normal, because you overlooked these soft markers. You did not check them nicely. So when the patient comes, then they are now bleeding and all that. Then you say, I did my job, everything was fine. You understand? Oh, that kind of stuff. You understand? It is because of that. It is because of this. So the foundation is always very critical. Without the foundation, we cannot have structures. So pregnancy of unknown location. I have discussed about this. A pregnancy of unknown location is not a pathology. It is not a diagnosis. It is a condition, a transitional condition. It's a condition that is happening, but it's just like when you wash your clothes, they are still wet. It's a transition. When they dry up, they will not be wet anymore. Or if you keep soaking them in water, they will keep on being wet like that. You understand? So the condition, we don't know where the pregnancy is. You understand? That's a condition. But after some time, you will know. It was an ectopic. Oh, it was just there in the endometrial cavity. I did not see it nicely. I did not use a TVS. I just used a transabdominal. You understand? Negligence, incompetence, use of outdated equipment, lack of experience are all confoundings when it comes to the diagnosis of some of these pregnancies of unknown origin. So the due diligence is to repeat. There's power in repetition. So the patient comes again, you check again, the pregnancy test is done again, they confirm the beta ECG if there are changes, you understand, to make sure that it was indeed not a pregnancy, it was a false positive pregnancy in the first place. You understand? So that's how we will get a definitive. When we get the definitive answer, now we are out of the phase where we say that this was a pregnancy of unknown. Now we know it was never there, or it was an ectopic pregnancy, or it was just an early pregnancy that was here to develop. Now it's there. I hope I'm making sense. So ectopic pregnancy mimicking pregnancy failure. So we can have an ectopic pregnancy that can also mimic pregnancy failure. There you can see there it will mimic. An ectopic pregnancy is not always a pregnancy failure because it can be a viable pregnancy, but it can pose risks. You understand? An ectopic pregnancy is not a pregnancy failure. It is a pregnancy outside the uterus. So it can, in the abdomen, if there's enough space and the attachments are fine, it can just reach term. I've seen one case where we monitored an abdominal ectopic pregnancy until the baby delivered a healthy baby in the abdomen outside the uterus. It's very possible. So do not confuse an ectopic pregnancy for a failed pregnancy. But though it poses far-reaching consequences when it's not diagnosed as well, it's life-threatening. I hope I am making sense. So now, early twin pregnancy with a single fetal demise, vanishing twin. So this is another manifestation of pregnancy failure. You can have one fetus is normal in a twin pregnancy, then the other one is vanishing or is dying. So this is another case of a failed pregnancy. We are not saying both failed, one failed. You understand? Then the other can make it. So in vanishing twin, the remaining or the residual twin just can make it nicely. You understand? So it's a partial pregnancy failure where one fails and the rest continues. So if you are not careful, you do a sonar, you see the twins, you tell your patient that these are twins, but later on when they come, you see that's one. So you are going to be seen like someone who's incompetent. You must know that there is what is called the vanishing twin syndrome, a sign of pregnant failure. Then the other one may be probably vanished. That's what a professional does. So now, this collection covers the major ultrasound appearance encountered in first trimester pregnancy failure and is well suited for teaching case discussions or ultrasound training. So this is fundamental. It is very key. Those who are teaching, those who are doing case discussions, those are training. Please, this it is looks like not big like the Rumag books, but this is the summary of the epitome of first trimester ultrasound scan. I don't know how to express it better than that. So the key diagnostic ultrasound criteria, the finding a crown rump length above or equal to 7 millimeters with no cardiac activity is a definitive pregnancy failure diagnosis. Mean sac diameter above or equivalent to 25 millimeters with no embryo, thus an unembryonic pregnancy. Thus an unembryonic pregnancy. Mean sac diameter above or equivalent to 25 millimeters with no embryo, thus an unembryonic pregnancy. So the empty uterus after previous confirmed pregnancy. So that's a complete miscarriage. Empty uterus after previous confirmed pregnancy. That's a complete miscarriage. Then the heterogeneous vascular tissue in uterus. So that is a retained product of conception. Heterogeneous vascular tissue in the uterus, that's a sign of retained product of conception, RPOCs. So gestational sac in the cervix, so inevitable miscarriage or abortion in progress. So that's an abortion in progress. Gestational sac in the cervix, so inevitable miscarriage and abortion in progress, or alternatively a cervical ectopic pregnancy. Enlarged or irregular yolk sac, suspicious for impending pregnancy failure. Enlarged or irregular yolk sac, suspicious for impending pregnancy failure. So it's a marker that the pregnancy might fail. So you must document like that. Irregular or collapsed gestational sac. So this is a poor prognostic sign when the gestational sac is irregular or collapsed. You must take note of that, guys. It's a poor prognostic sign. So the empty uterus with the positive beta HCG, empty uterus with a positive beta HCG. So that's a pregnancy or non-location until proven otherwise. So if you have an empty uterus and the pregnancy test is positive, this is a pregnancy of unknown origin until proven otherwise. Ladies and gentlemen, besides your images or your pictures on your walls, your grandfather's pictures on your walls, I urge you to add the images of this atlas in the walls of your bedroom, so that each time you sleep, you are going to see these things over and over and over and over again, so that you don't miss anything. Someone who trained ultrasound in 1983 might have forgotten now that the abnormal yolk sac or a calcified yolk sac might be an indicator of pregnancy failure, and they've done several thousands of first trimester sonars, and most or some of the patients, they came back after a week or 2 weeks after having miscarried, and then you said everything was normal. You understand? Learning is on a continuum. Learning has to take place every time and every day. I thank you so much for your time. Please share this educational content with your colleagues and your friends. I urge you to do that for the sake of the patient. Thank you so much. Hello, colleagues. How are you? So in this presentation, I am going to talk about early pregnancy failure. So it doesn't automatically mean that when someone gets pregnant, that pregnancy is going to make it. It's either it's going to make it or it's going to fail, or there are going to be complications. So here is a simplified approach to identifying pregnancy failure in the early stages. So early stage pregnancy failure refers to a non-viable pregnancy during the first trimester. It is usually occurs before the 13th week of gestation. Ultrasound is the most reliable imaging tool for confirming viability and guiding patient management. So ultrasound has got a very huge role in determining pregnancy failure and also identifying some of the early risks of pregnancy failure that you can identify. So step one, when you're doing an early ultrasound scan, is confirm the location of the pregnancy. So you should ask, is the pregnancy inside the uterus? That's very fundamental. Is there more than one gestational sec? So you are now working as a professional. You are having questions that you need to answer. You don't just hold a probe without having questions that you ought to answer. So, could this be an ectopic pregnancy? So, this is fundamental. This is very key. Is it intrauterine or is extrauterine? That's very pertinent. So, look for the gestational sac itself. You must look at the double residual sign. Is it there or is it absent? Where is it? You should look for the yolk sac. You should look for the embryo or the fetal pore itself. Is it there? At what stage are we? Is it visible or not? So if you know intrauterine pregnancy is seen, then consider a pregnancy of unknown location, PUL. So I've discussed about that previously. You can check in my previous presentations, then you can see where I was presenting about the pregnancy of unknown origin or location. So you must exclude an ectopic pregnancy, correlate with the serial beta SG measurements and repeat ultrasound scan if there is no pregnancy that is seen. So those are the other things that can be happening. It could be a pregnancy of an unknown location origin, then it could be an ectopic pregnancy, or you should consider beta ACG measurements and repeat the scan to make sure that the pregnancy was there in the first place. So step number 2 is assessing the viability. A viable pregnancy should demonstrate a gestational sac, a yolk sac, the embryo itself, and the cardiac activity. So you have to look at those things. So diagnostic criteria for pregnancy failure. Pregnancy failure is diagnosed when either of the following is seen: crown rump length equal to or above 7 mm with no heartbeat. So if you see that the crown rump length is equal to above 7 mm and you can't see a heartbeat, you must now think of a pregnancy failure. Or the mean sac diameter is above or equivalent to 25 millimeters with no embryo inside. These findings are considered definitive for a failed what? Pregnancy. Guys, ladies and gentlemen, write this down. This is your Bible. A crown rump length above or equal to 7 with no heartbeat. That is a sign of pregnancy. Definitive. If you measure this mean sac diameter is above or equivalent to 25 millimeters with no embryo, these are considered definite diagnosis for a failed pregnancy. I hope I am making sense there. I hope I'm making sense, okay? So step number 3, you must identify the type of early pregnancy failure. 1, an embryonic pregnancy or a blighted ovum. Ultrasound findings include a large gestational sac with no embryo, may or may not contain a yolk sac. So there might be or there might not be a yolk sac. So it doesn't mean that if there is a yolk sac, the pregnancy it's viable. Okay? So the diagnosis: mean sac diameter above or equivalent to 2 millimeters without an embryo is a sonographic sign, a definitive diagnosis of a failed pregnancy. So embryonic demise or miscarriage. Ultrasound findings: you see an embryo is present, but there's no cardiac activity, and the crown rump length is above or equivalent to 7 millimeters. So don't just rush to say that you are seeing a case of a missed abortion when it's not measuring less than or equal to 7 millimeters. So you must make it a point that when you're talking about an embryonic demise or a missed miscarriage, it has to conform to those. The embryo should be present. There should be no cardiac activity, and the crown rump length should be above or equal to 7 millimeters. So now, incomplete miscarriage. Ultrasound findings: thickened heterogeneous endometrium, retained products of conception, then increased vascularity on Doppler, which may be present or it might not be present. So those are the things that you have to look into when you're considering that a miscarriage has happened. So what are the ultrasound findings? What is it they're looking at? You don't just do a sonar nicodemously without understanding exactly. You must have a map. It's just like a builder who's building a house. They have what the design. You understand? They have the plan for the house. They know exactly what to do next. You understand? It's methodical. It's procedural. So when you're doing an ultrasound scan, it has to be procedural. It has to be methodical. You understand? You don't. You have to take it stepwise. Know what to look for. Know the pitfalls. You know, so that you give a comprehensive and a correct report. So the clinical features: vaginal bleeding, passage of tissue, and the open cervical os. So those are some of the part of the history that formulates an incomplete miscarriage or a miscarriage. So if someone presents with those clinical signs, it should ring at the back of your mind that you are likely dealing with a case of of a of a miscarriage, one or the other, be it complete or incomplete. Also, you must correlate with the information, the knowledge that your referring clinician and the patient is giving you. So, complete miscarriage. Ultrasound findings in empty uterus, thin endometrium without retained products of conception. So there should not be any. Don't just call everything a miscarriage before there's a confirmation that someone was pregnant before. So someone might just bleed because of other causes. It could be fibroids, it could be arteriovenous malformations, it could be polyps, it could be hormonal imbalances. It could be anything. It could be abnormal periods as well. So it doesn't mean when someone's bleeding is a miscarriage. So you have to also take into cognizance the history of where is the patient coming from. Was the pregnancy test done prior, and what were the findings? So clinical history usually includes complete passage of pregnancy tissue. So now, pregnancy of unknown location, PUL. Ultrasound findings: positive pregnancy test, no intrauterine pregnancy is noted, no definitive ectopic pregnancy is noted. So it requires serial beta HCG, repeat ultrasound in 48 or 72 hours. So if you don't see any sign of pregnancy, if someone is testing positive for the pregnancy, they warrant to be a transitional period where you call that a pregnancy of unknown origin. So the pregnancy of unknown origin is a transitional term, after which the answer will be found. Either someone was not pregnant at all, or it was an ectopic, or it was just an early pregnancy that was to develop in the normal endometrial cavity. So you must understand those things. Don't just rush to say that there's no pregnancy and then go. What about if it's too early for you to visualize it on ultrasound? And then you send someone say they are not pregnant, they go and they take these other drugs and all that, saying that thing that they're not pregnant. So do not be a risk practitioner, please. So evaluate for complications. Always assess for subchorionic hematoma, free pelvic fluid, adnexia masses, retained products of conception, and signs of ectopic pregnancy. So, guys, this is your Bible. Please, when you're doing your ultrasound scan, the first trimester scan, you must evaluate those signs of complications. Is there any subchorionic hematoma? Yes or no? And you localize it. Is there free pelvic fluid, be it caused by inflammation, be it caused by rupture of ectopic pregnancy or anything? So you must take note of that. Are there adnexal masses? You know, to quantify them. How many are they? Localize them. You understand? How big are they? Are they competing for space with the baby? So there's a lot of things that is involved to give a good report and also to save a pregnancy until the pregnancy delivered. So retain the products of conception if they are there. Then signs of ectopic pregnancy, you also have to take note of those. So now, this is a simplified ultrasound flowchart of the events or that ought to be done or that ought to be followed in that hierarchy or in that order. So now the first thing is positive pregnancy test. Is an intrauterine gestation sex seen? Yes or no? Is the embryo visible? If no, pregnancy of unknown location. Embryo visible? Yes or no? Is there heartbeat? Then embryo is absent. So mean sac diameter is above 25 millimeters. What does it entail? This is what? An embryonic pregnancy. So if that heartbeat is present, yes, so that's a viable pregnancy, which is very normal. If there's no heartbeat, so what are we saying? The crown rumble length is above or equal to 7 millimeters. That means what? It means that's a missed abortion. Yes, early pregnancy failure. No, repeat scan in 7 to 14 days. I repeat myself again. Look at this flow chart. Let us analyze it together. Let's do it stepwise like this. Pregnancy test is done. Is an intrauterine pregnancy or gestational 16? Is an intrauterine gestational 16? Yes or no? Pregnancy test positive. Is an intrauterine gestational 16? Now we are answering this using ultrasound. Yes, is there. Is the embryo visible? Yes or no? Is the heartbeat present? Yes or no? Is the crown rumble length above or equal to 7 millimeters? Yes or no? So you see, these are the questions that you have to flow, and you will be answering. If you master this flow chart, it will be very easy for you to do the sequence of an ultrasound first trimester ultrasound scan. So it's like that. You have to follow it like that. If you miss any of these steps, guys, you are going to make a very dangerous assumption. Doing an obstetric scan, it sounds like something that is very easy. I've checked the uterus, there's nothing innocent. I sent the patient away, there's nothing. Oh, I saw the patient, it's a missed abortion, or it's a blighted ovum, innocent. Maybe it did not make an extra effort. The fetus, the embryo is on the other end of the gestational sac, then you couldn't see it, or the probe angulation, or you didn't use the transvaginal, you understand? So there are many confoundings. So you must be very careful when you are doing this. So this is fundamental. This is your Bible, guys. Let me repeat it again for the third time, and I need you to repeat it over and over again. So this is the sequence how you do a first trimester ultrasound scan. The other mistake that most of these people do, they come to the department without a pregnancy test. So it's not good for the referring clinic just send a patient without testing the pregnancy. It's a protocol. They have to do that. So that if they come with a pregnancy result, they say that I have tested positive. Then you start from there. Then these are the questions that you are going to answer the ultrasound. Is an intrauterine gestational sac seen? Yes or no? If no, then it's a pregnancy of unknown location. You don't know where the pregnancy is, but it was someone says it positive, but the pregnancy can't see it. So yes, if the gestational sac is there, is the embryo visible? Yes or no? If not visible, then what does it mean? Is the mean sac diameter above or equal to 25 millimeters? If it's above and there's no visible embryo, what does it mean? It means this is likely to be what? A blighted ovum, an embryonic pregnancy. Then, if the heartbeat is, the baby is visible, is there heartbeat? Yes or no? If there's heartbeat, we are fine. That's a viable pregnancy. If there's no heartbeat, then is the crown rumble length above 7 equal to 7 millimeters? Yes or no? If yes, that's an early pregnancy failure. If no, repeat scan in 7 to 14 days. Ladies and gentlemen, I have done my part. I have done my part. I have given you the Bible. It's up to you to read the verses and the chapters when you deliver this to your patients so that you can serve a patient and you can become the ethical professional in your field and in your area, in your country, and in the department where you are working. Thank you so much. Don't forget to subscribe our channel and also notify others so that we produce the caliber of health cadres who are not just there for money, but who are there to save a patient. Thank you so much.
Welcome, colleagues. So in this presentation, I am going to talk about something that is not so familiar to most of you. Identifying rare diaphragmatic hernia variants during routine mid-trimester fetal anatomy screening. We will track the subtle displacement of the gastric bubble in subtle mediastinal shifts to identify rare diaphragmatic hernia variants, often missed during routine mid-trimester scans. So by isolating atypical retrocardiac masses and analyzing abnormal pleural interfaces, we bridge the gap between standard screening protocols and the definitive diagnosis of complex congenital defects. So the high stakes diagnostic challenge: what if a standard mid-trimester scan is hiding a life-altering secret right in front of you? Most clinicians look for the obvious, but rare diaphragmatic hernia variants often mask themselves as routine anatomy. Today, we are uncovering the subtle gastric displacements and atypical retrocardiac masses that separate a misdiagnosis from a life-saving intervention. So the expert investigative approach is the one that we're supposed to use. Those are experts. We are not students. We are not learners. We are not novices. Standard screening protocols often fail to catch complex congenital defects that don't follow the rules. By mastering the analysis of abnormal pleural interfaces and mediastinal shifts, you can bridge the gap between normal and critical. We are diving deep into the technical nuances of isolating rare variants that most ultrasound technicians overlook. So the hidden plain sight mystery. A routine fetal anatomy screening can change in an instant when you know exactly where the gastric bubble should be. These rare diaphragmatic hernias are masters of disguise, frequently mimicking benign structures during the second trimester. We are revealing the diagnostic roadmap to identifying these subtle anomalies before they become postnatal emergencies. So now, our title and its elaboration: identifying rare diaphragmatic hernia variants during routine mid-trimester fetal anomaly screening. So these are my presentation notes. Congenital diaphragmatic hernia CDH is a developmental defect of the fetal diaphragm that often allows abnormal abdominal organs to herniate into the thoracic cavity. Although most sonographers recognize classic left-sided CDH, rare variants may be overlooked during routine anomaly scans because they mimic normal anatomy or present with subtle findings. The aim of this presentation is to improve recognition of uncommon diaphragmatic hernias during the standard 18 to 24-week fetal anatomy examination. So what are our learning objectives? By the end of this presentation, we hope that you should be able to identify embryological development of the diaphragm, recognize common and rare diaphragmatic hernia variants, identify key sonographic signs, differentiate diaphragmatic hernias from thoracic masses, perform systematic ultrasound assessments, know when fetal MRI or specialist referral is indicated. So the embryology of the diaphragm. The diaphragm develops from 4 embryological components, which are the septum transversum, pleural peritoneal membranes, dorsal mesentery of the esophagus, and the muscular ingrowth from the body wall. Failure of fusion results in diaphragmatic defects, timing weeks 4 to 10 of gestation. So These are the types of diaphragmatic hernias that we have. I hope you've heard about them or you've never heard of. You are fortunate if it's the first time, because I'm going to tell you about them. So the first type is called the left buccal hernia. This is the most common, which is the frequency of 80 to 85%, which is the left posterior lateral aspect. That's the most location. Then the right buccal, which constitutes about 10 to 15%. Right posterior lateral. Then you've got the bilateral, less than 2%, which affect both sides. Then the mogagni, 2 to 5%, which is the anterior parasternal aspect. Then you've got the central tendon defect, which is very rare. They affect the central diaphragm. Evacuation, which is rare. Weak diaphragm rather than the true defect. Then you've got the hiatus hernia, which is extremely very rare. That is the esophageal hiatus. So the left buccal hernia, what is it? Typical findings include stomach inside the thorax, mediastinum shift to the right, cardiac displacement with a small abdominal circumference, polyhydramnios in late pregnancy. Diagnosis is usually straightforward. For this is the most common. If it happens, it's very obvious to see it on ultrasound. So the rare variant, which is the right-sided CDH, this variant is commonly missed because liver and lung have similar echogenicity. Stomach remains in the abdomen. Minimum mediastinal shift may be present. So helpful clues to identify it. Hepatic veins appear or are seen above the diaphragm. Hepatic veins. So if you see the hepatic veins above the diaphragm, so you should have a clue. The portal vein within the chest. So if you see the portal vein as well, so you know you have to use color Doppler to visualize this. The gallbladder visualized in the thorax and interrupted diaphragm. Color Doppler is extremely valuable. So the Mogagni hernia, anterior diaphragmatic defect, often contains the liver, the colon, and the omentum. Characteristics: mild cardiac displacement, anterior thoracic mass, easily confused with the teratoma or pericardial cyst or a lung lesion. Bilateral CDH. This is very common. This is very uncommon. So it's very uncommon when it happens in both sides. So ultrasound findings include severe pulmonary hypoplasia, both hemidiaphragmatic disruption, liver centrally displaced, with the poor visualization of abdominal organs. It is associated with very poor prognosis. Diaphragmatic evacuation. What is diaphragmatic evacuation? So not a true hernia. The diaphragm remains intact but is abnormally elevated due to the deficient muscle development. Sonographic features include smooth elevated diaphragm, liver remains below the diaphragm, no bowel loops inside chest. So the important differential diagnosis. Hiatus hernia. Very rare presentation. Signs include small cystic structure behind the heart, intermittent movement, normal diaphragm, normal abdominal stomach, can easily mimic bronchogenic cyst, esophageal duplication cyst. So systematic ultrasound assessment, you should evaluate the 4-chamber heart, the cardiac axis, the mediastinal position, the diaphragmatic continuity, the stomach position, the liver position, the portal vein, hepatic veins, the bowel loops, also subject them to color Doppler assessment. Color Doppler clues. What are some of the clues that you can get from color Doppler? Look for portal vein inside the thorax, hepatic veins above the diaphragm, umbilical vein displacement, the hepatic artery entering the chest. These findings strongly suggest right-sided liver herniation. So the lung to head ratio, measure contralateral lung area, observe expected lung head ratio, helps predict pulmonary hypoplasia, neonatal survival, a need for fetal intervention, the poor prognosis observed or expected when the lung to head ratio is less than 25%. So the differential diagnosis, CPM, which is no abdominal organs are found in the chest. Bronchopulmonary sequestration, feeding systematic arteries observed, bronchogenic cyst, solitary cyst, mediastinum teratoma, you see the calcifications, then the eventration in the diaphragm, pericardial cyst is to be adjacent to the heart. So the associated anomalies, approximately 40 to 50% of fetuses have associated anomalies. Common associations include cardiac defects, chromosomal abnormalities, neural tube defects, skeletal abnormalities, gastrointestinal malformations, and the genetic counseling should be considered always. So the role of MRI. What is the role of MRI in these congenital hernias? So MRI helps evaluate liver herniation, lung volume, hernia contents, surgical planning. MRI complements ultrasound but does not replace it. So the management includes maternal fetal medicine referral, detailed fetal echocardiography, genetic testing when indicated, serial ultrasound, MRI, delivery at a tertiary center, and neonatal surgery. So these are some of the practical scanning skills that you guys have to master or should put into context. Always identify the stomach, follow the diaphragm continuously, examine both hemidiaphragms, assess the cardiac axis, use multiple scan planes, apply color Doppler, check liver location, confirm bowel position. So now, to wrap this up, you take home messages. Rare diaphragmatic hernias are frequently overlooked. Right-sided defects are the most challenging because liver echogenicity resembles lung tissue. Color Doppler substantially improves detection. A systematic review of the diaphragm, stomach, liver, and mediastinum during every routine mid-trimester anatomy scan increases diagnostic confidence. Early prenatal diagnosis supports multidisciplinary counseling, delivery planning, and improved neonatal care. So, ladies and gentlemen, this is another piece of a cake to take home, to take to practices, so that we make our second trimester screening something that is really memorable to you and the patients. If it doesn't give those memories, it means we have done an injustice. So the memories said they may be, but they can save the patient. So this marks the end of our today's presentation. Let's grow the community. Share our content. Like, if you've got any questions, feel free. Our lines are directly open for communication. Anything that you feel you need, any information that you think we should share, we are there for you. Thank you so much. Enjoy the rest of your day. Bye for now.
Below are 20 ARDMS SPI sonograph principles and instrumentation style multiple choice questions covering ultrasound instrumentation physics. Each question includes the correct answer and a detailed explanation. ARDMS SPI practice questions instrumentation physics. So question 1, which ultrasound provides the best axial resolution? So I need you to write the answer in the comment section. Then the next page, I'm going to give you the correct answer. So write while I am opening this page. I'll give you a few minutes, then a few seconds, then I'll show you the answer. Question 1, which ultrasound transducer provides the best axial resolution? A, 2 MHz transducer, B, 3 MHz transducer, C, 5 MHz transducer, D, 10 MHz transducer. Which ultrasound transducer provides the best axial resolution? A, 2 MHz transducer, B, 3 MHz transducer, C, 5 MHz transducer, D, 10 MHz transducer. Let's go to the answer. So our answer is D, 10 MHz transducer. Explanation: higher frequency transducer produces shorter spatial pulse length, improving axial resolution. However, penetration depth decreases as frequency increases. So our answer is D, 10 MHz transducer. So you know that the higher the frequency, the higher the axial resolution, but the lesser the penetration depth. Question number 2. Axial resolution is primarily determined by A, the beam width, B, pulse repetition frequency, C, spatial pulse length, D, the dynamic range. Axial resolution is primarily determined by A, the beam width, B, pulse repetition frequency, C, spatial pulse length, D, dynamic range. So write your answer. So let's go to the answer now. Answer is C, spatial pulse length. Explanation: axial resolution is the ability to distinguish two structures lying along the beam axis. The shorter spatial pulse length SPL is equal to beta axial resolution. So axial resolution is the ability to distinguish two structures lying along the beam axis. So the shorter the spatial pulse length equals beta axial resolution. Question number 3. Increasing the transfer frequency will increase penetration, increase wavelength, improve resolution, D, increase attenuation length. Question 3. Increasing the transducer frequency will A, increase penetration, B, increase wavelength, C, improve resolution, D, increase attenuation length. So which one is the correct answer? Type your answers again. Okay, now let's disclose the answer. The correct answer is improve resolution. The explanation: higher frequency means better image resolution, more attenuation, less penetration. Higher frequency means better image resolution, more attenuation, and lesser penetration depth. Question number 4. The speed of sound in soft tissues assumed to be A, 1,200 meters per second, B, 1,450 meters per second, C, 1,540 meters per second, D, 1,700 meters per second. So the correct answer is 1,540 meters per second. 1,540 meters per second. That's the correct answer. So I've explained about that. So ultrasound scanners assume sound travels 1,540 meters per second in soft tissue. So the question number 5. The relationship between frequency and wavelength is A. Directly proportional, B. Inversely proportional, C. There's no relationship, D. Is exponential. The relationship between frequency and wavelength is A. Directly proportional, B. Inversely proportional, C. No relationship, D. Is exponential. So what's the correct answer? Wavelength and frequency, how are they related? Now let's discuss the answer. Answer is B. They are inversely proportional. So the explanation sorry, the wavelength is equal to speed of sound over the frequency. So the higher the frequency, the shorter the wavelength. So that's an inverse proportional relationship. Question number 6. What imaging artifact occurs when sound travels through a structure with a very low attenuation? A. Shadowing, B. Mirror image, C. Posterior acoustic enhancement, D. Reverberation. What imaging artifacts occurs when sound travels through a structure with very low attenuation? A. Shadowing, B. Mirror image, C. Posterior acoustic enhancement, D. Reverberation. So let's go to the answer. The correct answer is posterior acoustic enhancement. Explanation: fluid-filled structures attenuate very little sound, producing increased echoes deep to the structure. So the answer is posterior acoustic enhancement. Question number 7. Posterior acoustic shadowing is most commonly produced by A. The urinary bladder, B. Gallstones, C. Ovarian cyst, D. Ascites. Posterior acoustic shadowing is most commonly produced by A. Urinary bladder, B. Gallstones, C. Ovarian cyst, D. Ascites. Which one is the correct answer? Let's go to the answer. Answer is B. Gallstones. Strong reflectors and absorbers such as stones and bone create acoustic shadows. Question number 8. Which type of resolution is improved by electronic focusing? Which type of resolution is improved by electronic focusing? A. Temporal resolution, B. Contrast resolution, C. Lateral resolution, D. Axial resolution. Which type of resolution is improved by electronic focusing? A. Temporal, B. Contrast, C. Lateral, D. Axial. So the correct answer is lateral resolution. Electronic focusing narrows the beam width and improving lateral resolution by so doing. So electronic focusing narrows the beam width, improving the lateral resolution. Question number 9. The piezoelectric effect refers to A. Sound reflection, B. Sound attenuation, C. Electrical energy converted into sound and vice versa, D. Doppler shift. The piezoelectric effect refers to A. Sound reflection, B. Sound attenuation, C. Electrical energy converted into sound and vice versa, D. The Doppler shift. Which one is the correct answer? So our answer is C. Electrical energy converted into sound and vice versa. Explanation: piezoelectric crystals generate ultrasound when electrically stimulated and generate electricity when struck by the returning echoes. So that is the piezoelectric effect. Question number 10. Pulse repetition frequency PRF primarily depends on pulse repetition frequency PRF primarily depends on A. The frequency, B. Imaging depth, C. Gain, D. The dynamic range. Question 10. The pulse repetition frequency PRF primarily depends on A. The frequency, B. The imaging depth, C. The gain, D. The dynamic range. Let's go to the answer. The answer is imaging depth, B. Greater imaging depth requires longer listening time, reducing PRF. Greater imaging depth requires longer listening time, reducing the pulse repetition frequency. Question number 11. Increasing the imaging depth will
increase the frame rate, increase the PRF, reduce frame rate, improve temporal resolution. Question 11. Increasing imaging depth will A. Increase frame rate, B. Increase PRF, C. Reduce the frame rate, D. Improve the temporal resolution. So our correct answer is C. It reduces frame rate. So greater depth means each pause takes longer to retain, lowering the frame rate. Greater depth means each pause takes longer to retain, lowering the frame rate. Question number 12. The Doppler shift is greatest when the Doppler angle is A, 90 degrees, B, 75 degrees, C, 60 degrees, D, 0 degrees. The Doppler shift is greatest when the Doppler angle is A, 90 degrees, B, 75 degrees, C, 60 degrees, D, 0 degrees. So our answer is D, is 0 degrees. Explanation: maximum Doppler shift occurs when blood flows parallel to the ultrasound beam. Maximum Doppler shift occurs when blood flow is parallel to the ultrasound beam. Question number 13. Aliasing occurs because gain is too high, frequency is too low, Doppler shifts exceed the linguistic limit, D, the dynamic range is low. Aliasing occurs because A, gain is too high, B, frequency is low, C, Doppler shift exceeds the linguistic limit, D, dynamic range is low. Which one is the correct answer? Which one is the correct answer? Now let's disclose the answer. The answer is C, Doppler shift exceeds the linguistic limit. Explanation: aliasing occurs when Doppler shift exceeds half the PRF, which is the pulse repetition frequency. Question number 14. Increasing the color Doppler scale will A, increase aliasing, B, reduce aliasing, C, increase gain, D, increase the frequency. Increasing the color Doppler scale will A, increase aliasing, B, reduce aliasing, C, increase gain, D, increase frequency. Which one is the correct answer there? Increasing the color Doppler scale will increase aliasing, reduce aliasing, increase gain, or increase frequency. So now let's go to the answer. Our answer is B, which is reducing aliasing. Explanation: increasing the velocity scale raises the linguistic limit, so it reduces aliasing. Question number 15. Which imaging mode provides the highest temporal resolution? A, B mode, B, color Doppler, C, M mode, D, harmonic imaging. Which imaging mode provides the highest temporal resolution? A, B mode, B, color Doppler, C, M mode, D, harmonic imaging. So the correct answer is C, which is the M mode. Explanation: M mode samples a single scan line repeatedly, providing very high frame rates. Question number 16. What is the primary purpose of time gain compensation TGC? What is the primary purpose of time gain compensation TGC? A, increasing penetration, B, compensation for attenuation with depth, C, improve lateral resolution, D, reduce Doppler rays. What is the primary purpose of time gain compensation TGC? A, increase penetration, B, compensate for attenuation with depth, C, improve lateral resolution, D, reduce noise. So the correct answer is B, which is compensate for attenuation with depth. The explanation: TGC selectively amplifies echoes from deeper tissues to create uniform image brightness. Question number 17. Which transducer is the widest near field? Which transducer is the widest near field? A, the linear array, B, the curvilinear, C, phased array, D, endocavitary. Which transducer is the widest near field? A, linear array, B, curvilinear, C. phase array, D. endocavitary. So the correct answer is A, with the linear array. Explanation: linear arrays produce a rectangular image with a wider near field, ideal for vascular and superficial imaging. So the linear array produces a rectangular image with a wider near field, which is ideal for vascular and superficial imaging. Question number 18. Dynamic range controls: A. beam width, B. image contrast, C. penetration, D. pulse repetition frequency. Dynamic range controls: A. the beam width, B. image contrast, C. penetration depth, D. PRIF. So the correct answer is B, which is the image contrast. Explanation: a wider dynamic range displays more shades of gray in producing longer image contrast. A wider dynamic range displays more shades of gray, producing lower image contrast. Question number 19. Which factor primarily determines penetration? A. the gain, B. the frequency, C. TGC, D. compression. Which factor primarily determines penetration? A. gain, B. frequency, C. TGC, D. compression. So the correct answer is B, which is the frequency. Explanation: the lower frequency transducers penetrate deeper because they experience less attenuation. The lower frequency transducers penetrate deeper because they experience lesser attenuation. So question number 20, which is the last one. The Alara principle means: A is always lower acoustic radiation automatically, B as low as reasonably achievable, C acoustic levels are regularly assessed, D acoustic limit and radiation avoidance. So which one is the correct answer? The Alara principle means: A always lower acoustic radiation automatically, B as low as reasonably achievable, C acoustic levels are regularly assessed, D acoustic limit and radiation avoidance. So the correct answer is Alara is the guiding safety principle in diagnostic ultrasound. Operators should use the lowest acoustic output and shortest scanning time necessary to obtain diagnostic information. So our answer is B, as low as is reasonably achievable. So now, these are some of the tips of the RDMS SPI study tips for the examination, those who are writing, and also those who want to revise their ultrasound physics. You should master the relationship between frequency, wavelength, resolution, and penetration. Understand Doppler physics, especially the analyzing the linguistic limit, PRF, and Doppler angle. Learn common artifacts: shadowing, enhancement, reverberation, mirror artifact, refraction, side lobes. So you have to read about these. Review quality assurance, transducer types, focusing, beam formation, image optimization. You should memorize the key constants, e.g. the speed of sound in soft tissue is 1540 meters per second. The linguistic limit is half the pulse repetition frequency. The higher frequency means better resolution but lower penetration. Lower frequency is equal to greater penetration but lower resolution. Shorter SPL means better axial resolution. So these questions closely reflect the style and difficulty of the RDMS sonograph principle and instrumentation examination are useful for examination principles. So for examination preparation, sorry guys. So ladies and gentlemen, I will keep on giving you the different questions so that you have a bank of questions where you can study from, and also you can complement with the textbooks that we have so that you prepare yourself for the examination. Also, it's not only for those who are writing examination, even those who are studying their ultrasound, to master ultrasound. So keep abreast of this information, guys. Read widely so that you master ultrasound. Thank you so much. Don't forget to comment, like, and share. Enjoy your day. Hello, colleagues, and how are you? So today I have something special for you. So we have what we call endometrial receptivity quiz, evaluating normal and pathological changes during the menstrual cycle. That's our quiz for the day. So endometrial receptivity quiz, evaluating normal and pathological changes during the menstrual cycle. It's presented by Medical Ultrasound Academy to you guys with love. So the narration: can you identify receptive endometrium in this quiz? You test your ultrasound knowledge by recognizing normal cyclical changes and differentiate them from pathological conditions that may impair implantation. So the objectives of this quiz: by the end of this quiz, you should be able to recognize normal endometrial appearances, identify optimum implantation features, differentiate pathology from physiology, interpret ultrasound findings clinically, and improve fertility ultrasound reporting. So our quiz start now. Question number 1: which menstrual phase is shown? So these are the images. These are the images. These are the images. So which menstrual phase is shown? A, menstrual; B, early proliferative; C, late proliferative periovulatory; D, secretory. So I need you to type your answer for question number 1 in the comment section, and then after, in the next page, I'm going to disclose the answer. So do it right now. This helps us to learn. We are learning. It's not an examination class, but this is how we learn. Which menstrual phase is shown? A, menstrual; B, early proliferative phase; C, late proliferative peri-ovulatory; then D, secretory. Which is the best option? A, B, C, or D? Okay, I'm going to the next question. I'm going to the answer straight. Then after, I'll go to the next question. So now let me disclose the answer to you. So the answer is C for question number 1. Explanation: the classic triple line trilaminar appearance represents the late proliferative phase immediately before ovulation. The characteristics: the thickness from 7 to 11 millimeters, central echogenic line, hypoechoic functional layers, best implantation potential. So our answer is C. Question number 2. This endometrium is, so look at the endometrium. So that's the endometrium that we have. That's the endometrium that we have there. So what is this? This endometrium is A, menstrual; B, secretory; C, hyperplasia; D, it's a polyp. Question number 2. This endometrium is A, menstrual; B, secretory; C, hyperplasia; D, a polyp. So let's go to the answer now. So the correct answer is B. During the secretory phase, uniform echogenicity with a thick endometrium with the loss of the trilaminar appearance, progesterone effect. So that's secretory phase of the cycle. Question number 3. An endometrium thickness of 4 millimeters during embryo transfer is an endometrial thickness of 4 millimeters during embryo transfer is A, normal, B, excellent, C, poor receptivity, D, hyperplasia. And so that's the endometrium that we have there. If it measures 4 millimeters there, an endometrial thickness of 4 millimeters during embryo transfer is A, normal, B, excellent, C, poor receptivity, D, hyperplasia. Now let's go to the answer. So the correct answer for question number 3 is C. Explanation: a very thin endometrium is associated with lower implantation rates. So 4 millimeters is low, reduced pregnancy success, and poor vascular development. The answer is C. The explanation: a very thin endometrium, in our case was 4 millimeters, is associated with lower implantation rates, reduced pregnancy success, and poor vascular development. Now, question number 4. What pathology is demonstrated? Look at this. Look at this, what we have there. Look at this. Look at that. Look at that. What is that? What is this pathology? What is this pathology? That's the uterus. What is that pathology there? A submucosal fibroid. B, an endometrial carcinoma. C, endometrial polyp. D, secretory endometrium. What pathology is demonstrated? A, submucosal fibroid. B, endometrial carcinoma. C, endometrial polyp. D, secretory endometrium. So let's go to the answer. So our correct answer is C. The key features: focal echogenic lesion, feeding vessel on color Doppler, well-defined margins, may reduce implantation. So this is a polyp. So the answer is C. So a polyp has got a focal echogenic lesion with a feeding vessel on color Doppler, well-defined margins. It may reduce implantation. Question number 5. Which diagnosis best fits? So look at what we are seeing there, look at what we are seeing there, look at what we are seeing there. What we have there, what we have there. A, hyperplasia. B, normal secretory endometrium. C, menstrual phase. D, atrophic endometrium. Which diagnosis best fits? A, hyperplasia. B, normal secretory endometrium. C, menstrual phase. D, atrophic endometrium. So the correct answer is A. Ultrasound findings: thickened endometrium, heterogeneous echoes, cystic spaces, and diffuse involvement. So this is what? Endometrium hyperplasia. Now, question number 6. Which pathology commonly reduces implantation by distorting the cavity? By distorting the cavity. Which pathology commonly reduces implantation by distorting the cavity? Look what is going on there. This is distortion of the cavity. What is that? A, an intramural fibroid. B, a cervical polyp. C, a submucosal fibroid. D, an aborted cyst. Which pathology commonly reduces implantation by distorting the cavity? A, intramural fibroid. B, cervical polyp. C, submucosal fibroid. D, an aborted cyst. So let's disclose the answer. So the answer is C. So that's a submucosal fibroid, which distort the endometrial cavity and prevent embryo implantation, which increases the risk of a miscarriage. Question number 7. Which condition may cause implantation failure? In this case, what you're seeing there, look at this hyperemia, look at that hyperemia that is happening in this uterus there. Which condition may cause implantation failure in such a case? A, endometritis. B, secretory phase. C, normal menstruation. D, ovulation. Which condition may cause implantation failure? A, endometritis. B, secretory phase. C, normal menstruation. D, ovulation. So let's disclose the answer now. So the correct answer is A. This is endometritis, of which the signs include a thick, irregular endometrium, fluid collection, increased vascularity, clinical history of infection. So the answer is endometritis, that you've got these sonographic features: thick, irregular endometrium, fluid collection, increased vascularity, with a clinical history of infection. Question number 8. Which uterine disorder may impair implantation? Look at what's going on there. This is the myometria with some cystic spaces there. We have got this focal thickening there. Which condition is that? Which uterine disorder may impair implantation? A, adenomyosis. B, cervical cyst. C, follicular cyst. D, a normal uterus. Which is the best option in this case? A, adenomyosis. B, cervical cyst. C, follicular cyst. D, normal uterus. So the correct answer is A, which is adenomyosis. So typical findings of adenomyosis are globular structured uterus, some myometrial cyst, fan-shaped shadowing the Venetian blinds, with an irregular junctional zone. So our correct answer is adenomyosis. Question number 9. So we have got these images there, the images there, the images there. Which ultrasound technique best evaluates cavity abnormalities? Which ultrasound technique best evaluates cavity abnormalities? A, B mode only. B, color Doppler. C, 3D ultrasound. D, M mode. Which ultrasound technique best evaluates cavity abnormalities? A, B mode only. B, color Doppler. C, 3D ultrasound. And then D, M mode. So let's disclose the answer. So the correct answer is C. 3D ultrasound accurately demonstrate the polyps, the septa, the fibroids, and any congenital anomalies. 3D ultrasound accurately demonstrate polyps, the septa, fibroids, or any congenital anomalies. So now, the final challenge. Which feature indicates an ideal receptive endometrium? Which feature indicates an ideal receptive endometrium? A, 3 mm homogeneous. B, 8 to 12 mm trilaminar with good vascularity. C, thick heterogeneous cavity. D, fluid-filled cavity. Which feature indicate an ideal receptive endometrium? A, 3 mm homogeneous. B, 8 to 12 mm trilaminar with good vascularity. C, thick heterogeneous cavity. D, fluid-filled cavity. So let's disclose the answer. So the correct answer is B. Ideal implantation features include a thickness of 8 to 12 mm, Trilaminar appearance, good subendometrial blood flow with smooth cavity and no focal lesions. So in summary, ladies and gentlemen, the key takeaways: know the normal cyclical appearance, assess thickness and echogenicity, look for vascularity, exclude the polyps, fibroids, hyperplasia, adenomyosis, and endometritis. Combine ultrasound findings with the patient's menstrual history. So now, the call to action. How many questions do you answer correctly? Be honest to yourself. Comment on your score below in the comment section. Like the video, subscribe to Medical Ultrasound Academy, subscribe to Medical Ultrasound Academy so that you don't lose any of these very vital and important learning keys and points. Share with colleagues preparing for ultrasound and fertility examinations. Thank you so much. I wish you well. Enjoy the rest of your day. Let's meet again in our next presentation. Bye.
Endometriosis is a growing concern in the contemporary world. Most young ladies and mid-level ladies, they get affected by endometriosis, and it gives them a lot of pain, inconveniencing them from their daily activities, work, and another household chores. So in this presentation, I am going to talk about endometriosis mapping. It is fundamental, it is very critical for any radiologist, any sonographer to understand how to map for endometriosis so that you don't miss it. So I need you to watch and listen to this video till the very end, because they are very critical key areas or key concepts that I am going to discuss about that most of you are not aware of. So do not miss any portion of this presentation. Otherwise, you are not going to be competent or to master endometriosis mapping for the rest of your life. So this is just a comprehensive guide to documenting deep infiltrating lesions in endometriosis. So this is my introduction. The objectives of this presentation are, by the end of this presentation, participants should be able to understand the purpose of endometriosis mapping. This is very critical. You must be able to perform a systematic ultrasound examination, apply the IDEA, which is the International Deep Endometriosis Analysis Approach. Did you know about this? Just to be honest, guys, are you aware of what that IDEA is? The International Deep Endometriosis Analysis Approach. How is it done? So you must also recognize sonographic features of deep infiltrating endometriosis, which is the dye. Dye. Have you ever heard about dye? Or you've been scanning for so many years. Have you ever heard about dye? So in this presentation, you are going to understand what dye is, which is deep infiltrating endometriosis. So you must be in a position also after to produce a structured ultrasound report when you are reporting a case of endometriosis. So by definition, what is endometriosis? Endometriosis is the presence of endometrial-like glands and stroma outside the uterine cavity. It is a chronic inflammatory condition that can cause pelvic pain, dysmenorrhea, dyspareunia, infertility, bowel and urinary symptoms. Approximately 1 in 10 women of reproductive age are affected by endometriosis. So you see how so widespread it is. So now let's discuss what is endometrial mapping. So most of you have been wondering, what is this mapping all about? So you can see here, that's the region of the pelvis, and you can see the different compartments that I've put up. So when I'm mapping, you're sort of localizing the endometriosis. Where is it? So endometriosis mapping is a systematic ultrasound examination used to identify, localize, and document endometriotic lesions before surgery. So it's a systematic way that we use now to identify, to localize, and then to document the endometric lesions or tissue that we see or that is found. So what are the objectives of endometrial mapping? So in this presentation, we are supposed to determine the disease extent, to identify bowel involvement. Is bowel involved or not? Detect bladder involvement, assess ovarian disease, evaluate adhesions, and assist surgical planning. So the compartments that are supposed to be evaluated when doing an endometriosis mapping are the anterior compartment, which is the bladder, and the vesical uterine pouch. Then you also have to assess the middle compartment, that is the uterus, the ovaries, and the fallopian tubes, if they are also involved with their endometriotic lesions, which are also there. So in the posterior compartment, you have what is called the uterosacral ligaments. You must check on those. Then you have to have the posterior vaginal fornix. You have to check for deep infiltrating lesions. Then the rectal vaginal septum, you also have to check on that. Then the rectum itself, you have to look around it. And then the rectal sigmoid colon, then the sigmoid colon. You have to assess for any deep infiltrating endometriotic tissue that you can find there. So now let's talk about the patient preparation in endometriosis mapping. So the preparation, explain the examination to the patient. That's the fundamental and the first thing that they're supposed to do. Don't do things nicodemously when the patients are not aware what is being done to them. So obtain informed consent from the patient, encourage bladder emptying, then position patient in the lithotomy position. That's the transvaginal that we're talking about, the transvaginal approach. So use a high frequency transvaginal probe, 5 to 9 megahertz or higher. Then perform a gentle examination due to tenderness. So you know these patients, some of them they will be feeling tenderness due to the endometriosis. So you must also use a gentle examination. So the clinical history of the patient. Ask about the dysmenorrhea, dyspareunia, chronic pelvic pain, dyschezia, dysuria, infertility, or previous surgery. So you have to ask that kind of history or capture that history before and during the examination. So the idea examination protocol. So here is the protocol. So there are basically 4-step idea protocols, that steps that you are supposed to do when you are doing the idea protocol. So the first step for this protocol is you have to check the uterus and the ovaries. Uterus and the ovaries. Then the second step, soft markers, site-specific tenderness, ovarian mobility. You see that? The second step of the protocol, idea examination protocol, is you have to check for markers. Are there any obvious markers of endometriosis? Site-specific tenderness, go there where the patient is saying that this is where the pain is. Then ovarian mobility, check if the ovaries are moving. So the step 3 is a sliding sign. So the ovary has to be moved to move. The uterus, sorry, it has to move. That is what we call the sliding sign. I will demonstrate that practically. I will check a case for you, then I will demonstrate for that. I'll present on a practical case like that. Then you can see the sliding sign, how it is done, and where it is positive and negative. Step 4, deep infiltrating lesions. Stress using the same sequence in every patient for consistent. So you must check for deep infiltrating lesions. So you have to stress using the same sequence in every patient for consistency. So you must be consistent, must be methodical in the way you do things so that don't forget other areas or to assess other areas. So the uterus and adenomyosis. So You must assess for the size of the uterus, the position of the uterus, the myometrium, the endometrium. So when you're checking for adenomyosis, check the size of the uterus. Is it enlarged, the normal size, the position, what the position of the uterus, then the myometrium, the heterogeneity, and other lesions that you can find there. Then also check the endometrium. How is it distorted? Is it normal position? Is it enlarged? So you have to look into all those aspects. So the sonographic signs of adenomyosis, so is the heterogeneous myometrium, is asymmetrical wall thickening. You can have myometrial cyst, then you got fan-shaped shadowing, then you can have echogenic islands, then indistinct junctional zone, then the translesional vascularity. So you can have translesional vascularity. So these are the fundamental sonographic signs of adenomyosis. I have been showing you some signs of adenomyosis when we're doing our daily quiz sessions. I will also show you the images of how adenomyosis appears, like different types, different appearances. Then you appreciate that. I will share that one with you in the other slide. So I am saying the sonographic sign of adenomyosis. Did you know about this? Heterogeneous myometrium, asymmetrical wall thickening, myometrial cyst, fan-shaped shadowing, echogenic islands, then indistinct junctional zone or the translesional vascularity that should be present. Okay, so now we have to assess the ovaries, ovarian assessment. So this is still part of endometriosis mapping. So you have to evaluate the size of the ovaries, the mobility of the ovaries, the follicles, and the cysts. Evaluate the size of the ovaries, the mobility, the follicles, and the cyst. So the endometrioma features, so this is an endometrioma there. So it's a homogeneous low-level echoes, which is called the ground glass appearance that we're always supposed to see. Then with the thick holes, so the holes are thickened, like you can see there. With minimum internal vascularity, so there's no or internal minimum vascularity in the endometrioma itself. So bilateral in up to half of cases. So in most cases or some cases, it can present both ovaries. So you have to check both ovaries for sonographic sign of endometriosis. There it is, right and the left side. So differentiate from hemorrhagic cyst, dermoid cyst, and the neoplasm. So you must pay due diligence so that you don't confuse them from a hemorrhagic cyst, a dermoid cyst, or a neoplasm. So be very careful when you're doing an assessment of the ovaries to check for endometriosis so that you don't confuse an endometrioma for a hemorrhagic cyst, a dermoid, or a neoplasm, which is the cancer of the ovary itself. So ovarian motility tests, ovarian motility sign, the kissing ovaries. What is called when you're saying that the kissing ovaries, saying that the ovaries they just get in contact with each other, so they're bigger. You say that they come in contact with each other. So the technique: apply gentle probe pressure, observe whether ovary moves freely, ovary is fixed, ovary adheres the uterus, ovary adheres the bowel. Fixed ovary suggests adhesions. Kissing ovaries strongly suggests severe endometriosis. So if you have got ovaries that are now enlarged, then they are non-mobile, then you should also think of endometriosis. So you must observe again the ovary. If it moves freely, ovary is it fixed? Ovary adheres to the uterus, or ovary adheres to the bowels. So fixed ovaries suggest adhesions. Kissing ovaries are strongly suggestive of severe endometriosis. Now let's talk about what's called the sliding sign. Do you know about the sliding sign, guys? Have you ever heard about the sliding sign? Do you also check on it when you are assessing for endometriosis? So the positive sliding sign structures, they move freely. So the pelvic structures, the uterus, the ovaries, they have to move freely within the peritoneal space. So suggest no significant pouch of Douglas obliteration, no significant pouch of Douglas obliteration. So the negative slide sign, structure fails to slide. So suggests adhesions, obliterated pouch of Douglas, deep infiltrating endometriosis. So we are saying that when the adhesions, when the uterus, for instance, is attached by adhesions to the surrounding pelvic organs, it can't move because it's fixed, stuck. It's like a glue that is holding it in space, so it can't move. So a negative sliding sign is one of the signs that we use to say that there's endometriosis, or there's absent endometriosis. So you see, you have to make it a point that you're trying to use the sliding sign as much as possible to exclude endometriosis and also deep infiltrating endometriosis. So you also assess also the anterior compartment. So you have to evaluate the bladder wall, the vesico uterine pouch, and the distal ureters when visible. So you have to check there are nodules there. They have to check. You see, this is the wall of the bladder there. You can see there's a nodule there. So this is endometriosis. So this is deep infiltrating endometriosis. So you can see a nodule there on the base there. That's a nodule there, and the bladder is there. The sonography findings: hypoechoic nodules, irregular wall thickening, then reduced mobility, and then the focal tenderness. So these are the signs of deep infiltrating endometriosis. So you can see these hypoechoic nodules, they deposit there around the bladder, around the vesical uterine pouch, and around the distal ureters. So be very vigilant when you assess for deep infiltrating endometriosis. So now you also have to assess the posterior compartment. The posterior compartments. What do you assess? You see these hypoechoic nodules that we have. These ones, they can be very silent. That you see those ones. It is very easy for you to miss endometriosis, deep infiltrating endometriosis, if you are not so diligent. You see how they appear. Like you see that one around the sigmoid colon there. You can see this area that is hypoechoic there, like a rim. It looks like a mass, like it is. There is a rectal sigmoid cancer there, but it's endometriosis. So assess uterosacral ligaments, the posterior vaginal fornix, the rectal vaginal septum, and the rectum, the sigmoid, and the sigmoid colon. So for those hypoechoic nodules, so the typical features of deep infiltrated endometriosis are solid hypoechoic nodules. They with irregular margins. Then they can retraction, and then fibrosis, tenderness, and the distortion of the anatomy. So you can see that the anatomy will be distorted, and you are seeing these features. Then you should know that you are dealing with a case of endometriosis. So the features again: solid hypoechoic nodules. So you see, these are the solid hypoechoic nodules that I'm talking about. These are the solid hypoechoic nodules that you are seeing there. They've got irregular margins, so they're infiltrating, and retraction, fibrosis, tendon distortion of anatomy. So bowel endometriosis. So you can also see that endometriosis can infiltrate and affect the bowels. So you can see this deposits in the bowels there. They deposit in the bowels. So you can see on CT, there on MRI. Sorry, you can see endometriosis there. So the common site is the rectal sigmoid colon. That's where mostly you find deep infiltrating endometriosis. They need to appear like that. So the sonographic features: hypoechoic muscularis lesion, hypoechoic muscularis lesion, irregular thickening with a narrowing of bowel lumen, and then reduced sliding. And then we can have fixed bowel loops. So the loops can also be fixed by the adhesions. So this is how you make an assessment of bowel endometriosis. So the measurements: you should record distance from the anal veg if assessed, then the lesion size, circumferential involvement, depth of invasion. So because you are dealing with the bowel, so you must also assess the circumferential involvement. Is it occupying 1/3 of the bowel? Is it affecting 1/4 or the whole bowel? Is it encasing the whole bowel or not? So you have to report on those when you are doing endometriosis mapping. And the depth of invasion, how deep is it? You understand? So initially I said you must also measure the distance from the anal veg. So from the anal veg there, you can then make a measurement to the exact spot where you see an endometric nodule. How far is it? So this is mapping, because we are localizing it. So this is the structured reporting. How do you report on endometriosis? So there's suggested report format for you guys. I've just put this one suggest for you. Then you can also alter. This is just a template.
So the clinician indication: pelvic pain, dysmenorrhea, infertility, then the uterus, the position, the size, adenomyosis, if it's there, they comment on it, the ovaries, the mobility, endometriosis, they are there, the adhesions, then you're checking on those. So the sliding sign, is it positive, is it negative? This is part of your report. Anterior compartment, talk about the bladder, the vesicular pouch, are they clear from these nodules or not? Then the posterior compartment, guys, you have to talk about check also the uterosacral ligaments and report on that, the rectovaginal septum, the rectum, the rectal sigmoid, and the sigmoid. So just make sure on the report that you're including those to make sure that it's mapped. This is a special type of a report. It's not the normal pelvic ultrasound report that you're talking about. We are now talking about endometriosis mapping. So the report of an endometrial map must show this, and the region that you didn't see, you have to indicate that I couldn't see the rectal sigmoid. I couldn't see the rectum. I couldn't see the sigmoid on ultrasound. You understand? You have to, so that the clinician will know which area has been mapped. If there's need for a CT MRI, you understand? Then they can go for the MRI. So now, the conclusion: no evidence of dye, no evidence of deep inferior endometrium. If there is none, if it is there, then you have to report likewise. Mild disease, moderate disease, extensive disease with the bladder or bladder, bowel or bladder involvement. So you have to also then conclude, like, if it is is extensive, is affecting the bladder and the bowels. So you have to take note of that in the endometriosis mapping report, ultrasound report. There's a special type of a report. That's why I make this presentation. So now, the your key takeaways. So it has been a long presentation. So let me give you the key takeaways, and then you can call it home. You can call it a day. So remember these 5 key points. 1. Follow a systematic examination protocol every time. 2. Always evaluate ovarian mobility and the sliding sign. 3. Examine the anterior, middle, and posterior compartments. 4. Measure and document every lesion accurately. Then 5. Use a structured report to improve communication and surgical planning. Use a structured report to improve communication and surgical planning. So let me repeat the takeaways again. The takeaway points: follow a systematic examination protocol every time. Always evaluate ovarian mobility and the sliding sign. Don't forget to examine the anterior, the middle, and the posterior compartment. If you don't, you have to tell the referring clinician that I couldn't do this. Then maybe there's a reason for that. Measure, document every lesion accurately and localize it. Use a structured report to improve communication and surgical planning. So don't just make a report haphazard. So with the structure of a format, you can have a template for endometriosis mapping. So those guys who are having maybe using their typing their reports, I urge you that you can make a template for endometriosis mapping, so that every time we're doing an endometriosis mapping, you just edit your report so that it conforms to a certain standard in their format. So this brings us to the end of this exciting presentation. Ladies and gentlemen, I thank you so much for your time, for your resilience, your patience. I encourage you to like and share our videos if you so do like them. Then I also need you to give us an honest feedback if there are areas of improvement or what else we could do differently for you to understand or to master what we are trying to put across. So there are practical sessions. If you are going to follow our practical cases, I'm going to be including the videos, upload some videos, so that you can also see how we do the practicals. Thank you so much. Enjoy the rest of your day ahead. Thank you. So today I've got a talk that might disappoint most scholars. What they've been told by their lecturers, what they think works in real time versus what is on the ground, the truth. So we as practitioners, we have not just read things from books. So we have gone beyond that and then put everything into practical context. And we've texted everything in practical times. So now, the conclusion
after everything has been done, here is where I stand. So now let's talk like this. Beyond the genital tubercle method, debunking early fetal gender myth and rumors. That's what we are going to debunk now. Those myths and the rumors. Can you really tell a baby's gender early? Can you? I'm asking you practitioners where you are. Are you managing? Is it really possible? Are we really telling our patients the truth? So, the myth-busting challenge. Think you can tell your baby's gender just by looking at a 12-week ultrasound scan? Most parents believe the gender tubercle is a foolproof giveaway, but science says you are probably being misled by common myths. Today, we are debunking the biggest pregnancy rumors and revealing why early predictions are often just guesswork. So, the curiosity gap. Let's talk about the curiosity gap. What if everything you have heard about early gender reveals is scientifically inaccurate? From the angle of the nub to old wives' toes, millions are falling for misinformation before the second trimester even begins. We are going beyond the surface to show you what's actually happening during fetal development in 2026. So the expert warning, we as experts, what is our warning? Stop relying on blurry ultrasound photos to plan your gender review party. There is a massive difference between internet rumors and clinical reality when it comes to the gender tubercle. We are breaking down the biological facts to save you from the confusion of early gender myths and unreliable viral trends. So I've seen lecturers at universities taking these myths as academic truths that are taught students. But we as practitioners, we have seen it otherwise. And we've learned the hard way times when we have used these things. And our patients, they come back to say that you're lying to us. After they've thrown parties, gender reveal parties that are very expensive. So now, beyond the gender tubercle model, let's talk. Debunking early fetal gender myths and rumors. So the narration. Can an ultrasound accurately predict your baby's gender at just 11 or 12 weeks? Or are many of the claims circulating online simply myths? Today, we will separate scientific evidence from popular rumors. So why parents want to know the gender early? Parents are often curious because they want to prepare emotionally, plan baby names, organize gender reveal events, purchase baby items, and then satisfy natural curiosity that they have. So what is the narration? The excitement of pregnancy often creates a desire to know the baby's sex as early as possible. Unfortunately, this has also led to many myths and misleading claims. The excitement of pregnancy often creates a desire to know the baby's sex as early as possible. Unfortunately, let me repeat myself. Unfortunately, this has also led to many myths and misleading claims. So, the genital tubercle never changes. The genital tubercle never changes. That's myth one. The genital tubercle never changes. So the myth, the knob already points exactly like a penis or a clitoris. The truth, the genital tubercle exists in both male and female fetuses. At 11 weeks, they appear remarkably similar. The angle gradually changes during development. Key point, the genital tubercle is not a miniature penis in every fetus. Get this right. Get this right. So, Let's explain the embryology. So from week 6 to week 8, the male and the female external genitalia are identical. Week 6 to week 8, the male and the female external genitalia, they are very identical. So from week 9 to 13, hormonal influence begin differentiation. So now at week 14, anatomical difference begin increasingly obvious. So the narration, the same embryological structure develops differently depending on genetic, sex, and hormone exposure. So the famous nub theory. The nub theory says that angle greater than 30 degrees suggests a male, angle parallel to the spine suggests a female. It is not 100% correct, ladies and gentlemen. It is not 100% correct. Accuracy depends on gestational age, fetal position, sonographer experience, and the image quality. I think that's speculating well. So now, the common internet rumors, what are they? The skull shape theory, the placenta location, which is called the Ramsey theory, the heart rate prediction, the mother's cravings, the belly shape, scientific evidence, none reliably predict fetal sex. So this is the scientific evidence. So why mistakes happen? The common reasons: legs are crossed in the fetus, the umbilical cord mistaken for genitalia, poor fetal position, maternal obesity, early gestational age, motion artifact. So the narration: many incorrect predictions are caused by technical limitations rather than poor scanning. Do you get that? So the technical limitations, they cause a lot of these inaccurate predictions. So when is ultrasound most accurate? Here we have it. So from 11 weeks, we got a low to moderate accuracy. Hear that, hear that. 12 weeks, we've got moderate accuracy. 13 weeks, we've got high accuracy. Then from 18 to 22 weeks, that's where we have got a very high accuracy. So be it you are a parent or be it you are a practitioner, use the correct thing that gives less errors. So schedule your gender review scan, a gender review scan at 18 to 20 weeks, even beyond. So the best practice, routine anatomy scans provide the highest confidence for ultrasound-based fetal sex determination. Routine anatomy scans provide the highest confidence for ultrasound-based fetal sex determination. So some they do it from 18 to 23, some they do it from 20 to 2. That's the ideal time that you should tell your patient about the gender, and you should spread that gospel to your patients that that's the most ideal time, not the myths which they are told and they know. Otherwise, they'll come to you to say that you lied to us. So I hope it's all making sense. So what about DNA testing? What about DNA? Are there no other ways? Are there no alternative pathways? Should we say that because the gender should be method is failing, so it's a done deal? No. Cell-free DNA, NIPT, can determine fetal gender very early. So its advantages are extremely high accuracy, blood test, no dependence on fetal position. So the reminder, the primary purpose of NIPT is screening for chromosomal conditions, not simply sex determination. Did you just hear that? The primary purpose of NIPT test is screening for chromosomal condition, not simply fetal sex determination. So now, what are the ethical considerations when everything has been said and done? The medical professional should avoid overconfidence, explain uncertainties, counsel parents appropriately, prioritize fetal health over gender curiosity. Those are the things that you must cultivate as a practitioner. You should not be overzealous and do things above board or use rumor mongering to give misleading information to your patients. As medical practitioners or professionals, avoid overconfidence. Explain the uncertainties. Counsel parents appropriately. Prioritize fetal health over gender curiosity. So now, here are your key takeaway home. Your key takeaways. The first one, the gender choke buckle exists in every fetus. Did you get that? Early predictions are estimates. Every predictions in the early stages are estimates, not guarantees. Most internet gender myths lack scientific support. Accuracy improves significantly after 13 to 14 weeks. The mid-trimester anatomy scan remains the most reliable ultrasound assessment. I think I am making a point home here. I'm taking the point home. So now the call to action. I have done my part. I have told you the scientific way or the scientific standpoint. It's now up to you to take the myths, the rumors as part of practice. It's not correct whatever you are told at school. There are certain things that can make you pass at school, at the university, get your degree, but that might not be true in practice. So practice, experience is the best teacher. So, did you learn something new in this presentation? Let's be honest. Did you learn something new in this presentation? If you did, please like this video and comment. When did you first find out your baby's gender? If you are a parent, when did you first find out a fetal gender if you are a parent? Ladies and gentlemen, please subscribe to Medical Ultrasound Academy for real ultrasound cases, RDMS quizzes, report writing, obstetric, ultrasound education, weekly live teaching sessions, and also we do scrutinize the practice of ultrasound. We put into perspective the real ultrasound practice versus theoretical ultrasound. There is theory. My colleagues, some of them, they are in the academia. They have so many years without even touching a patient or holding a probe at the hospital. So they don't really know what exists in reality versus what happens in the academia side. So we are speaking from experience. We must not rely on myths and rumors. Rumor mongering is not good medical practice. Thank you so much. Enjoy the rest of your day. Don't forget to subscribe, share this educational content with your colleagues. Let's meet again in the next presentation. Bye. Welcome back, colleagues. So in this presentation, I am going to discuss about one of the most critical aspects of gynecological ultrasound. So we are going to talk about advanced reporting strategies for describing complex adnexal masses using what is called the aorta symbol rules. So this is advanced ultrasound, guys. You have to master it. Please listen carefully so that you don't miss any critical aspect of reporting these complex masses when you see them on gynecological examinations. So now, I am giving the slide numbers so that if you've got a question, you can just maybe ask me, go to slide number 1, number 2, number 3, then you ask something there. It will be easier for you to follow up. So I'm dividing the sections as slides. So advanced reporting strategy for describing complex adnexal masses using the aorta symbol rules. So
improving diagnostic confidence, standardized ultrasound reporting. This is our mission. This is our goal. We have to improve the standardized way of reporting our findings. So I am the presenter. So it's coming from Medical Ultrasound Academy. So the slide 2 now. Complex adnexal masses remain one of the greatest diagnostic challenges in gynecological ultrasound the world over. So the major question is this lesion benign or malignant? So this is the major challenge when you're doing gynecological studies now, to say, is the lesion that I'm seeing, is it cancerous or is non-cancerous? So accurate reporting influences patient counseling, surgical planning, referral to gynecology oncology, follow-up recommendations, and patient survival. So the International Ovarian Tumor Analysis, which is called the aorta group, developed standardized ultrasound rules to improve diagnostic accuracy. So this is what now we are going to talk about in this presentation. So it's called the International Ovarian Tumor Analysis aorta group. So now, our objectives in this presentation. By the end of this lecture, you should be able to understand the aorta symbol rules, identify benign ultrasound features, recognize malignant ultrasound features, apply the rules in different and difficult masses. So write professional standardized reports and know when further assessment is required. So now, what is an adnexal mass? What is an adnexal mass? What is an adnexal mass? An adnexal mass is any lesion arising from the ovary, the fallopian tube, the broader ligaments, the para-ovarian tissues. They include benign masses, which can be functional cysts, the dermoid cyst, endometriomas, hydrosalpinx, fibromas, or they can be malignant or cancerous, which involves the epithelium, ovarian cancer, metastasis, germ cell tumors, or they can be borderline tumors. So you can see here we do have got a sample of the adnexal masses. So this is a cyst. This is a simple cyst. You can see this one. You can see their internal echoes which are inside there. So this is got solid papillary excrescences. So I'm going to classify and differentiate these different ovarian masses using the aorta classification. So why standardizing reports matters? If you ever ask yourself, why do standardizing report matters? So without standardizing terminology, different radiologists describe the same lesion differently. For example, radiologist A, large cyst with echoes. Radiologist B, multilocular cystic lesion with irregular papillary projections showing moderate vascularity. So the second report immediately provides valuable clinical information. So this one, we can't tell for the radiologist A that if it's cancerous or it's benign. But now if we are using the reporting according to radiologist B, multilocular cystic lesion with irregular papillary projection showing moderate vascularity. So now, this gives us more detail. So now, what is the aorta? What is aorta? What is it? What is this classification that we're talking about? What is this aorta classification? So the International Ovarian Tumor Analysis aorta, an international collaboration that developed evidence-based ultrasound models for ovarian tumors. So this is what the aorta now stands for, the International Ovarian Tumor Analysis. So they developed an international collaboration that developed evidence-based ultrasound models for ovarian tumors to classify them. So the main goals of the aorta classification, to develop simple rules, adnexal model, simple rules risky, logistic. There's the simple rules which they develop. They use certain tools. So these are the tools that we are going to break down here, which say the simple rules, the adnexal model, the simple rules risky, logistic regression models, or as integration, then diagnostic accuracy. So approximately sensitivity 92 to 96%, specificity 74 to 92%. So the tools which they developed according to this model, they are approximately 92 to 96
percent sensitive. So you can see that if you're going to follow the aorta regulations to classify or to report your ovarian tumors or masses, you've got this about 92 to 96% sensitivity of differentiating benign from malignant tumors, and they are approximately 74 to 92% specific for that. So now, the principles before applying aorta: always document patient age, menopausal status, the symptoms, CA 125 if available, pregnancy, previous malignancy, or previous surgery. So those are very critical piece of information that you have to document before you apply the aorta classification. Always document the patient age, menopausal status, the symptoms, CA 125 available. So that's just a clinical marker for cancer, pregnancy, previous malignancy, or the previous surgery. So now, ultrasound examination protocols. So you can see, look at this lesion there, look at this lesion there, look at this lesion. So those are the lesions that we need to classify. If you see a lesion like that, you should be in a position to tell that, is it cancerous, is it not? So you are going to use the aorta classification. It gives a picture to everyone internationally to say that the report what you are referring to. Otherwise, you are going to talk with a language that doesn't not resonate with anyone else, and you might even confuse the referring clinician and your colleagues. So you perform a transvaginal ultrasound, that's the basic, and a transabdominal ultrasound. So you have to do both, because some lesions are too big. So if you don't just do the transabdominal, just only do transvaginal, you can miss those bigger lesions. So you have to evaluate the size, the location, the wall, the septations, the solid tissue, the papillary projections, the shadowing if there's any, the color, Doppler, ascites, and metastasis. So those are some of the things that now you need to be looking into when you see an ovarian mass. Is the size, how big it is, then you give the dimensions, the location, the walls, are they thick or normal walls, the septations, solid tissue components inside, papillary projections if there are any, the shadowing if there's any, color Doppler, ascites, and metastasis if there's any. So now, the 5 benign features, the B rules, they are called the B rules. So now we are dealing with the aorta classification. We've got the 5 benign features, or the B rules. Feature B1, so it's a unilocular cyst. So if it's a unilocular cyst, it's B1. B2, solid component which is less than 7 millimeters, so it's B2. B3, acoustic shadows. So if there's acoustic shadowing, so it's classified as B3. If B4, smooth mouth look like tumor, so if it's a smooth tumor with multiple loculations but less than 10 centimeters, then it falls under B4. Then B5, there's no Doppler flow, no Doppler flow. So when you are classifying the tumors according to aorta, you can classify them B1, B2, B3, B4, B5. So the B's are for the B rules for benign tumors, non-cancerous. So now, here is B1, example of the tumors that you can have. This is a unilocular cyst there. You can see here, you can see there's a simple cyst there. So the characteristic of B1, the walls are thin. You can see that the walls are thin there. There are no septations, no nodules, no papillary projections, anechoic fluid, suggest the functional cyst or serous cystadenoma. So the B1 unilocular cyst, they can suggest functional cyst or serous cyst. So you can see that is an example of a what? Of a unilocular B1 cyst. So now the B2 small solid components, you can see here we have got these small solid components that are inside there. Those components there, the solid components that we have there. So solid tissue present, largest solid parts less than 7 millimeters, often seen in benign cystadenoma or small dermoids. So those are the features now that you must look into if they are solid features or components which are less than 7 millimeters. So that can be a benign cystadenoma or a small dermoid. So now, B3, acoustic shadows. So you can see here there are acoustic shadows there, acoustic shadowing that we have there, acoustic shadowing there. So shadows suggest a dermoid, a fibroma, a fibrothecoma, or dense fibrous tissue, usually these ones are benign. So if there are caustic shadows like that, so it suggests a dermoid. So these are B3. B3, it can be dermoid, a fibroma, fibrothecoma, dense fibrous tissue, or usually benign. So when you're writing the report now, these are some of the differentials that you are going to put, and you classify your lesion as a B3 lesion, then you can put all those differentials. So now, the B4, which are smooth multilocular lesions, so you can see here is multiloculated, multilocular there. So the characteristics, they've got a smooth septa, and there are no papillary projections inside. They are less than 10 centimeters, and usually benign cystadenoma. So they can be benign cystadenomas. So this is a B4 classification, which is multilocular lesion, as you can see there. And characteristics, a smooth septa, no papillary projections, less than 10 centimeters, usually a benign cystadenoma. So now the B5, no blood flow. So you can see this is about B5. This is B5. So if you put color, color score 1, no vascularity, they are usually benign. So if you put color Doppler there and there's no color flow, then you classify them as what? B5. So now, 5 malignant features, the M rules. So you see that the lesions which are the B rules are the benign ones. Then the M rules, these are the malignant ones, the cancerous ones. So M1, irregular solid tumor. So it's irregular solid tumor is M1. So if the M2, when there's associated ascites, that's M2 now. M3, 4 or more papillary projections inside the ovarian mass. So M4, irregular multilocular solid mass, which is above 10 centimeters. So if it is above 10 centimeters, irregular multilocular solid tumor. Then M5, very strong Doppler flow from within. So those are the classifications: M1, M2, M3, M4, M5. Just like the B rules from B1 to B5. So M1, these are examples of a M1 irregular solid tumor. So you can see here that is a tumor there that we have there. These are another tumor that we have. These are the tumor that we have there. So these are highly suspicious with irregular margins. You can see these margins are irregular there. There are irregular margins there. Then heterogeneous echo texture. So the echo texture will be heterogeneous, as you can see there, heterogeneous echo texture there. Then with internal vascularity. So there's internal vascularity like that, then you should say or classify them as M1 solid tumors, ovarian tumors. So M2 now. So you've got a lesion that we have there with associated ascites. So you can see this ascites here, there's ascites there. So we will see free fluid beyond the pouch of Douglas. So raise concern for advanced malignancy. So if you are going to see a fluid there, that is a sign of advanced malignancy. So that is a M2 classification of the lesion. So now M3, with the multiple papillary projections. So you can see here there are multiple papillary projections inside there. These are papillary projections inside. Papillary projections which are above or equal to 4 millimeters. Irregular, vascular, highly malignant risk. So there's a very high risk of malignancy when you see a lesion with those papillary projections. So it's now our M3 classification. So now, the M4, which is a large, irregular, multilocular solid tumor. So M4, large, irregular, multilocular solid tumor. So you can see here the mass that we have there with all those multiple loculations there, like that, like that, like that. So the size greater than 10 centimeters. So irregular walls with the solid components and then strong suspicion. So those are strongly suggestive of malignant. So these are now called the M4 ovarian lesions. So now, M5, which is the strong Doppler flow. So you can see there's a strong Doppler flow, which is neovascularization there. You can see here the strong Doppler flow within the mass itself, within the ovarian mass, as you can see here, which is color score 4. So marked neovascularity with a low resistance vessel. So if you put a Doppler, you're going to see that there's going to be low resistance. So there's a lot of blood that is flowing there. So the vessels, they dilate to allow more blood to feed the tumor there. So this is now our M5 criteria or category of these ovarian tumors according to the aorta classification. So now, Doppler score color score. So how do we classify the Doppler color score within a tumor? Class 1, there's no flow. Class 2 is minimum flow. Then class 3, there's moderate flow. Then class 4, there's very strong flow. So that's how you also classify Doppler flow within a lesion according to the aorta classification. Class 1, no flow. Class 2, minimum flow. Class 3, moderate flow. Class 4, very strong flow. Guys, you see the difference now from the tradition where you just say, I'm seeing an ovarian mass, I'm seeing an ovarian mass, you understand, that kind of jargon. So now we are doing advanced ultrasound where we are now using this international standard way of reporting and doing our gynecological ultrasound scans. So now, the aorta decision algorithm. So you have to understand this algorithm and follow it when you're doing an ultrasound scan. Only B features when they are only benign features, benign. Only M features when they are only malignant features, malignant. Both B and M. So some features, they are borderline. You can see that they've got features of benignity and malignant at the same time. So that would be inconclusive. Neither. So expert evaluation. So now they will need an expert evaluation, or you have to refer for other imaging modalities like MRI and then also maybe for biopsy. So now, we must have a reporting checklist to see that we've standardized everything, we've done everything. So those will always include the location, the dimensions, the morphology, the wall, the septations, papillary projections, the solid tissue, shadowing, then Doppler, aside if there is any, then peritoneal disease, then lymph nodes, then the final aorta assessment. So this is the checklist for your reporting. Always include the location, the dimensions, the morphology, the wall, the septations, the papillary projections, the solid tissue, shadowing if there's any, Doppler flow, ascites, peritoneal disease, lymph nodes, then final aorta assessment. So now this is an example benign report. So this is how you write your benign reports like this. Right ovary contains a 5.2 centimeter unilocular anechoic cyst with smooth walls. No septations, no papillary projections, no vascularity, no ascites. So aorta features B1, then B5. The impression, benign ovarian cyst. So that's how you write a classical or a typical aorta report. Right ovary contains a 5.2 centimeter unilocular anechoic cyst with smooth walls, no septations, no papillary projections, no vascularity, no ascites. So aorta features B1 to B5. Impression, benign ovarian. So you just write whatever classification, if it's B1, B2, B3, B4, B5, then you put it under there. So example of a malignant report. Now this you can see the feature, this the images that we have here for a malignant lesion or mass. Large multilocular solid left adnexal mass, irregular septations, 5 papillary projections, marked Doppler flow, and moderate ascites. So that's how you write a simple report for a malignant ovarian lesion. Large multilocular solid left adnexal mass, irregular septations, 5 papillary projections, marked Doppler flow, moderate ascites. So aorta, then you classify depending on what you see. Is it M1, M3, M4, M5? Then you give the impression highly suspicious for an ovarian malignancy, urgent gynecological oncology referral. So you see how we now write a malignant suspicious ovarian lesion using the aorta classification. Large multilocular solid left adnexal mass, irregular septations, 5 papillary projections, marked Doppler flow, moderate ascites. Then you classify according to aorta. Is it M1, M2, M3, M4, M5? Just like that. The impression, highly suspicious for ovarian malignancy, urgent gynecological oncology referral is needed. So now, there are some cases which are very inconclusive. Inconclusive cases. Both benign and malignant features are present. Examples, dermoid with a vascular mural nodule. And then you can have borderline tumors like hemorrhagic cysts with irregular clot. Then recommended expert scan, MRI, adnexal model, then the serial follow-up. So this is what you do to some lesions which are inconclusive. You can't say are they benign, are they malignant in ultrasound. So this includes dermoid with vascular mural nodule, borderline tumors, hemorrhagic cyst with irregular clot, recommended expert scan, MRI, Adnix model, and serial follow-up. So now, these are the common reporting mistakes such most people do make. These are the common mistakes that you also have to avoid. 1. Calling every complex cystic mass malignant. 2. Ignoring Doppler. 3. Forgetting papillary projections. Measuring incorrectly, not documenting vascularity, omitting ascites, or using vague wording. So, guys, these are some of the most common errors or mistakes that you do when you are reporting on ovarian tumors or lesions. Calling every complex cyst malignant, some they will not be. Ignoring Doppler, forgetting papillary projections, measuring incorrectly, not documenting vascularity, omitting ascites, or using vague wording. So now, here's a template of a structured report template. So here, patient name, the age, the symptoms, so clinical history, the technique that you're using, transvaginal plus transabdominal. Then you describe the mass, the location, the size, the morphology, the walls of the mass. Then the septa, if there is any, the solid tissue components, papillary projections, color, Doppler, associated findings, the conclusion. Then you put the aorta category, then management recommendation if there are any that you can pick. So the clinical management, result management. So benign, routine follow-up is recommended. When they have been malignant now, gynecological oncology referral is recommended. Indeterminate, then MRI or Adnix or expert ultrasound is then recommended. So this is how we classify or manage different lesions after we have classified according to the aorta classification. So there are times that which you can determine what is it. Is it benign or malignant, or using the aorta classification, then we can send the patient for an MRI or Adnix or expert ultrasound. So now, the key take-home messages. So if you've got a question, guys, I've just put the slide number so that you say go to slide number 30, slide number 15, so that I can go there. Then we can explain together. If you've got questions, feel free to put the questions on the comment section. Then we can also discuss. Or if you could need more help on that, then I can build up with you like that. So standardized reporting improves communication internationally. So aorta symbol rules are highly accurate, as you have seen the sensitivity and the specificity that it has. Doppler assessment is essential. Report morphology before giving an impression. Okay. When uncertain, recommend expert assessment rather than overcalling. You see, don't name call everything. Don't name call everything. You should seek for expert knowledge if you are not confident. So let me repeat the take homes again. Standardized reporting improves communication. Aorta symbol rules are highly accurate. Doppler assessment is essential. Report morphology before giving an impression. When uncertain, recommend expert assessment rather than overcalling, name calling. So now, ladies and gentlemen, I thank you so much. Thank you so much for your time. Thank you so much. I hope you are learning. If you found this presentation helpful, please like the video, share your questions or comments in the comment section, subscribe to our Medical Ultrasound Academy so that we grow our community. Explore more playlists on gynecological ultrasound, aorta, orals, and ultrasound reporting, please. So we have got our suggested next video that presentation that is coming on orals ultrasound risk stratification, a step-by-step practical guide. It's coming very soon. It's coming very soon. Check out our notification. Then I will notify you. I think in 2 days' time you should be having this orals ultrasound risk stratification presentation. Thank you so much. Enjoy the rest of your day. Bye.
Hello, colleagues. How are you doing? I hope that you are doing very well. So in this presentation, let us discuss about an intrauterine contraceptive device. So when someone is having an intrauterine contraceptive device and they start to have lower abdominal pain, the assumption is it could be the IUCD that is causing the pain. So at times, the IUCD will be very much innocent. So in this presentation, I need you to understand the role of ultrasound in evaluating patients with pelvic pain and an IUCD. So you should be in a position to recognize the normal sonographic appearance of an intrauterine contraceptive device, and then also differentiate IUCD related complications from unrelated pelvic pathology. You must also appreciate the importance of avoiding diagnostic bias. So, you don't just rush into conclusions to say. So, the history of this patient is a 32-year-old female. So, it's a para 2. So, she's complaining of severe lower abdominal pain for 5 days with intermittent pelvic cramps. Then she has mild spotting and pain worse during intercourse. She has no fever and no symptoms of urinary tract related. Then the copper IUCD was inserted 82 months earlier. So that's the brief history of the patient in question that we have today. So the initial suspicion from the referring clinician was that it could be an inflamed intrauterine contraceptive device, or is malpositioned, or probably it's just pelvic inflammatory disease, or an embedded IUCD. So the patient was requested for removal. She requested for removal of the IUCD because from the discussion they had with the doctor, she thought that was could be the culprit. So on ultrasound, as you can see, I used trans-abdominal. It was good enough, so I didn't have any need to show you the images that I later did, or to demonstrate the ovaries. So here you can clearly see, or here you can clearly see here, the IUCD there. You can see it nicely there, and then you can appreciate that the surrounding areas, they are looking very okay. So the first thing that you're supposed to do is identify the uterus, then also the size, also the contour of the uterus. You have to make sure that the contour of the uterus is smooth and there are no other confoundings. So the uterus in this case looks homogeneous. There are no fibroids that I saw, definitely, and I didn't see any sonographic sign of adenomyosis. So the other thing that you're supposed to do is to assess the endometrium, then the fluid, if there are fluid anyway, or there are any retained products, endometrial masses. So those are some of the things that you ought to make peace with. So the assessment of the IUCD position is very pertinent, very critical. As you can see there, you must check for the fundal position, then the arms of the IUCD. So let me show you the arms of the IUCD, that they are fully extended. So then the stem is centered. So this is the stem. So these are the arms. So you can see these are the arms. Let me show you the arms. So what we have here, these are the arms of the IUCD. You can see they are well fully extended there. So that's the stem of the IUCD. So it should be centered. So you can see that it's symmetrical. It's centered in the endometrium, as you can appreciate there. So the entire device within the endometrium. So you can see that the entire device is located within the endometrial cavity, as you can appreciate there. So I can't see any sonographic evidence of embedment. So like this, look at this picture there. That one this one is embedded. That's an abnormally positioned intrauterine contraceptive device. So there's a difference. There's no sonographic sign of perforation, as I've seen from here. And also, I did not see any photograph sign of rotation or any migration, as you can appreciate from this echogenic IUCD. So on ultrasound, basically you have to understand the how it appear like. So it should be bright, as you can see, and echogenic stem. So On transverse section, again, you must appreciate a small dot that is echogenic. So it should be symmetrically positioned, as I've alluded to. So you also have to demonstrate to show the cervix, and if there's nothing in the cervix as well, then if you can appreciate the ovaries, the normal follicles, the blood flow in the ovaries as well, if to check if there's no torsion, because if there's no pain, if there's pain, then you should consider other factors if the IUCD is in normal position. So you also have to assess the adnexia, for possible masses that you can see in the adnexal regions, and no sonographic sign of tubal ovarian abscess. If there is any hydrosalpinx, ectopic pregnancies, is also you have to make peace with those. So you must also appreciate the back of the uterus, the part of Douglas, if there's no free flow in the POD or any complex collections, pass. So those are the things that you should look into. So in this case, or in my case, there was no evidence of an IUCD causing the symptoms whatsoever, unless maybe otherwise you saw them, but I tried my best, I couldn't. So now, what could be the differentials in case that the IUCD is in position, like in my case? So the differential can be early pelvic inflammatory disease that cannot be maybe not be so invisible on ultrasound, or ovulation pain, which is called mitochemes. Mitochemes can also cause pelvic discomfort of pain. So endometriosis can also be another factor. Then, unfortunately, from this video only on transabdominal, it could be difficult for you to visualize deep-seated endometriosis. Then you can also miss that one. So small hemorrhagic ovarian cyst can also cause abdominal pain, or low abdominal pain. So gastrointestinal complications can also cause the pain. So in this case, that could possibly explain it, because you can see there's some bowel gas there. So this is some bowel gas that you can see here, which is casting this dead shadow there. So it could probably be due to bowel-related issues. So urinary tract pathology can also cause low abdominal pain, or it can be musculoskeletal related. So my advice to you, ladies and gentlemen, is you must avoid bias. So many clinicians immediately blame the IUCD for a crime that it never committed. So when a patient presents with pelvic pain, however, a normal IUCD does not immediately automatically mean it is responsible for the symptoms. So ultrasound, the role of ultrasound now in the evaluation of an ICD should now evaluate the uterus, the ovaries, the adnexia, the cervix, the cow district, and the urinary bladder for any other pathology that might be causing the problem before concluding that the IUCD is the cause. So in general, we should not always blame things. You must also look at the merits of certain things. So the IUCD is one of the safest long-acting reversible contraceptive method. So if it is correctly positioned, like in this case, it really causes severe pain after the initial insertion period. It can cause persistent pain, usually suggests another pelvic pathology. So if you see that there's persistent pain, it could be something else. It could also be the one causing the infection. So it can be rejected by the body. So those are some of the things that you have to make peace with and understand when you are assessing the PID. So ultrasound plays a crucial role in confirming correct placement and also including complications. So you must know that when these patients comes to your department, the ultrasound that you're using is very valuable in the assessment of an IUCD. So some of the complications that arise from the insertion of an IUCD can be malpositioning, that's I've discussed about, or a low-lying IUCD, then impediment arm within the myometrium, like what you saw in this image there. So it's embedded there, and also perforation. You can also perforate and it go outside there, the mass of the myometrium of the uterus. So and it can also be expelled via the cervix expulsion. Then it can also cause pelvic inflammatory disease. So that would be PID. So thickened uterus, free fluid, and hyperemia are associated with pelvic inflammatory disease, or the infection that can be induced by these IUCDs. So pregnancy a gestational sick despite IUCD. So these are some of the challenges that someone can still get pregnant despite them having the IUCD. So those are some of the challenges. So now when you're writing the report, you must indicate that there's no sonographic evidence of malpositioning, embedment, perforation, inflammation, or pelvic inflammatory disease. So those ones you should always write them in your report. So now the learning points in this case are always assess IUCD location systematically. So you have this systematic way of doing things and just not blaming the IUCD for crimes that it never committed. So in normal position, IUCD is unlikely to be the cause of chronic pain, and ultrasound should exclude the alternative causes before recommending IUCD removal. So you must also correlate imaging findings with the clinical examination laboratory results. You must avoid bias, so do not attribute symptoms to the IUCD without objective evidence. So we need objective evidence before we can say that the IUCD is the culprit or the cause of pain that the patient will be experiencing. So I think this is making a lot of sense. So I really had to include this case under my discussion because it's not always the case that if there's pain, it is always attributed to an intrauterine contraceptive device. But the knowledge and the history that for you that know that it is there gives us a lot of leeways to navigate through. So we are navigating from multiple angles to see, is it the cause? Can it be the culprit, or it's not, or something else? So ladies and gentlemen, next time when you see a patient with an intrauterine contracture, don't exclusively exclude that as the cause of pain. It could be, in most cases, could be the cause of pain, malpositioning, inflammation which are induced by these IUCDs. So I thank you so much for your time. I hope you are learning, and I also appreciate your presence in the channel. I also take your comments seriously. Please do give us constructive criticism so that we grow. We also reach the bigger audience. We need a bigger international audience that is coming to harmonize our practice, to improve our practice. Also, we need to learn from them. Thank you very much. Enjoy the rest of your day. Welcome to our daily quiz questions. So today we basically have 10 quiz sessions on the pancreas. Pancreatic quiz sessions. So question number 1 is on pancreatic anatomy. Which option best identifies the organ demonstrated in this transverse epigastric scan? Which option best identifies the organ demonstrated in this transverse epigastric scan? So, ladies and gentlemen, we have introduced our daily certificate for the outstanding students. So when you are writing your answers, please write your full name and then give your answers. So your answers must be clear and must be precise, like number 1, A, B, C, then number 2, number 3, number 4, so that we can correlate it nicely. So here we are going to give the certificates on a daily basis like that for the outstanding students who get everything correct. So which option best identifies the organ demonstrated in this transverse epigastric scan? Which option best identifies the organ demonstrated in this transverse epigastric scan? So this is the organ that we are talking about. So this is the organ that we are talking about, this one. So question number, the choices are on question number 1, A, the pancreas, B, the left kidney, C, the spleen, then D, the gallbladder. Which one is the best choice? So please write your best choice. Don't forget to write your full name so that when you compile the names for the certificates, you are also involved. So this is question number 2 now. Acoustic window. Which organ is being used as the acoustic window to visualize the pancreatic tail? So this is the pancreatic tail here. We have got the spleen here. We have got the splenic vein here. We have got the colon there. So which organ is being used as the acoustic window to visualize the pancreatic tail? Choose one. A, left hepatic lobe. B, the spleen. C, the urinary bladder. D, the right kidney. Which is the best option here? Which organ is being used as the acoustic window to visualize the pancreatic tail? A, left hepatic lobe. B, the spleen. C, the urinary bladder. D, the right kidney. So let's move on to question number 3. So this is an image interpretation. What is the most likely diagnosis from this pancreatic ultrasound appearance? What is the most likely diagnosis from this pancreatic ultrasound appearance? So this is the pancreas there, and you can visualize, or you can see the pancreatic appearance that we have there. So choose one. A, acute pancreatitis. B, advanced chronic pancreatitis. C, pancreatic lipomatosis. Then D, the normal pancreas. What is the most likely diagnosis from this pancreatic ultrasound appearance? A, acute pancreatitis. B, advanced chronic pancreatitis. C, pancreatic lipomatosis. Then D, a normal pancreas. So let's move on now to question number 4. Subtle EUS features. This pattern of lobularity, stranding, and hyperechoic foci is most consistent with. So look what is happening here, look what is happening there, look what is happening there, look what is happening there. So choose which one is correct. A, early chronic pancreatitis. B, pancreatic pseudocyst. C, acute cholecystitis. D, pancreatic agenesis. So you can see what we have here, the head of the pancreas, then the corpus. What is this morphology that you are seeing there? What is that? Early chronic pancreatitis. B, pancreatic pseudocyst. C, acute cholecystitis. And D, pancreatic agenesis. The pattern of lobularity, you can see the lobes there, the stranding fat that is depositing in, and hyperechoic foci is most consistent with. And then the hyperechoic foci, what is it consistent with? Okay, so let's now proceed to question number 5. Diffuse enlargement. Diffuse hypoechoic enlargement with a capsule-like rim suggests which diagnosis? Diffuse hypoechoic enlargement with a capsule-like rim suggests which diagnosis? Look what we have here. Choose one. A, autoimmune pancreatitis. B, pancreatic trauma. C, chronic calcific pancreatitis. D, simple pancreatic cyst. Diffuse hypoechoic enlargement with a capsule-like rim suggests which diagnosis? So autoimmune pancreatitis, pancreatic trauma, chronic calcific pancreatitis, or simple pancreatic cyst. Which one is the best option? Okay. Now let's proceed to question number 6. Doppler assessment. Segmental enlargement of the body and tail with this Doppler pattern most frequently suggest. Segmental enlargement of the body and tail with this Doppler pattern most likely suggests. So you can see what is happening with the pancreas there in this one. A. Segmental autoimmune pancreatitis. B. Splenic infection. C. Pancreatic duct stone. D. portal vein thrombosis. Which one is the best option there? Segmental enlargement of the body. And tell you with this Doppler pattern most strongly suggests segmental autoimmune pancreatitis, B. Splenic infection, C. Pancreatic duct stone, then D. portal vein thrombosis. So question number 7, solid pancreatic mass. Solid pancreatic mass. What is the most likely diagnosis for this hypoechoic, poorly defined pancreatic mass? What is the most likely diagnosis for this hypoechoic, poorly defined pancreatic mass? You can see the mass that we have in the pancreas there. That one, what is that? Likely to be A. Ductile adenocarcinoma, B. Serous cystadenoma, C. Pancreatic pseudocyst, D. Normal pancreatic head. What is the most likely diagnosis for this pancreatic hypoechoic, poorly defined pancreatic mass or lesion? What is the most likely diagnosis there? Question number 8. Post-pancreatitis collection. A well-defined fluid collection with posterior enhancement after pancreatitis is most likely. You see what we have there, what we have there. A well-defined fluid collection with posterior enhancement after pancreatitis is most likely A. Pancreatic pseudocyst, B. Pancreatic adenocarcinoma, C. Duodenal hepatoma, D. Calcified lymph node. So which one is the best option there? So question number 9, pancreatic head lesion. An enlarged pancreas with a mass-like formation in the head may represent what we have there, this one. Choose one. A. Autoimmune pancreatitis. B. Hepatic hemangioma. C. Renal angiomyolipoma. D. Splenic abscess. An enlarged pancreas with a mass-like formation in the head may represent A. Autoimmune pancreatitis. B. Hepatic hemangioma. C. Renal angiomyolipoma. D. Splenic abscess. So question number 10 on elastography. Hyperechoic foci and strands with predominantly hard tissue on elastography. What we have here, what we have here, A. Chronic pancreatitis, B. Simple pancreatic cyst, C. Normal pancreas, D. Acute appendicitis. Hyperechoic foci and strands with predominantly hard tissue on elastography. This is the B mode there. You can see on B mode what we're talking about. This is elastography. Those who don't know elastography, it's just a demonstration. Chronic pancreatitis, simple pancreatic cyst, D. C. Normal pancreas, D. Acute pancreatitis. So, ladies and gentlemen, all the best. So we are now introducing a certificate for our best student, best performers every day. So attempt your questions. Make sure you put your correct name when you are giving the certificate. It has to be in your name. So attempt all the questions. Remember, these certificates only give those who get everything correct. We can't generate certificates for everyone. So try your best. We wish you well, all the best, and also remember to take seriously our educational content, our notes, because we are learning and learning is happening. Enjoy the rest of your day. Thank you so much. Bye for now. Today we are exploring ruptured appendicitis, a condition where every ultrasound image can reveal a critical clue. we will learn how to identify the subtle sonographic signs of perforation, recognize life-threatening complications, and confidently distinguish a ruptured appendix from other causes of right lower quadrant pain. By the end of this presentation, you will know exactly what to look for, how to report your findings professionally, and how your ultrasound examination can directly influence urgent patient management. So let's begin. The introduction. A ruptured appendix, also known as a perforated appendicitis, occurs when an inflamed appendix develops a hole in its wall, allowing pus, bacteria, and intestinal contents to spill into the surrounding tissues. This is a surgical emergence that can lead to localized abscess formation or generalized peritonitis if untreated. For sonographers, recognizing the ultrasound signs of perforation is essential because the classic appearance of acute appendicitis may disappear once the appendix ruptures. So this is how a normal appendix appears like. I've just put some images to also show how an inflamed appendix should look like. Look at this appendix. That's how a normal appendix appear like, with a normal gut sign, as you can see here. So that's a normal appendix that you are visualizing there. But now, when an appendix is inflamed, you can see how thickened the walls are and how hypoequivocal edematous they are. You can compare the differences and you can see how thickened the walls now are. Look at this wall and look at this wall and how different they look. Look at that. So that is the major distinction between a normal appendix and a condition or a case of appendicitis. So now the sonographic features: a blind ending tubular structure which arises from the cecum, compressible, diameter less than 6 millimeters, thin wall which is less than 2 millimeters, no sonographic inflammatory sphet, minimum or absent Doppler flow. So these are the sonographic features of a normal appendix. It is a blind ending tubular structure which arises from the cecum. It is compressible, diameter is less than 6 millimeters. It has got a thin wall less than 2 millimeters, no surrounding inflammatory fat, with minimum or absent Doppler flow. So the pathophysiology of appendicitis. So the sequence usually follows: lumen obstruction, mucus accumulation, increased intraluminal pressure, venous congestion, ischemia, bacterial invasion, wall necrosis, and perforation rupture. So that's the sequence of how appendicitis progresses up until the time it ruptures. So what are the causes? The most common causes of appendicitis include an appendicolith, which is a stone within the appendix itself, lymphoid hyperplasia, fecalith, which is a fecal matter stone or a clump of fecal matter that resembles a stone. The foreign bodies, parasites, tumors, which are also rare, but they can also cause inflammation of the appendix. So what are the clinical presentation? Patients usually present with severe right lower quadrant pain, fever, tachycardia, nausea, vomiting, gagging, rebound tenderness, signs of sepsis or diffuse abdominal pain after the rupture. So now, what is the ultrasound technique to make a diagnosis for appendicitis? So the probe, high frequency linear 7 to 15 megahertz is recommended. Curvilinear 3 to 5 megahertz for deep abdomen. So you use both and you interchange both. A high frequency transducer is more ideal to see more detail, whereas a curvilinear you can also see at the deep ends of the appendix, and if there is also any leakage, you can also visualize the rest of the abdominal contents. So the patient position is supine position, left posterior oblique if necessary. The patient position in supine position, left posterior oblique if necessary. Examination method, use graded compression. So when you're talking about graded compression, you are compressing gradually, putting a little pressure, then you sort of increase the pressure and see how the patient responds. Starting scanning, right iliac fossa, the cecum, terminal ileum, psoas muscle, pelvis, most important if severe inflammation is suspected. But there are exceptions to this case. Normally, we see the appendix at the McBain's point in the right iliac fossa, but it can assume variable position. I've seen patients with an appendix that is in the left iliac fossa. You can even find an appendix as high up as the Morrison or hepatorenal space as well. So you must pay due diligence on someone who's been paying, look around and be generous. You might find in appendix it's in a typical position. Also, there are patients who do have more than one appendix. So you have to be careful about that. We had one case that we had where the patient had appendicitis and the appendix was removed, but he started again to feel the pain in the opposite side of the abdomen, and they had to go to theater again. What they found was so shocking. They found a second appendix that was also there. So those are some of the exceptions that you can't expect, but which can in reality happen. So the sonographic findings of acute appendicitis before rupture: non-compressible appendix, diameter which is greater than 6 millimeters, with wall thickening, hyperemia in appendicolite can be there, and echogenic periappendiceal fat. So you can also have periappendiceal fat. So the sonographic findings after rupture. So after rupture, you see free fluid around the appendix there. You can see there's an abscess there. You can see fat stranding that we have there. There's fat stranding, and then you can see there's fluid or an effusion right around or around the peritoneal space. The appendix may be difficult or impossible to visualize because it is decompressed. So you see after it ruptures, it sheds off its contents. So it can be very difficult to visualize it. And also the surrounding contents can also mask the appendix so that it becomes very difficult to visualize well. So the important findings include loss of appendix wall integrity. The normal wall becomes interrupted. Instead of a smooth tubular wall, defects are seen. So also with the periappendiceal abscess, most common sign, appearance, complex fluid collection, thick irregular walls with internal debris, septations, gas echoes, posterior acoustic enhancement. So that's an abscess. So you can also have an abscess that is forming around the appendix itself, which is called now a periappendiceal abscess with these sonographic features: complex fluid collection, thick irregular walls, internal debris, septations, gas echoes, or posterior acoustic enhancement. So can also have what is called flame, an inflammatory soft tissue mass. Ultrasound appearance, it will be ill-defined hypoechoic tissue, no true fluid cavity, increased vascularity. We can also have an extraluminal appendicolite after the rupture, highly suggestive of a perforation, appears as bright echogenic foci with posterior shadowing located outside the expected appendix. So this is an extraluminal appendicolite, or a stone that came from the appendix itself. So the free fluid may occur in the right lower quadrant, in the pelvis, in the paracolic or in the Morrison's pouch. Fluid may contain debris, septations, or pus. So the echogenic inflamed fat, the surrounding fat becomes bright, thickened, heterogeneous. This is one of the earliest indirect signs. So gas outside the appendix, gas appears as bright echoes, dead shadowing, reverberation artifacts, and highly suspicious for perforation. So you can see gas outside the appendix as well. So hyperemia, which is increased blood supply or hypervascularity. Color Doppler shows increased flow, inflamed bowel, hypervascular abscess wall, central abscess remains avascular. So the measurement criteria, so as I said before, that the normal appendix should have a diameter that is 6 millimeters or below, and then the wall thickness should be 2 millimeters and below. Then you can have an abscess in an appendix. You should measure the length, the width, and the depth of an abscess, and record the largest diameter if it is there. So what are the differential diagnoses where we feel that maybe when we think that we are seeing a case of an acute appendicitis or chronic appendicitis or appendicitis in general? Consider the Crohn's disease, Meckel's diverticulitis, cervical diverticulitis, cecal diverticulitis, ovarian torsion, ruptured ovarian cyst, pelvic inflammatory disease, which is PID, and terminal ileitis, mesenteric adenitis, right ureteric stone as well. So here is a simple ultrasound report that you can write if you see a case of suspected or a case of confirmed appendicitis. So right lower quadrant ultrasound examination, the findings, the appendix is not clearly visualized, a complex irregular hypoechoic collection measuring 5.3 by 3.4 centimeters is present within the right iliac fossa, containing internal echoes and debris, marked echogenic inflammatory fat surrounding the collection, and echogenic shadowing appendicolite is demonstrated adjacent to the collection. Small volume free fluid is present in the pelvis. Color Doppler demonstrates increased peripheral vascularity surrounding the collection. The impression: ultrasound findings are highly suspicious for a ruptured or perforated appendicitis with periappendiceal abscess formation. Urgent surgical consultation is therefore recommended. So what are the complications of appendicitis? Generalized peritonitis, so it can cause inflammation of the peritoneal space, it can cause sepsis, septic shock, multiple intra-abdominal abscesses, bowel obstruction, fistula formation, and prolonged ileus. So how do we manage appendicitis? Treatment typically includes intravenous fluids, broad spectrum antibiotics, pain control, surgical consultation, appendectomy, immediate or interval, depending on the clinical scenario, percutaneous drainage for selected abscesses. Now, the key ultrasound signs to remember, the finding and the significance. Non-visualized appendix with inflammatory changes, suspicious for perforation, complex periappendiceal collection, abscess, echogenic inflamed fat, periappendiceal inflammation, which is fat stranding, extraluminal appendicolite, strong evidence of rupture, free fluid with debris, perforation or peritonitis, gas outside the appendix, which is perforation, flame, severe localized inflammation, hypervascular abscess or active infection. So here are the clinical pills or your take home. Failure to visualize the appendix does not exclude appendicitis, especially when secondary inflammatory signs are present. A complex right iliac fossa collection with an extraluminal appendicolite is highly suggestive of a perforated appendicitis. Correlate ultrasound findings with the patient's clinical presentation and laboratory results. If ultrasound findings are equivocal and clinical suspicion remains high, contrast enhanced CT or MRI in selected patients, such as pregnant individuals, is often the next imaging modality. Ladies and gentlemen, this brings us to the end of our presentation. I hope by now you exactly know what to look for when you are dealing with the case of suspected appendicitis, and you can appreciate the sonographic findings, and you can write a report that communicates well your findings. And you know the measurement, the dimensions that you have to use as the reference is 6 millimeters of diameter and the wall thickness of 2 millimeters and below. So those are your references. I thank you so much for your time. I hope you are keeping well and you are keeping abreast with the learning process, remember to share the educational content. Remember to subscribe to our channel as well. Bye for now. Let's meet again in the next educational series. Bye. Hello colleagues and welcome. So in this presentation, we are going to talk about the forgotten compartment. So scanning protocol for detecting deep endometriosis of the sciatic nerve. I need you to watch this presentation till the end, because what we are now talking is gold. This is a golden lecture, because what we are talking about, most of you have never heard about it. So the scanning protocols for detecting endometriosis of the sciatic nerve. So you see, this is the sciatic nerve. You see the anatomy of the sciatic nerve. That's the sciatic nerve there. So we want now to elucidate deep endometriosis that stretches as far as the sciatic nerve. So the diagnostic blind spot. Pelvic routine surveys may stop before the lateral pelvic wall. Neural disease can present as cyclical sciatica rather than pelvic pain. Delayed recognition risk, fixed neuropathic pain, and motor deficit. So we are dealing with one of those type of endometriosis that is so much concealed that even the most experienced, they will always and every time miss it. So the red flags that trigger the nerve protocol: buttock pain radiating below the knee, cyclic burning, electric pain or numbness, weak ankle movement, reduced flexes or foot drop, deep lateral tenderness or non-parametrial disease. So you can see here the hands for the sciatic nerve to check for deep endometriosis that is invading the nerve itself. Know the root before scanning. That's very fundamental. That's critical. You must have the compass. You must have the atlas before you do the scan. So the sacral roots form the lumbosacral plexus. The sciatic nerve approaches the greater sciatic foramen. Piriformis is the key muscular landmark. Internal iliac vessels and the ureter define the danger zone. Ladies and gentlemen, we are now talking ultrasound. We are now talking about saving the patient, especially those patients with chronic pain. They do all tests, nothing is seen. So this could be the hidden answer. This could explain it. Preparation and equipment. Explain the extended examination, obtain consent, high-frequency transvaginal probe, and the transabdominal backup is needed. So linear or curvilinear probe for transgluteal assessment. Optimize depth, focal zone, and gentle compression. So now look at endometriosis there. The submucosal, look at endometriosis there. Start with idea 4-step survey. If you remember, when we were talking about the idea principle in the previous lecture. 1. uterus and the adnexia, including endometriomas. 2. Soft markers, tenderness and organ mobility. 3. Sliding sign in the pouch of Douglas status. Then 4. Anterior and posterior deep endometriosis mapping. So look here, we are checking for endometriosis in the submucosa there, then you can check for endometriosis. So this is a skill that only skilled handlers can do or can perform. Not everyone can master the art of hunting for endometriosis to those depths, going to those jungles, those bushes. That's where experience now and knowledge needs to be compounded together to have a comprehensive answer. So extend laterally from the cervix, find the cervix, find the uterosacral ligament, then the parametrium, track the ureter towards the pelvic side walls, identify the internal iliac vascular branches with Doppler, then search posteriorly towards the sacral plexus. So you see, this is where you start, then you search all the way, you search all the way. This is your cervix there. That's the cervical canal there. So those are the landmarks that you are using to search for this deep hidden endometriosis. So the transvaginal intrapelvic nerve sweep begin in the posterior fornix with a sagittal reference. Rotate towards the symptomatic side. Use slow fan sweeps along the lateral pelvic wall. Compare both sides for caliber and echo texture. So here you can see here we do have got the uterine cervix there, and then we do have what endometriosis there. This is endometriosis. You can see these are the hypoechoic nodules which are consistent with your endometriosis. So the transgluteal sciatic nerve assessment. So look now what we do have here. We have with a hypoechoic lesion that is here, and then with the damaged serosa there, you can see the nerve there, the sciatic nerve that is hypoechoic. Patient prone or lateral decubitus, locate ischial tuberosity and the greater trochanter. Identify the nerve deep to the gluteus maximus. Track proximally towards the sciatic notch. So what suspicious disease may look like? What suspicious disease may look like? Focal or diffuse nerve enlargement, hypoechoic nodule encasing or replacing the fascicles, irregular fibrotic tissue at the sciatic notch, associated tenderness and reduced tissue mobility. So you can see what is happening there. You can see the damaged serosa there. You can see what is happening there. So these hypoechoic regions or nodules there, that's endometriosis. So measure for reproducibility, lesion in 3 orthogonal dimensions, nerve diameter or cross-sectional area where feasible, distance to sciatic notch and adjacent vesicles, side segment depth and pain correlation. So you can see here we do have got the round ligament there, and then we do have got an endometrioma that we have here, the endometrioma there, then the uterus is here. So the common mimics, the piriformis syndrome and muscular injury, lumbar disc disease or foraminal stenosis may also mimic, peripheral nerve sheath tumor, fibrosis, and post-operative change or vascular lesion can also mimic sciatic endometriosis. So you can see there's a nodule here. This is a nodule. That's also endometriosis. So when is MRI needed, or when does MRI becomes essential? When does MRI then become essential? Neurological deficit or progressive symptoms, equivocal or inaccessible ultrasound finding, then suspected sacral plexus or extrapelvic extension, and preoperative neural and vascular mapping. So there you see, now we are hunting for endometriosis around the sciatic nerve. There. So the report what the surgeon needs. Exact site and the neural segment involved, the lesion size, the morphology, and the nerve relationship. Extension through the sciatic foramina, associated ureteric, bowel, or vascular disease, recommendation for specialist MR or referral. So you should answer the clinical question, and you must localize the lesions so that the surgeons, when they go with the clinical precision and extract the tumor or the lesion or the nodule of endometriosis with accuracy. They don't have to struggle. So now, the practical scanning checklist. What are the things that you have to do when you're doing the ultrasound scan? A, ask about catamenial, sciatica, and neurological symptoms. Complete the standard ideal examination. Extend to the lateral compartment when triggered. Compare nerves bilaterally and document the sign loops. Escalate weakness, numbness, or foot drop urgently. So, ladies and gentlemen, this brings us to the end of this very rich presentation. I hope you have learned a useful trade, and I hope that deep-seated endometriosis that affects, that's in case of the sciatic nerve, you can be in a position to think about it when a patient presents pain that doesn't go away, and also to hunt for it. So your assignment for the day is go and read the anatomy of the sciatic nerve. That's the first thing. When you read the anatomy of the sciatic nerve, check the sonographic appearance of the sciatic nerve. The second practical aspect is I need you guys to check for the sciatic nerve. I will very much appreciate those who share on our WhatsApp group the images of the sciatic nerve that they have acquired. That much I will appreciate. So that is how learning happens. Go and read the anatomy of the sciatic nerve, and after that, try to see how the sciatic nerve appears like on ultrasound, and then try to do the imaging of it. Thank you so much. Don't forget to share our educational content and subscribe to our content as well. Enjoy the rest of your day. Bye for now. Dear colleagues, for those of you who practice ultrasound, there are those moments which are so difficult to handle when you have to confront very difficult decisions. The joy of every parent, the joy of every patient when they visit your department, especially when they are pregnant. They are not having any illness, they are not having any sickness. It is the joy that they have that they are now pregnant, they visit the department. Let's discuss on this case. Join me and see the emotion unfolds. Missed abortion at 8 weeks 2 days, when the embryo is present but cardiac activity is absent. So the case introduction: 28-year-old gravida 2 para 1, gestational age by LMP 8 weeks 2 days, reduced pregnancy symptoms, no heavy bleeding or severe pelvic pain is noted. So the case standard, 8 weeks 2 days. ladies and gentlemen, is quite emotional. The clinical question: is the pregnancy intrauterine? Is an embryo present and measurable? Is cardiac activity demonstrated? Are there agent complications? The joy of life to every patient, that moment when they see the movement of the unborn baby. Let me capture that moment for you. Look at that moment. It is this moment of joy. It is this moment of assurance when parents are assured that they are carrying a living being. It is those exciting moments. You know, in early stages, they can't feel the movements. But when they see the movements in real time like this, it is those mesmerizing moments for a couple, especially the ones who are expecting for the first time. The joy of being pregnant for the first time. The joy that comes with the expectation of life. So it is those moments that an ultrasound can capture. Look at the incredible, beautiful embryo there. So it's now a fetus because you can see the features are all developed. So you can see the face, you can see the legs, you can see the heart. So there is proof of life. But not all days are the same. Not all moments are joyful and memorable. There are those moments. There are those moments. Now, let's look at this. This is that other moment. This is that other moment. Now, we have a beautiful soul. You can see that on a flash, the parents, they're seeing the embryo for the first time and they're excited. They can see on the screen that now there is a baby. Now there is an embryo. So when they see the head, when they see the body, they get so excited. But wait for that moment. When we try to identify the heartbeat, look at color Doppler, we can't see anything. It is this other moment, ladies and gentlemen. This is the moment that is so devastating. It is devastating to you, the sonographer. It is devastating to the parent. How are you going to tell the patient? How are you going to disclose this type of news? So the unfortunate it happened. At first, they've seen the baby, they've seen the embryo, they've seen the images, they've seen that there's something. They are so excited, they can see the head, they can see the limbs starting to fall. But now, wait for it. It is that other moment. It is that other moment when there is no proof of life. This is emotional. This is very devastating. This is one of the worst experiences to anyone who is doing ultrasound scans, especially on a daily basis. We have got these moments. It is these other moments. It is these other moments, colleagues. Now, the systematic scanning protocol for a missed abortion: confirm an intrauterine gestational sac, identify the yolk sac and the embryo, optimize magnification around the embryo, measure the crown rump length in a true mid-sagittal plane, observe the cardiac region using real-time 2D or M mode. So the case ultrasound findings: single intrauterine gestational sac, yolk sac and embryo are visualized. The crown rump length is approximately 18 millimeters. Ultrasound age approximately 8 weeks, 2 days. No embryonic cardiac activity is demonstrated. Why this case? Why this meets diagnostic criteria or thresholds? A crown rump length above 7 millimeters or equal to 7 millimeters with no heartbeat is diagnostic on transvaginal ultrasound. This embryo measures approximately 18 millimeters. Absence of cardiac activity was confirmed carefully. Local policy, image quality, and second review still matter. Do not diagnose from dates alone. LNP may be inaccurate. Ovulation and implantation vary. One uncertain scan may require follow-up. Certainty must precede intervention. So the definitive versus uncertain viability: definitive crown rump length above or equal to 7 millimeters and no heartbeat. Definitive mean sac diameter above or equal to 25 millimeters and no embryo. Suspicious crown rump length less than 7 millimeters and no heartbeat. Suspicious mean sac diameter 16 to 24 millimeters and no embryo. Suspicious findings require repeat transvaginal ultrasound scan. So the differential considerations: incorrect dates with early viable pregnancy, pregnancy or uncertain viability, an embryonic pregnancy, complete or incomplete miscarriage, ectopic or heterotopic pregnancy when location is uncertain. So the suggested ultrasound report: transvaginal early pregnancy ultrasound. A single intrauterine gestational sac contains a yolk sac and embryo. The crown rump length measures approximately 80 millimeters, corresponding to 8 weeks, 2 days. No embryonic cardiac activity is demonstrated during careful real-time observation. The cervix closed. No significant free fluid noted in the pouch of Douglas. Impression: findings are diagnostic of early pregnancy loss or embryonic demise. Clinical correlation and early pregnancy unit review are advised. So the communication with compassion. So we must communicate with compassion with the patient, confirm privacy before discussing the results, use clear, non-blaming language, allow silence and questions, explain the next clinical step, and provide agents return advice. So management is shared decision: expectant management, medical management, surgical management. Choice depends on stability, preference, and local protocols. So the key lessons from this case: scan systematically before concluding, measure the crown rump length accurately, confirm absent cardiac activity carefully, apply conservative diagnostic thresholds, repeat the scan whenever certainty is insufficient, report clearly and communicate compassionately. Ladies and gentlemen, it is this other moment. It is this other moment. So the joys of our profession, the sorrows of our profession, the turbulences, the flaws of our profession, they are defined in these still images. They are defined in these visual images, the real-time images. They can carry so sad memories, so devastating memories. Ladies and gentlemen, my heart is grieving. So allow me some time to calm down. The experience wasn't so nice. The experience wasn't so nice. Let's meet again in the next presentation. Bye for now. Hello and welcome. In this presentation, we are going to discuss comprehensively on the lower limb venous and arterial Doppler ultrasound. The lower limb Doppler ultrasound, we will talk about the detailed arterial, venous, reflux, and the reporting nodes. We are also going to tackle on the clinical reasoning, image interpretation, and reporting. So don't miss any part of this presentation. If you miss, you might not be competent forever in a Doppler assessment. So let's do it systematically together. What a complete lower limb Doppler examination must answer: the venous questions. Is the vein patent and fully compressible? Is thrombus present? And is it acute or chronic? Is the flow spontaneous, phasic, augmentable? Is the reflux present? If yes, where does it originate? And how far does it extend? So the arterial questions are: is there inflow, disease, focal stenosis or occlusion? Where is the lesion and how severe is it? What is the distal hemodynamic effect? Are ABI, TBI waveforms concordant with the symptoms? So, choose the study before choosing the settings. Common examination types: DVT, Patent's duplex, venous reflux, insufficiency mapping, native arterial duplex, ABI or TBI with segmental pressures, bypass graft or stent surveillance, preoperative vein mapping. So the clinical details to confirm: side and symptom onset, pain, swelling, ulcer or claudication, previous DVT, surgery, ablation or bypass, anticoagulation and vascular risk factors, exact area of concern, whether a limited or complex study is requested. So the equipment and process determine whether flow, slow flow is seen. So the transducers: linear 7 to 15 megahertz, most thigh and cow vessels is used, which is a high resolution probe. Lower frequency linear or curvilinear obesity, edema, or deep veins. So when you're dealing with the deep veins, you might use a lower frequency transducer or when examining obese patients. Small footprint linear, ankle, pedal, and difficult calf windows. Continuous wave Doppler, ABI or TBI pressure acquisition. Optimize the system. Begin with appropriate depth and focal zone. Use low venous PRF and low wall filter for slow flow. Use sufficient color gain without blooming. For arteries, keep spectral angle less or equal to 60 degrees and parallel to flow. Set scale so the waveform fills the display. Document technical limitations honestly. Patient positioning is part of the examination. DVT or patterns. Supine with head slightly elevated. External rotate the hip and flex the knee. Reverse Trendelenburg may distend the veins. For popliteal, curve veins prone, lateral, or seated if needed. Reflux arterial. Reflux, standing or reverse Trendelenburg with the limb dependent. Support the patient to prevent falls. Arterial, supine, warm room, rest before pressures. Keep curve at heart equivalence level and avoid talking or any movements. Compression is a primary test for lower limb DVT. The technique uses transverse imaging and compress at short intervals from proximal to distal. Apply enough pressure to co-opt the arterial and posterior walls completely. Compare adjacent arterial behavior in the opposite limb when useful. Do not compress aggressively over severe pain, open wounds, or suspected free-floating thrombus. The diagnostic principle: a normal vein collapses completely. Persistent lumen is called non-compressibility and is the key sign of thrombosis. A complete venous patterns protocols follows the anatomy. Proximal or deep systems, common femoral vein and saphenofemoral junction, deep femoral vein origin, femoral vein proximal, mid and distal, popliteal vein, popliteal tibial and peroneal veins where indicated or protocol requires. The superficial and additional veins, the greater saphenous vein at the junction, small saphenous vein and saphenopoppliteal region, symptomatic superficial veins, muscular calf veins when visualized, iliac IVC assessment when waveform or symptoms suggest proximal obstruction. So normal venous flow is 4 recognizable behaviors: expected findings, complete compressibility, spontaneous color and spectral flow, respiratory phasicity in proximal veins, meaning to say that you must see the collapse and the movement or the adjustment in the diameter with respiration, prompt increase with the distal augmentation, valve closure without pathological retrograde flow. So abnormal clues: absent or incomplete compression, intraluminal echoes with lumen expansion or contraction, absent color field after optimization, continuous or monophasic proximal venous flow, poor augmentation or prolonged reverse flow. So distinguish acute from chronic thrombus using multiple signs. Features favoring acute DVT: non-compressible, often enlarged vein, hypoechoic or heterogeneous thrombus, smooth or poorly attached thrombus margin, absent or reduced flow, and collateralization usually limited. Clinical onset may be recent, but ultrasound age is an estimate. Features favoring chronic chance: small, irregular, or incompletely compressible vein, echogenic wall, adrenal material, synechia, webs, recanalized channels, wall thickening, calcification, or established collaterals. Use chronic post-thrombotic change when appropriate. Use careful language when thrombus is uncertain. Recommended approach: describe location, the extent, occlusive status, and compressibility. State acute, chronic, post-thrombotic change or indeterminate age only when supported. Avoid subacute unless your laboratory has defined criteria and correlation. Escalate suspected proximal or iliac obstruction when common femoral vein waveforms are asymptomatic or poorly phasic. Example impression: acute occlusive DVT extends from the left popliteal vein into the distal femoral vein. The common femoral vein remains patent. So the reflex testing technique, dependence and provocation. How to provoke reflux: distal manual compression and sudden release, pneumatic cuff regurgitation where applicable, valsalva at the common femoral vein, saphenofemoral junction. Record baseline maneuver and duration of retrograde flow. Trace superficial reflux to its source whenever possible. Common thresholds: superficial veins retrograde flow above or equal to 0.5 seconds. Deep vein retrograde flow above or equal to 1 second. Perforators often less above or equal to 0.5 second. Diameter and outside relationship matter. Apply laboratory defined criteria and current local standards. Do not diagnose from color flow alone. So MAP reflux is connected pathway, not isolated measurements. Document deep system patterns in reflux. Superior superficial femoral junction, saphenous femoral junction, greater saphenous vein segments, SPJ, SSV, and accessory veins. Vein diameters in dependent position, source pathway, and distal extent of reflux. Relevant tributaries and perforators. Previous ablation segments and residual channels. Report side and patient position, provocation method, reflux during duration and location, superficial anatomy or variance, deep vein obstruction or reflux, relationship to symptoms, ulcer or planned treatment. Arterial duplex combines morphology, color, and spectrum. B mode plus color, plaque location and character, residual lumen and vessel diameter, color arising in focal jet, post-stenotic turbulence, occlusion, collateral channels, or aneurysmal change. Spectral Doppler, record peak systolic velocity and standard segments. At standard segments, measure end systolic velocity when grading significant lesions. Sample pre-stenosis and stenosis and post-stenosis. Maintain angle less than or equal to 60 degrees and consistent angle correlation. Compare peak systolic velocity ratio with the proximal normal segments. Follow the arterial tree in a reproducible order. The thigh, distal external iliac artery where accessible, common femoral artery, profunda femoris origin, superficial femoral artery, proximal, mid, and distal. Knee to foot, popliteal artery, proximal, mid, and distal. Tibial peroneal trunk, anterior tibial artery, posterior tibial artery, peroneal artery, dorsalis pedis were indicated. So a normal high resistant limb artery is multiphasic. Normal resting pattern, rapid systolic upstroke, sharp systolic peak, brief early diastolic flow reversal, possible late diastolic forward component, progressive peak systolic velocity reduction distally without focal step up. So the disease patterns: focal velocity acceleration and stenosis, spectral broadening and turbulency, post-stenotic disturbance, downed monophasic tardus pavus downstream, no detectable flow in occlusion after flow optimization. So you must grade the stenosis with a local validated velocity scheme. Typical native artery teaching framework. Category: normal less than 50%, peak systolic velocity ratio less than 2.0, supportive appearance, no major focal jets or waveform preserved, 50 to 74%, ratio 2 to 3.9, focalizing elevated PSV turbulence above 75%, peak systolic velocity ratio above or equal to 4, marked velocity rise and diastolic velocity often elevated. Occlusion, there's no flow. Lumen field collateral reconstitution may be present. Exact threshold vary by laboratory vessel, graft, and stent. Use morphology and downstream hemodynamics on one number alone, not on one number alone. So the tarsus parvus signals an upstream lesion. Do you know what tarsus parvus is? Recognize it, which is a delayed systolic acceleration, rounded damped systolic peak, reduced peak systolic velocity and positivity, often monophasic downward waveform. Compare with the contralateral limb and proximal segments. What it means, look proximally for inflow, stenosis, or occlusion. A normal common femoral artery waveform edges against major ipsilateral inflow disease. A damped CFA waveform may suggest aortoiliac disease. Collateral flow can mask the true level. Correlate to the ABI, PVI, R, and symptoms. ABI converts angle pressure into an interpretable ratio. ABI is equal to higher angle systolic pressure divided by higher brachial systolic pressure. So how to measure? Rest supine before testing. Use appropriate size cuffs. Obtain both brachial pressures. Measure DP and PT angle pressures. Calculate each leg separately. So the interpretation, less than or equal to 0.9 abnormal, which could be indicative of peripheral artery disease, PAD 0.91 to 0.99, which is borderline, 1 to 1.4, which is normal, above 1.4, non-compressible. Use TBI when arteries are non-compressible. Toe pressures help when ankle arteries are incompressible. When TBI helps, ABI is above 1.4, suspected medial calcification, diabetes, chronic disease, or advanced age. Discordant symptoms and apparently normal ABI. Assessment distal perfusion and wound healing content. Practical points. Use photophleismography suitable toe sensor. Warn the feet and minimize motion. TBI less than or equal to 0.70 is generally abnormal. Interpret abnormal toe pressure with the clinical context. Severe edema, wounds, or amputation may limit the movement. Artifacts can mimic or hide vascular disease. So, too little compression pressure, too much color scale or filters, mistaking duplicated femoral veins for a single patent channel, confusing lymph nodes, cysts, or arteries with veins, calling color absence thrombosis before optimization, arterial pitfalls, angle above 60 degrees or angle cancer not parallel to flow, sampling outside the tightest gate, analyzing without spectral confirmation, excess probe pressure reduces flow, missing tandem lesions, or relying on PSV alone. A high quality worksheet makes the final report defensible. Minimum image set, patient side identification indication, compression images at the protocol defined levels, color and spectral samples with labeled anatomy, measurements and angle correlation where relevant, pathology images showing extent and severity, technical limitations, images or notes. So the quality check, correct laterality throughout, anatomical labels match the image, waveform scale and baseline are appropriate, reflux time or velocity ratio is visible, contraindications are resolved before sign off. Agent findings follow the escalation policy. Venous reporting answered the clinical question. Suggested structure, examination, lower limb, venous Doppler, side and scope. Findings, compressibility, color flow, physicity, and augmentation by segment. Thrombosis, extent, veins, proximal or distal extent, occlusive status, and age features. Superficial systems, thrombosis or reflux were assessed. Limitations, cough, visualizations, edema, pain, dressing, or body habitus. Impression, one concise conclusion plus urgent communication when required. Arterial report, localized disease and describe its effect. Suggested structure and examination, arterial duplex plus or minus ABI, stroke TBI, side and scope. Findings, plaque patterns, waveform and segmental velocities. Lesion, vessel, segment, PSV ratio, EDV, and supportive color or B mode signs. Distal effect, post-stenotic turbulency, dampening or collateral reconstitution. Physiology, ABI or TBI over TBI and waveform category. Impression, severity and level of disease. Mention occlusion and run of limitations. Example impressions should be precise and clinically useful. Venous examples, no sonographic evidence of acute DVT in the examined right lower limb veins. Acute non-occlusive DVT in the left popliteal vein extending into the distal femoral vein. Chronic post-thrombotic change in the right femoral and popliteal veins. Superficial vein reflux in the greater saphenous vein from the saphenofemoral junction to below knee deep system remains patent. Arterial examples, hemodynamically significant stenosis in the mid SFA with the PSV ratio 3.1 and post-stenotic turbulence. Occlusion of the distal SFA with collateral reconstitution of monophasic popliteal flow. Damned common femoral artery waveform suggestive proximal inflow disease. ABI is abnormal bilaterally, worse on the left, correlate with symptoms and vascular assessment. Escalate findings that may change immediate management. Urgent critical communication examples, new proximal acute DVT or extensive iliofemoral thrombosis, suspected phlegmasia or threatened venous outflow, acute arterial occlusion with limb ischemia symptoms, severity, reduced absent distal perfusion with rest pain or tissue loss, expanding pseudoaneurysm or other unexpected high-risk vascular finding. Follow the facility's escalation pathway and document who was conducted, the time, and the response. A disciplined sequence produces reliable Doppler examinations. 1. Confirm the clinical question and correct protocol. 2. Position the patient and optimize the preset. Follow a complete anatomical sequence. Combine B mode, color, and spectral evidence. Apply validated criteria and recognize limitations. Report locations, extent, and severity and agency. So lower limb arterial anatomy scan in sequence. So you can see this. That's the anatomy of the lower limb. So you can see the veins there going downwards. You can see the trunk, the artery. So the arteries, the trunk as you go down there, like that. So the key landmarks that you're supposed to appreciate and know are the aortoiliac iliac inflow. So from the aorta to the iliac is there. You have to understand that. And the common femoral artery. So you can see the common femoral artery there as it runs like that. Then you have to understand the profunda and the superficial femoral veins as they go like that. And then you have to understand the popliteal artery as it go to the back like that, and also you have to know the anterior tibia and the posterior tibial. And the peroneal, the dorsalis pedis, you must also understand them in the turn of. So you have to know which region you are dealing with so that you can document anatomy nicely. Are you here at the aortoiliac portion, or you are here in the common femoral, or in the popliteal, or the dorsalis? So you just have to understand the anatomy well, so that when you're documenting, you know exactly where you are. So the deep and superficial lower limb veins. So the veins again, so you can see here the landmarks. So you can see here the common femoral veins there, and you can also see the femoral and the profunda veins. So the femoral veins as they go there, as you go down there, in the greater saphenous, this one, that's the greater saphenous as it goes down there. And then the popliteal veins is at the back, is at the back there, that's the popliteal vein there. Then you also have to analyze the posterior tibial, as it goes there, and the anterior tibial as it goes there. So the paired curve and the variance, so those are the major veins that the deep venous system as it goes like that, and it runs up and at the back like that. That is what you have to appreciate when you are doing your your Doppler studies, lower limb Doppler studies. So ultrasound atlas, thrombosis and compression. So now let's look here at how a normal vein should appear like. So if you look here, you can see that we do have an artery and a vein in their patent. The flow is there. So the blue is your vein, the red is your artery, and you can see that after compression, it collapses nicely. So the vein collapses nicely like that, but the artery, because it was thicker walls, it doesn't compress. And then when there's an acute DVT now, so you can see this enlarged and non-compressible, so you can see that's a DVT there, and you can't compress it. That's a deep venous thrombosis. But in chronic stages now, you can see that the DVT is there, it's echogenic the center, but it is instability, peripheral flow there. So this is now a sign of a chronic thrombosis. So you can see an echogenic thrombus and recanalization is taking place now. That's recanalization. You can see there is peripheral perfusion. So this can help you to actually determine the age of the thrombus, acute stages, and the chronic thrombus. So now arterial ultrasound, plaque stenosis, and occlusion. So you can now see this is smooth wall and laminar flow. This is the smooth flow there, laminar flow. But you can now see that there's arteriosclerosis with a calcified plaque plus shadow. So this is arteriosclerosis. Then you can see a plaque there, and you can see that posteriorly there's a shadow, calcification with a shadow there at the back. So this is how now you can now differentiate a normal artery from a one with an arteriosclerosis and a plaque. So a stenosis. So you can see here there's a stricture, there's a stenosis, and there's a aliasing that's happening there because we are moving from a bigger or a wider surface area portion to a narrow surface area. So you can know, the conservation of what? The conservation of mass. So that when the surface area increases, the velocity decreases, and when the surface area decreases, the velocity increases. So that's what exactly happened there. So here, because the surface area is decreased, you can see that the velocity increases and there's going to be an aliasing. So the stenosis is going to be seen like that. So occlusion, absent flow, or collateral. So there's complete occlusion. Now you can see that you can't see Doppler perfusion, and there is a re-establishment of the collateral flow like that. So confirm stenosis with the spectral velocity sampling, pre-stenosis at the gate, and post-stenosis. Calculate the pixel velocity ratio using validated laboratory criteria findings. So, ladies and gentlemen, this brings us to the end of this brief but long presentation on venous and arterial lower limb Doppler. I hope you've mastered a useful trade. If you've got any questions, please feel free. You can ask and type under the comment section. I will always respond accordingly. Take your time to go through the anatomy nicely so that you know how the vessels branch and which segment is what, so that you exactly know the anatomy. If you know the anatomy now, it will be very difficult, because for you to see a pathology or a DVT, it can be easy, but for you now to know which artery, which vessel is this one, that can be a challenge. So you have to master your anatomy again. So once again, thank you so much. So scan, subscribe, learn, report with confidence. Scan, learn, report with confidence. Lower limb Doppler ultrasound. So these are the detailed notes: clinical reasoning, image interpretation, and reporting. That's our motto is medical ultrasound imaging. Subscribe, like, and share. Bye for now. Let's meet again in the next segment. Bye.
So here we have got a patient who had a ruptured appendix. So the appendix ruptured, that is a week ago. So he had a laparotomy, and then now she's having a problem. There is some blood that is coming from the umbilicus. So I did a sonar now, and then this is what I saw. You can see here, that's the umbilical area there, that's the umbilical area. So you see, we can see there's a collection of free fluid there with the fibrin echogenic strands. So these are fibrin strands, fibrin echogenic strands that you're seeing there. So this is a collection that I'm seeing there. So you can see these lines there, these lines there, which are bright, these are called fibrin strands. These are fibrin strands, the fibrin strands. So do you know the significance of the fibrin strands? So also, you know, when blood is clotting, it tends to form those strands. So this is a what happens when blood clots. So if you see a mass or a lesion with the fibrin strands inside, you must always suspect blood that is clotting. Either it's a hemorrhagic cyst, or if it's not a hemorrhagic cyst, then you could be having a hematoma in the making. So here, in this case, you can see that we have got blood uh, that is collecting there. So this is post-operative complication. So this is part of the incisional line, where you are now seeing that there is a collection of blood that is now formed. So this is a hematoma. So those are some of the challenges that comes with the operations. Infections can come, bleeding can happen, post-operative bleeding can happen. So the technique for me to see or localize this collection, I used a small hawk stick so that I can pick even the smallest pocket of effusion. So the hawk stick played the magic. So you can see, I can see nicely the lesion. Then you can see the lesion also has got posterior acoustic shadows there. So here is acoustic shadow. There's an acoustic shadow there. Then these collections, they also need to be
distinguished from inflammatory processes like in abscess collection. So how do we differentiate a hematoma from an abscess? So fundamentally, the history matters. So if the patient is having pain, a fever, and then if we are going to put color and you see hyperperfusion on the peripheries of the lesion or the mass, you must then think of an abscess because it's an inflammatory process. So you see, I put color, but there's no enhancement. So there's no enhancement on color Doppler. So the peripheries are clear, meaning to say that it's not an inflammatory process. So an inflammatory process is associated with increased blood flow towards the inflamed area, hyperemia. If you know the 5 cardinal signs of inflammation, tumor, robot, dolo, color, function lesia, if you remember those ones, so you can understand that you use those cardinal signs to now distinguish an ordinary hematoma from an inflammatory process. Then, because there's no edema on the peripheries there's no hypervascularity on the peripheries there. So the best differential is a post-operative hematoma that is collected there. So I hope it's making sense to you. So MSK is one of those areas which is quite interesting and which most people are not interested in. So you can see I tried to also use microvascular to pick the least signals or the smallest signals to amplify the signals so that we can see if there's perfusion there, but there's no perfusion, as you can see whatsoever. There's no perfusion. So this basically it puts a no to an abscess. An abscess should have hypervascularity there, high hypervascularity there, and the tenderness. So this was not tender. It wasn't tender. It's just the collection that is so hard there on the umbilicus. So this is a post-surgical hematoma. So the worst that can happen during surgical procedures is when they can perforate a bowel, or they can also perforate a blood vessel. So, but there are some small blood vessels also that can also leak or bleed. So I think in this case, because you see that the hematoma is well contained, it's encapsulated, it's well encapsulated, meaning to say that it's not a major vessel that has been severed or that has been damaged. So just a localized, a small hematoma there. So ladies and gentlemen, this is my case. If you've got any contributions and questions, please feel free, ask in the comment section. Then we can build our learning profile together. Enjoy the rest of your day. Don't forget to put on the notification button so that we keep on updating each other as we learn. Thank you so much.
Hello everyone, and how are you? How are you doing? I hope you're doing very well. So we are going to start on our American Registry for Diagnostic Medical Sonography examination preparation questions. So in this session, we do have got 20 typical questions, explanations, answers. So if you want to enhance your practice as well, even if you are not writing for the American Registry exams, this is ideal for you to have an in-depth understanding of the medical ultrasound. So the American
The American Registry for Diagnostic Medical Sonography, RMDMS examination system is the gold standard for certifying medical sonographers globally. So to earn an RDMS credential, a candidate must successfully pass 2 separate computer-based exams within a 5-year period, the foundational physics, and at least 1 clinical specialty exam. So this physics exam is compulsory. So a RDMS examination tips. So this one is the obstetric part that I am going to discuss with you in this session. So these are the tips for a typical obstetrics examination session. So the American Registry questions, they are multiple choice questions, and then you have to make a choice from there. So these questions reflect the clinical reasoning and image interpretation style commonly encountered on the ARDMS obstetric and gynecology examination. So the tips: you must know fetal anatomy in all standard planes. You must memorize first trimester pregnancy failure criteria, crown rump length and mean sac diameter thresholds. You must understand umbilical artery, middle cerebral artery, uterine artery, and the ductus venosus Doppler patterns. You must be able to differentiate common fetal anomalies such as anencephaly, spina bifida, omphalocele, gastroschisis, duodenal atresia, congenital diaphragmatic hernia. So you must master fetal biometry, estimated fetal weight calculations, amniotic fluid assessment, placenta abnormalities, and multiple gestational evaluation. So you must master those ones if you want to pass these American Registry examinations. So let's go into the questions, and then I need you to attempt the question self-assessment. So the next page I will be giving the answers. The first page I give you the question. So attempt on your own to attempt, then self-evaluate yourself to see how far you can go. So question number 1: during a routine first trimester scan at 8 weeks, a fetal pole measures 16 millimeters, crown rump length, but no cardiac activity is demonstrated. So this is what we have here. That's the images. So what is the most likely diagnosis? A, pregnancy of unknown location. B, missed miscarriage. C, viable pregnancy. D, ectopic pregnancy. So the question again: during a routine first trimester scan at 8 weeks, a fetal pole measures 16 millimeters crown rump length, but no cardiac activity is demonstrated. So what is the best diagnosis for that? A, pregnancy of unknown location. B, missed miscarriage. C, early viable pregnancy. D, ectopic pregnancy. So now let's move on to the answer. So the correct answer for this question is a missed miscarriage. Explanation: according to accepted first trimester ultrasound criteria, a crown rump length which is above or equal to 7 millimeters with absent heartbeat is diagnostic of pregnancy failure. Repeat scanning is unnecessary if image quality is adequate. So you must make sure that the image quality is adequate. Otherwise, you can also make a misdiagnosis because the quality of your images are quite poor. So that is the correct answer for question number 1. So question number 2: a patient at 20 weeks undergoes fetal biometry. Which parameter is most accurate for pregnancy dating in the second trimester? A, the female length. B, the head circumference. C, biparietal diameter. D, abdominal circumference. A patient at 10 weeks undergoes fetal biometry. Which parameter is most accurate for pregnancy dating in the second trimester? A, female length. B, head circumference. C, biparietal diameter. D, abdominal circumference. Okay, so let's go to the answer. So the uh, correct answer now is B, which is the head circumference. So explanation: head circumference is less affected by fetal head shape than BPD and is therefore preferred for dating. So the correct answer for dating in the second trimester, the most accurate, is the head circumference, which is less affected by fetal head shape than the BPD and is therefore the preferred choice. So let's go to the next question. Question number 3. A sonographer observes the fetal stomach positioned on the right side of the abdomen. So what should be suspected? A sonographer observes a fetal stomach positioned on the right side of the abdomen. So what should be suspected? A. An omphalocele. B. Situs inversus. C. Duodenum atresia. Then D. gastroschisis. A sonographer observes the fetal stomach position on the right side of the abdomen. What should be suspected? A. Omphalocele. B. Situs inversus. D. Duodenal atresia. Then D. gastroschisis. So our correct answer is B. That's situs inversus. The fetal stomach is supposed to be positioned in the left side. That's the normal position. So question number 4. During Doppler assessment of the umbilical artery at 32 weeks, absent any diastolic flow is demonstrated. What does this indicate? During Doppler assessment of the umbilical artery at 32 weeks, absent any diastolic flow is demonstrated. What does this indicate? A. Normal placental function. B. Placental insufficiency. C. Polyhydramnios. D. Maternal diabetes. During Doppler assessment of the umbilical artery at 32 weeks, absent any diastolic flow is demonstrated. What does this indicate? A. Normal placental function. B. Placental insufficiency. C. Polyhydramnios. D. Maternal diabetes. So the correct answer is B, which is the placental insufficiency. The explanation: absent reversed end diastolic flow indicates severe placental resistance and fetal compromise. So that's placental insufficiency. Our answer is B. Now, question number 5. Which fetal structure should always be seen in the standard 4-chamber view? Which fetal structure should always be seen in the standard 4-chamber view? A. Pulmonary veins. B. Left ventricular outlet tract. C. Both atria and the ventricles. D. The aortic arc. Which fetal structure should always be seen in the standard 4-chamber view? That's the standard 4-chamber view, the standard 4-chamber view. A. Pulmonary veins. B. Left ventricular outlet tract. C. Both atria and ventricles. D. The aortic arc. So our answer is C. Both atria and the ventricles are supposed to be seen in the 4-chamber view. Question number 7. Which biometric measurements is most affected by fetal growth restriction? Which biometric measurement is most affected by fetal growth restriction, IUGR? A. Biparietal diameter. B. The femur length. C. Abdominal circumference. D. The head circumference. Which biometric measurement is most affected by fetal growth restriction? A. Biparietal diameter. B. Femur length. C. Abdominal circumference. D. The head circumference. So our correct answer is C, which is the abdominal circumference, the one that is mostly affected by fetal growth restriction. Question number 8. Which vessel normally carries oxygenated blood from the placenta? Which vessel normally carries oxygenated blood from the placenta? A. Umbilical artery. B. Umbilical vein. C. Ductus arteriosus. D. The aorta. Which vessel normally carries oxygenated blood from the placenta? A. Umbilical artery. B. Umbilical vein. C. Ductus arteriosus. D. The aorta. So the correct answer is the umbilical vein, which is B. The umbilical vein. That's B. Question number 9. Which abnormality is most associated with increased knuckle translucency?
Which abnormality is most associated with the increased knockout translucence? A. Down syndrome. B. Clubfoot. C. Renal agenesis. D. hydrocephalus. Which abnormality is most associated with increased knockout translucency? A. Down syndrome. B. Clubfoot. C. Renal agenesis. D. hydrocephalus. So our correct answer is A, which is Down syndrome. Down syndrome is the correct answer. Question number 10. The lambda or twin peak sign indicates. So the lambda or the twin peak sign, what does it represent? A. Monochorionic twins. B. Dichorionic twins. C. Twin to twin transfusion syndrome. D. Conjoined twins. The lambda twin peak sign indicates A. Monochorionic twins. B. Dichorionic twins. C. Twin to twin transfusion syndrome. D. Conjoined twins. So the correct answer is B, which is dichorionic twins. Dichorionic twins. Question number 11. Which fetal presentation places the buttocks closer to the cervix? Which fetal presentation places the buttocks closer to the cervix? A. Cephalic. B. Bridge. C. Shoulder. D. Transverse. Which fetal presentation places the buttocks closest to the cervix? A. Cephalic. B. Bridge. C. Shoulder. D. Transverse. So the correct answer is that's a bridge presentation. That's a bridge presentation. Question number 12. Which fetal anomaly is classically associated with the double bubble sign? Which fetal anomaly is classically associated with the double bubble sign? A. Jejunal atresia. B. Duodenal atresia. C. Esophageal atresia. D. Imperforate anus. Which fetal anomaly is classically associated with the double bubble sign? A. Jejunal atresia. B. Duodenal atresia. C. Esophageal atresia. D. Imperforate anus. So the correct answer is B, which is duodenal atresia. Question number 13. Polyhydramnios is defined as A. AFI less than 5 centimeters. B. AFI above 24 centimeters. C. AFI 10 centimeters. D. MVP 2 centimeters. So polyhydramnios is defined as A. AFI less than 5 centimeters. B. AFI greater than 24 centimeters. C. AFI 10 centimeters. D. MVP 2 centimeters. So the correct answer is B. AFI above 24 centimeters. And AFI above 24 centimeters is classified as polyhydramnios. Question number 14. Which Doppler vessel is commonly used to assess for fetal anemia? Which Doppler vessel is commonly used to assess for fetal anemia? A. Umbilical artery. B. Uterine artery. C. The middle cerebral artery. D. Ductus venosus. Which Doppler vessel is commonly used to assess fetal anemia? A. Umbilical artery. B. Uterine artery. C. Middle cerebral artery. D. The ductus venosus. So our correct answer is C, which is the middle cerebral artery. The middle cerebral artery is the correct answer here. Question number 15. Which feature differentiates gastroschisis from omphalocele? Which feature differentiates a gastroschisis from an omphalocele? A. Liver outside the abdomen. B. Membrane covering the bowel. C. No covering membrane. D. Midline defect. Which feature differentiates a gastroschisis from an omphalocele? A. Liver outside the abdomen. B. Membrane covering the bowel. C. No covering membrane. D. Midline defect. So the correct answer is C. No covering membrane in a gastroschisis. So there's no covering membrane
but in the omphalocele, that's where we find a covering membrane. Question number 16. Which structure bypasses the fetal lungs? Which structure bypasses the fetal lungs? A. The ductus arteriosus. B. Portal vein. C. Umbilical artery. D. The pulmonary vein. Which structure bypasses the fetal lungs? A. Ductus arteriosus. B. Portal vein. C. Umbilical artery. D. The pulmonary vein. So the correct answer is ductus arteriosus. The ductus arteriosus. A. That's the correct answer. A. Ductus arteriosus. So now let's go to question number 17. Which biometric parameter is least useful for estimating the fetal weight? Which biometric parameter is least useful for estimating the fetal weight? A. HC, head circumference. B. Abdominal circumference. AC. C. FL is the femur length. D. The mean seg diameter. Which biometric parameter is least useful for estimating the fetal weight? A. HC. B. AC. C. FL. D. The seg diameter. So the correct answer is the mean seg diameter. The seg diameter. Question number 18 now. A fetus demonstrates absent calvarium with exposed brain tissue. What is the diagnosis? A fetus demonstrates absent calvarium with exposed brain tissue. What is the most likely diagnosis? A. Hydrocephalus. B. Holoprosencephaly. C. Anencephaly. D. Encephalocele. A fetus demonstrates absent calvarium with exposed brain tissue. What is the most likely diagnosis? A. Hydrocephalus. B. Holoprosencephaly. C. Anencephaly. D. Encephalocele. So our correct answer is C, which is in anencephaly. Anencephaly is the correct answer there. Anencephaly. Question number 19. The fetal bladder should normally fill and empty approximately every. The fetal bladder should normally fill and empty approximately every A. 5 minutes. B. 30 to 45 minutes. C. 2 hours. D. 4 hours. The fetal bladder should normally fill and empty approximately every A. 5 minutes. D. 30 to 45 minutes. C. 2 hours. Then D. 4 hours. So the correct answer is B, which is 30 to 45 minutes. The fetal bladder should empty every 30 to 45 minutes. So question number 20, which is the last question for this session. Which Doppler index increases with worsening placental resistance? Which Doppler index increases with worsening placental resistance? A. The pulsatility index PI. B. Peak systolic velocity only. C. Mean velocity. D. The acceleration time. The question again. Which Doppler index increases the worsening placental resistance? A. Pulsatility index PI. B. Peak systolic velocity only. C. Mean velocity. Then D. The acceleration time. So our correct answer is A, which is the pulsatility index PI. The explanation: as placental vascular resistance increases, the pulsatility index PI raises, resistance index RI rises. So any diastolic flow decreases and may become absent or reversed in severe placental insufficiency. So that's the correct explanation answer. So it is the pulsatility index PI that increases. So ladies and gentlemen, this brings us to the end of this session. So I want you to do a self-evaluation before you look at the answer. Try to write your answer down, then compare, assess yourself, then evaluate yourself. I also need your self-evaluation certificates. Give yourself your certificate. I'm not going to give you the certificate myself, but your certificate is your own self-evaluation. Certify yourself to say that I'm competent enough,
I am ready for the exam. So I'm going to keep on giving you these American registry examination questions. Then you revise as much as you can. When you feel that you are ready, then you can attempt the examination. All the best are those who are writing the registry examination. All the best, all those who are also learning, acquiring knowledge. This is very useful for your practice. Do as many as you can and then learn as much as you can. Thank you so much. Don't forget to share this information, like our videos, and also comment. Thank you. Hello everyone. So most of my male clients or patients, they think or they feel that ultrasound is only meant for pregnant scanning. So they get the surprise of their lifetime when they are referred for an ultrasound scan. So now, let me introduce to you medical ultrasound. Even those who are already practicing, the applications of medical ultrasound. This looks like a very simple, straightforward topic, but it's not. Because this is now the foundation of what we are supposed to do. It's the syllabus of medical ultrasound. So what we are going to discuss now, I need you to pay very particular attention to our syllabus of ultrasound. So beyond pregnancy, the diverse application of ultrasound in modern medicine. This is my presentation today. So ultrasound is more than just looking at babies. Did you know that? Yes, you do, because you're a sonographer. Yes, you do, because you're a radiologist. But there's somebody who doesn't know that, the patient, and someone who's being introduced to ultrasound for the first time. We've got students. So, the narration. When many people hear the word ultrasound, they immediately think about pregnancy. While fetal imaging is one of the most recognized uses of ultrasound, these incredible technologies become an indispensable tool across almost every field of medicine. So today, we will explore how ultrasound saves lives, improves diagnosis, guides procedures, and helps doctors make rapid decisions all without radiation. So, what is ultrasound? So by definition, ultrasound is an imaging technique that uses high-frequency sound waves, real-time imaging, no ionizing radiation, and portable technology. So the advantages of ultrasound are: it is safe, it's non-invasive, it's affordable to most, it's repeatable, it's real-time, and then we can have what is called bedside imaging. So the narration: unlike X-rays or CT scans, ultrasound uses sound waves rather than radiation, making it extremely safe even for repeated examinations. So, the obstetric and the pregnancy application. Most common application of medical ultrasound: confirm pregnancy, determine gestational age, detect ectopic pregnancy, multiple pregnancies, fetal anomalies, placental localization, growth monitoring, Doppler assessment, and amniotic fluid assessment. So narration: although pregnancy imaging remains the most familiar use of ultrasound, it represents only one part of this technology's capabilities. So let's delve more into that. Gynecological application. So ultrasound evaluates fibroids, ovarian cysts, endometriosis, PCOS, pelvic pain, infertility, endometrial pathology, early pregnancy complications, for instance. So, the abdominal application of medical ultrasound. Common organs examined: the liver, the gallbladder, the pancreas, the kidneys, the spleen, the abdominal aorta. So the common diagnosis: the fatty liver, the cirrhosis, the gallstones, the kidney stones, hydronephrosis, abdominal aneurysms. So cardiology or echocardiography application of medical ultrasound. It evaluates the heart chambers, the heart valves, ejection fraction, congenital heart disease, pericardial effusions, and cardiomyopathies. So the narration: Echocardiograph allows cardiologists to observe the heart beating in real time. So the vascular application of medical ultrasound. Applications: deep venous thrombosis, the varicose veins, carotid stenosis, peripheral artery disease, dialysis fistula assessment, venous insufficiency. So the breast application of ultrasound is used for breast lumps, the cyst, the fibroadenomas, breast cancer evaluation, axillary lymph nodes, ultrasound guided biopsies. So the thyroid applications of medical ultrasound. It detects the thyroid nodules, the goiter, thyroid cancer, enlarged lymph nodes, salivary gland disease. So the musculoskeletal ultrasound application of medical ultrasound, it evaluates the tendons, the ligaments, the muscles, the bursa, the joint effusions, the sports injuries, common conditions, the rotator cuff tears, the Achilles tendon rupture, tennis elbow, plantar fasciitis, for instance. So we also would what is called the emergency ultrasound, which is called the point of care ultrasound, POCUS. So used in emergencies, fast examinations detects internal bleeding, cardiac tamponade, the pneumothorax, pleural effusion, shock evaluation. So the narration: point of care ultrasound is revolutionized emergency medicine by providing immediate diagnostic information at the bedside. So now, the pediatric ultrasound. Do you know the pediatric application of ultrasound? Applications: infant hips, pyloric stenosis, appendicitis, the kidneys, the neonatal brain, injury susception, to name but a few. So also we got the interventional ultrasound. Interventional ultrasound. Have you ever heard about it? So what is it? It guides needle biopsies, fluid drainages, joint injections, vascular access, nerve blocks, tumor ablation. The benefits of interventional ultrasound are high accuracy, safer procedures, and fewer complications. So now, there is also the emerging applications of medical ultrasound. What are those? So the future directions: AI-assisted ultrasound, elastography, contrast-enhanced ultrasound, handheld ultrasound devices, tele-ultrasound, robotic ultrasound systems. So the narration: artificial intelligence and portable devices are making ultrasound faster, smarter, and more accessible, bridging high-quality imaging to remote and deserved communities. So we are bringing medical ultrasound that is accessible to remote and undeserved communities. So the underserved, undeserved communities. That's where we are taking ultrasound to, using these imaging technologies and applications. So now, why ultrasound matters? The key advantages: one, no radiation, is affordable, it's portable, bedside imaging, dynamic imaging, also with immediate diagnosis, safe for all ages, and cost effective. It also guides treatment. So now, in conclusion, your take-home message for the day: ultrasound is not just for pregnancy. It has transformed the diagnosis and management of disease involving their heart, blood vessels, the abdomen, the breast, the thyroid, the muscles, the joints, imaging medicine, pediatrics, image guiding procedures. So the narration: from the imaging room, from the emergency room to the operating theater, from newborn babies to elderly patients, ultrasound continues to transform modern medicine. As technology advances, its role will always continue to expand, making healthcare safer, faster, and more accessible around the world. So, thank you for watching. Like this video, share your favorite ultrasound application in the comments, subscribe to Medical Ultrasound Academy for ultrasound case studies, RDMS and SPI preparations, report writing tutorials, obs and gyne imaging, Doppler ultrasound, quiz questions, practical scanning tips. So the question of the day that I want to leave you with: which ultrasound specialty interests you the most? Obstetrics, cardiology, vascular, emergency, musculoskeletal, interventional? Let us know in the comments. So we need to compile the preferences, which areas that you should tackle first, according to the majority wish. Yeah, then we can do the other ones later, because I'm going to teach you all. So to me, this is an introduction. So the areas that I have covered in these presentations are what I am going to teach you or assist you with. So if you got certain areas, so depending on the number, the cumulative number of people who want certain areas, if you say that you want musculoskeletal, we want obstetrics, gynecology, I will center myself much on those areas. So I will focus more on those areas, then the other ones later. Or if there's a 50-50, then I can just be doing them concurrently as we go. Thank you so much for your time. Enjoy the rest of your day. Let's meet again in the next presentation. Bye. Hello, everyone. So most of my male clients or patients, they think or they feel that ultrasound is only meant for pregnant scanning. So they get the surprise of their lifetime when they are referred for an ultrasound scan. So now, let me introduce to you medical ultrasound. Even those who are already practicing, the applications of medical ultrasound. This looks like a very simple, straightforward topic, but it's not. Because this is now the foundation of what we are supposed to do. It's the syllabus of medical ultrasound. So what we are going to discuss now, I need you to pay very particular attention to our syllabus of ultrasound. So beyond pregnancy, the diverse application of ultrasound in modern medicine. This is my presentation today. So ultrasound is more than just looking at babies. Did you know that? Yes, you do, because you're a sonographer. Yes, you do, because you're a radiologist. But there's somebody who doesn't know that, the patient, and someone who's being introduced to ultrasound for the first time. We've got students. So, the narration. When many people hear the word ultrasound, they immediately think about pregnancy. While fetal imaging is one of the most recognized uses of ultrasound, this incredible technology has become an indispensable tool across almost every field of medicine. So today, we will explore how ultrasound saves lives, improves diagnosis, guides procedures, and helps doctors make rapid decisions, all without radiation. So, what is ultrasound? So by definition, ultrasound is an imaging technique that uses high-frequency sound waves, real-time imaging, no ionizing radiation, and portable technology. So the advantages of ultrasound are: it is safe, it's non-invasive, it's affordable to most, it's repeatable, it's real-time, and then we can have what is called bedside imaging. So the narration: unlike X-rays or CT scans, ultrasound uses sound waves rather than radiation, making it extremely safe even for repeated examinations. So, the obstetric and the pregnancy application. Most common application of medical ultrasound: confirm pregnancy, determine gestational age, detect ectopic pregnancy, multiple pregnancies, fetal anomalies, placenta localization, growth monitoring, Doppler assessment, and amniotic fluid assessment. So narration: although pregnancy imaging remains the most familiar use of ultrasound, it represents only one part of this technology's capabilities. So let's delve more into that. Gynecological application. So ultrasound evaluates fibroids, ovarian cysts, endometriosis, PCOS, pelvic pain, infertility, endometrial pathology, early pregnancy complications, for instance. So, the abdominal application of medical ultrasound. Common organs examined: the liver, the gallbladder, the pancreas, the kidneys, the spleen, the abdominal aorta. So the common diagnosis: the fatty liver, the cirrhosis, the gallstones, the kidney stones, hydronephrosis, abdominal aneurysms. So cardiology or echocardiography application of medical ultrasound. It evaluates the heart chambers, the heart valves, ejection fraction, congenital heart disease, pericardial effusions, and cardiomyopathies. So the narration: echocardiograph allows cardiologists to observe the heart beating in real time. So the vascular application of medical ultrasound. Applications: deep venous thrombosis, the varicose veins, carotid stenosis, peripheral artery disease, dialysis fistula assessment, venous insufficiency. So the breast application of ultrasound is used for breast lumps, the cyst, the fibroadenomas, breast cancer evaluation, axillary lymph nodes, ultrasound guided biopsies. So the thyroid applications of medical ultrasound. It detects the thyroid nodules, the goiter, thyroid cancer, enlarged lymph nodes, salivary gland disease. So the musculoskeletal ultrasound application of medical ultrasound, it evaluates the tendons, the ligaments, the muscles, the basa, the joint effusions, the sports injuries, common conditions, the rotator cuff tears, the Achilles tendon rupture, tennis elbow, plantar fasciitis, for instance. So we also would what is called the emergency ultrasound, which is called the point of care ultrasound, POCUS. So used in emergencies, fast examinations detects internal bleeding, cardiac tamponade, the pneumothorax, pleural effusion, shock evaluation. So the narration: point of care ultrasound is revolutionized emergency medicine by providing immediate diagnostic information at the bedside. So now, the pediatric ultrasound. Do you know the application of ultrasound? Applications: infant hips, pyloric stenosis, appendicitis, the kidneys, the neonatal brain, injury susception, to name but a few. So also with the interventional ultrasound. Interventional ultrasound. Have you ever heard about it? So what is it? It guides needle biopsies, fluid drainages, joint injections, vascular access, nerve blocks, tumor ablation. The benefits of interventional ultrasound are high accuracy, safer procedures, and fewer complications. So now, there is also the imaging applications of medical ultrasound. What are those? So the future directions: AI-assisted ultrasound, elastography, contrast-enhanced ultrasound, handheld ultrasound devices, tele-ultrasound, robotic ultrasound systems. So the narration: artificial intelligence and portable devices are making ultrasound faster, smarter, and more accessible, bridging high-quality imaging to remote and deserved communities. So we are bringing medical ultrasound that is accessible to remote and undeserved communities. So the underserved, undeserved communities. That's where we are taking ultrasound to, using these imaging technologies and applications. So now, why ultrasound matters? The key advantages: one, no radiation, is affordable, it's portable, bedside imaging, dynamic imaging, also with immediate diagnosis, safe for all ages, and cost effective. It also guides treatment. So now, in conclusion, your take-home message for the day: ultrasound is not just for pregnancy. It is transformed the diagnosis and management of disease involving their heart, blood vessels, the abdomen, the breast, the thyroid, the muscles, the joints, imaging medicine, pediatrics, image guiding procedures. So the narration: from the imaging room, from the emergency room
to the operating theater, from newborn babies to elderly patients, ultrasound continues to transform modern medicine. As technology advances, its role will always continue to expand, making healthcare safer, faster, and more accessible around the world. So, thank you for watching. Like this video, share your favorite ultrasound application in the comments, subscribe to Medical Ultrasound Academy for ultrasound case studies, RDMS and SPI preparations, report writing tutorials, OBS and GYN imaging, Doppler ultrasound, quiz questions, practical scanning tips. So the question of the day that I want to leave you with: which ultrasound specialty interests you the most? Obstetrics, cardiology, vascular, emergency, musculoskeletal, interventional? Let us know in the comments. So we need to compile the preferences. Which areas that you should we tackle first, according to the majority's wish? Then we can do the other ones later, because I'm going to teach you all. So to me, this is an introduction. So the areas that I have covered in these presentations are what I am going to teach you or assist you with. So if you've got certain areas, so depending on the number, the cumulative number of people who want certain areas, if you say that you want musculoskeletal, we want obstetrics, gynecology, I will center myself much on those areas. So I will focus more on those areas, then the other ones later. Or if there's a 50-50, then I can just be doing them concurrently as we go. Thank you so much for your time. Enjoy the rest of your day. Let's meet again in the next presentation. Bye.
Hello colleagues, how are you? Now we are going to do the cesarean scar pregnancy quiz. These are detailed ultrasound quiz questions. They are just 6 questions that I need us to attempt. So question number 1, where is the gestational sac? Where is the gestational sac? Where is the gestational sac? You can see there. Where is this? Clinical scenario: a 32-year-old woman, G3P2 with 2 previous cesarean sections, presents at 7 weeks gestation with light vaginal bleeding. Transvaginal ultrasound demonstrate empty uterine cavity, empty cervical canal, gestational sac located in the anterior lower uterine segment, sac impeded in the previous cesarean scar. Which is the most likely diagnosis? A. Cervical ectopic pregnancy. B. Incomplete miscarriage. C. Cesarean scar pregnancy. D. Low intrauterine pregnancy. So these quiz questions are just meant for or revision to enhance on what we have done in the lecture. So it's not an examination, but just an enhancement lecture, so that you master what we have just done. So which is the correct answer? Which one is the correct answer? Transvaginal ultrasound demonstrate empty uterine cavity, empty cervical canal, gestational sac located in the anterior lower uterine segment, sac impeded in the previous cesarean scar. Which is the most likely diagnosis? A. Cervical pregnancy. B. Incomplete miscarriage. C. Cesarean scar pregnancy. D. Lower uterine pregnancy. So the answer is C, which is cesarean scar pregnancy. The explanation: the combination of empty uterine cavity, empty cervical canal, gestational sac implanted within the anterior lower uterine segment and the cesarean scar is diagnostic of a cesarean scar pregnancy. So let's proceed. Question number 2, which ultrasound finding confirms the diagnosis? So you see there, you see there, you see there, you see there. Clinical scenario: a woman with 1 previous cesarean section is scanned at 6 weeks. Ultrasound shows gestational sac in the lower anterior uterus. Residual millimeter measures 1.8 millimeters. Intense vascularity surrounding the sac, as you can see there. Which finding most strongly suggests cesarean scar pregnancy? A. Thick endometrium. B. Simple ovarian cyst. C. Thin residual endometrium with rich peritrophoblastic blood flow. D. Free pelvic fluid.
which a woman with one previous cesarean scar is scanned at 6 weeks. Ultrasound shows gestational sac in the lower anterior uterus. Residual millimeter measures 1.8 millimeters. Intense vascularity surrounding the sac, which finding most suggest cesarean scar pregnancy. A. Thick endometrium. B. Simple ovarian cyst. C. Thin residual endometrium with rich trophoblastic blood flow. D. Free fluid. So our correct answer here is C. Explanation: typical cesarean ectopic pregnancy demonstrate very thin residual endometrium, hypervascular trophoblastic ring, low resistant Doppler flow. These findings help distinguish CSP from miscarriage or low intrauterine pregnancy. So question number 3, differential diagnosis. Clinical scenario: a patient has empty uterine cavity, gestational sac inside the cervical canal, normal anterior lower uterine wall, no scar implantation. That is what we have there. Differential diagnosis. What is the diagnosis? A. Cesarean scar pregnancy, cervical ectopic. C. Miscarriage. D. Placenta previa. A clinical scenario: a patient is empty uterine cavity, gestational sac inside the cervical canal, normal anterior lower uterine wall, no scar implantation. What is the good diagnosis? A. Cesarean scar pregnancy. B. Cervical pregnancy. C. Miscarriage. D. Placenta previa. So the correct answer is cervical pregnancy. The explanation: unlike CSP, a cervical pregnancy planted within the cervical canal, not in the anterior lower uterine segment scar. So question number 4, the Doppler interpretation. Clinical scenario: color Doppler demonstrates numerous vessels surrounding the gestational sac, high velocity flow, low resistance waveform. What does that represent? A. Corpus luteum. B. Placenta insufficiency. Active trophoblastic invasion. D. Endometrial polyp. So what does that represent? Color Doppler interpretation. Clinical scenario: color Doppler demonstrate numerous vessels surrounding the gestational sac, high velocity flow, low resistance waveform. What does this represent? A. Corpus luteum. B. Placenta insufficiency. C. Active trophoblastic invasion. D. Endometrial polyp. So the correct answer is C. The intense vascular ring represents active trophoblastic invasion, a hallmark of viable cesarean scar pregnancy. The intense vascular ring represents active trophoblastic invasion, a hallmark of viable cesarean scar pregnancy. Question number 5, which measurement is most important? Which measurement is most important? There you see there's a niche there, there's a record niche there, then you see there's this ectopic pregnancy there in the cesarean scar. Clinical scenario: while documenting a suspected CSP, which measurement is most critical to include the ultrasound report? A. Ovarian volume. B. Endometrial thickness. C. Residual myometrial thickness between the gestational sac and the bladder. C. Cervical length. Clinical scenario: where documented suspected CSP, which measurement is most critical to include in the ultrasound report? A. Ovarian volume. B. Endometrial thickness. C. Residual myometrial thickness between the gestational sac and the bladder. D. The cervical length. So the correct answer is C. The explanation: residual myometrial thickness helps estimate the risk of uterine rupture, placenta accreta spectrum, blood invasion. It is one of the most important measurements in the report. So question number 6, this is the reporting challenge. There we have the scenario that we have the clinical scenario. Your ultrasound findings include empty uterine cavity, empty cervical canal, live embryo at previous cesarean scar, residual myometrium is 2 millimeters, marked trophoblastic vascularity, as you can see there, residual myometrium which is only 2 millimeters, marked trophoblastic vascularity, no free fluid. Which is the best explanation? A. Threatened miscarriage. B. Low intrauterine pregnancy. C. Pregnancy of unknown location. So the and then D. Live cesarean scar ectopic pregnancy, marked thinned residual myometrium. Clinical scenario: your ultrasound findings include empty uterine cavity, empty cervical canal, Life improved the previous cesarean scar. Residual myometrium 2 mm, marked peritrophoblastic vascularity, no free fluid, which is the best interpretation. Threatened miscarriage, low intrauterine pregnancy for no location, live cesarean scar, ectopic pregnancy, marked thinned residual myometrium. So the correct answer is D. The impression should clearly identify the pregnancy is a live cesarean scar, ectopic pregnancy, the presence of markedly thinned residual myometrium indicating increased risk, the need for IGN specialist or obstetric gynecological assessment. So the bonus question, true or false, a positive sliding signs suggests the diagnosis of a cesarean scar ectopic pregnancy. The answer is false. In a cesarean scar pregnancy, the gestational sac is firmly implanted within the scar and does not slide with gentle pressure from the transvaginal probe. A positive sliding sac sign is more consistent with a miscarriage in progress rather than a cesarean scar pregnancy. So, ladies and gentlemen, this brings us to at the end of our quiz session. So, these quiz sessions are meant for learning. They are not examination questions. So, I hope you are learning a useful trade from them. Take them very seriously. They will assist you with your daily diagnosis as you do your practice or your work. Enjoy the rest of your day. Let's meet again in the next presentation. So I encourage you to comment if you've got areas that you need me to present on or to tackle or to clarify on. I will do that with pleasure. Feel free under the comment section to add your comments. If you've got any suggestions, I also take those ones. Thank you so much. Enjoy the day.
Welcome back, colleagues. So, learning without assessing your knowledge is useless. So, in this episode, we are going to tackle some 6 quiz questions. So, these are on identifying subtle fetal cleft lip signatures using the maxillary line technique. These questions are designed for sonographers, radiologists, obstetricians, and ultrasound students. Each includes a detailed explanation and recommending image for presentation. So, question number 1. A 22-week fetal anomaly scan demonstrated a smooth and uninterrupted echogenic maxillary line on the coronal facial view. A 22-week fetal anomaly scan demonstrated a smooth, uninterrupted echogenic maxillary line on the coronal facial view. The upper lip and nostrils appear symmetrical. What is the most likely diagnosis? A 22-week fetal anomaly scan demonstrates smooth, uninterrupted echogenic maxillary line on the coronal facial view. The upper lip and nostrils appear symmetrical. What is the most likely diagnosis? A. Unilateral cleft lip. B. Bilateral cleft lip. C. Normal fetal upper lip. D. Cleft with a palate. So the correct answer is A. Unilateral cleft lip. B. Bilateral cleft lip. C. Normal fetal upper lip. D. Cleft lip with palate. So the correct answer is normal fetal upper lip. So the explanation: the maxillary line should appear as a continuous bright echogenic line without interruption or asymmetry. A normal coronal facial view demonstrates continuous upper lip, symmetrical nostrils, intact philantrum, smooth alveolar ridge, no defect in the maxillary line. These findings exclude the cleft lip. So, a normal coronal facial view demonstrates continuous upper lip, symmetrical nostrils, intact philantrum, smooth alveolar ridge, no defect in the maxillary line. These findings exclude the cleft lip. So, the educational appeal: A continuous maxillary line is one of the strongest indicators of normal upper lip. Now let's go to question number 2. During a 20-week anatomy scan, the sonographer noticed a small interruption of the left side of the upper lip. The left nostril is widened and the maxillary line is interrupted on one side only. What is the diagnosis? During a 20-week anatomy scan, the sonographer noticed a small interruption of the left side of the upper lip. The left nostril is widened and the maxillary line is interrupted on one side only. What is the most likely diagnosis? A. Bilateral cleft lip. B. Unilateral cleft lip. C. Normal variation. D. Isolated cleft palate. What is the correct answer? During a 20-week anatomy scan, the sonographer noticed a small interruption of the left side of the upper lip. The left nostril is widened and the maxillary line is interrupted on one side only. What is the diagnosis? A. Bilateral cleft lip. B. Unilateral cleft lip. C. Normal variation. D. Isolated cleft palate. So the correct answer is B, which is the unilateral cleft lip. Explanation: typical ultrasound findings include break in the upper lip, interrupted maxillary line, nostril asymmetry, missing soft tissue on one side, normal opposite side. These findings are classic for unilateral cleft lip. Educational appeal: most cleft lips are unilateral and occur most frequently on the left side. Question number 3. A fetal facial scan shows interruption of the maxillary line on both sides with a protruding central premaxilla. Which diagnosis is most likely? A fetal facial scan shows interruption of the maxillary line on both sides with a protruding central premaxilla. Which diagnosis is most likely? A. Isolated cleft lip. B. Bilateral cleft lip. C. Normal upper lip. D. Facial artifact. A fetal facial scan shows interruption of the maxillary line on both sides with the protruding central premaxilla. Which diagnosis is most likely? A. Isolated cleft lip. B. Bilateral cleft lip. C. Normal upper lip. D. Facial artifact. So the correct answer is B. Bilateral cleft lip. The explanation: characteristic findings include bilateral interruption of the lip, a floating premaxilla, wide facial defect, symmetrical abnormalities, flattened upper lip contour. So the educational appeal: protruding premaxilla is a classic feature of bilateral complete cleft lip. Question number 4. An interrupted upper lip is identified on coronal view imaging. Axial imaging demonstrates a discontinuity of the alveolar ridge extending into the palate. What is the diagnosis? An interrupted upper lip is identified on coronal imaging. Axial imaging demonstrates a discontinuity of the alveolar ridge extending into the palate. What is the correct diagnosis? A. Isolated cleft lip. B. Cleft lip with cleft palate. C. Normal features. D. Facial shadow artifact. An interrupted upper lip is identified on coronal imaging. Axial imaging demonstrates a discontinuity of the alveolar ridge extending to the palate. What is the diagnosis? A. Isolated cleft lip. B. Cleft lip with cleft palate. C. Normal features. D. Facial shadow artifact. So the correct answer is B, which is cleft lip with cleft palate. The explanation: palatal involvement is suggested when lip defects extend posteriorly, alveolar ridge is interrupted, hard palate is discontinuous, oral and nasal cavities communicate. These findings indicate combined cleft lip and palate. So, palatal involvement is suggested when lip defect extends posteriorly, alveolar ridge is interrupted, hard palate is discontinuous, oral and nasal cavities communicate. These findings indicate combined cleft lip and palate. So the educational appeal: always evaluate the palate whenever a cleft lip is detected because associated palatal defects are common. Question number 5. A suspected defect is seen on the fetal upper lip. After waiting for fetal movement, the apparent defect disappears. What is the most likely explanation? A suspected defect is seen on the fetal upper lip. After waiting for fetal movement, the apparent defect disappears. What is the most likely explanation? A true unilateral cleft lip. B, facial artifact caused by fetal position. C, bilateral cleft lip. D, cleft palate. A suspected defect is seen on the fetal upper lip. After waiting for fetal movement, the apparent defect disappears. What is the most likely explanation? A, true unilateral cleft lip. B, facial artifacts caused by fetal position. C, bilateral cleft lip. D, cleft palate. So the correct answer is B, that is facial artifact caused by fetal position. The facial artifact caused by fetal position. Explanation: false positive appearance may result from fetal hand covering the mouth, umbilical cord across the face, acoustic shadowing, poor insonation angle, maternal body habitus. Always reassess in multiple planes after fetal movement. So the educational appeal: never diagnose a cleft lip from a single image. Confirm the finding in sagittal, coronal, axial, and if available 3D views. Question number 6. Which fetal facial abnormality remains the most difficult to diagnose prenatally using ultrasound because the upper lip may appear completely normal? Which fetal facial abnormality remains the most difficult to diagnose prenatally using the ultrasound because the upper lip may appear completely normal? A, bilateral cleft lip. B, unilateral cleft lip. C, isolated palate. D, median cleft lip. Which fetal facial abnormality remains the most difficult to diagnose prenatally during ultrasound because the upper lip may appear completely normal? A, bilateral cleft lip. B, unilateral cleft lip. C, isolated cleft palate, D, median cleft lip. So the answer is C, which is isolated cleft lip. The explanation: isolated cleft palate is challenging because the upper lip is intact, the palate is deep within the oral cavity and difficult to visualize. Acoustic shadowing from facial bones can obscure the defect. Dedicated axial and coronal or palatal views, as well as advanced techniques such as 3D imaging, improve detection but do not identify all cases. So the educational appeal: the maxillary line technique is excellent for detecting cleft lip, but a normal maxillary line does not exclude an isolated cleft palate. A systematic assessment of the palate is essential whenever possible. So ladies and gentlemen, this marks the end of our quiz session. All the best to those who have attempted these questions. These are not quiz for an examination. These are academic quiz that enhances your knowledge and your understanding of cleft lip and palate diagnosis. Thank you so much. All the best in your practices. Don't forget to subscribe, share, and comment our educational content. Thank you. Hello, colleagues, and welcome. So in this presentation, I am going to discuss about one of the misunderstood areas in the practice of medical ultrasound, especially during the anatomy or anomaly scan. from 18 to 23 weeks. So my presentation today is on identifying subtle fetal cleft lip signatures using the maxillary line technique. Have you ever heard about the maxillary line? And do you know it? So if someone opens the mouth, so you see this is the middle tubercle that you see the prominence there inside the mouth at the roof there. And then what we have here on these sides, that's what we call the maxillary line. So the technique is using that line. So now, my introduction. Cleft lip is among the most common congenital facial anomalies, occurring in approximately 1 in 700 live births worldwide. Prenatal detection is improved significantly with advances in high-resolution ultrasound, yet small unilateral cleft lips and microforms remain challenging to identify. The maxillary line technique is a systematic sonographic approach that evaluates the continuity and the symmetry of the fetal upper lip and the maxilla. Rather than rely solely on obvious tissue defects, it focuses on subtle alterations in the echogenic maxillary line that may represent an early clue to a cleft. So what are our learning objectives in this lecture? By the end of this presentation, participants should be able to understand embryology of the fetal lip and palate, identify normal fetal facial anatomy, understand the maxillary line technique, detect subtle unilateral and bilateral cleft lips, differentiate isolated cleft lip from cleft lip with palate, recognize indirect sonographic markers, and avoid common scanning mistakes. Then produce a structured ultrasound report, which is the end game of communication. So the incidence. Orofacial clefts occur in approximately 1 in 700 live births. One of the commonest congenital anomalies may occur alone, may occur with trisomy 13, trisomy 18, 22q11 deletion, rare Pereire-Robin sequence, or Van der Waals syndrome. So the early diagnostics improves the delivery planning, the feeding preparation, airway management, surgical counseling, and genetic counseling. So now, the embryology, normal fusion. The upper lip forms from the right maxillary process, left maxillary process, and the middle nasal process. So fusion between 5 and 7 weeks of gestation, the palate is formed. So from 7 to 12 weeks, failure of fusion results in cleft lip, cleft palate, complete clefts, incomplete clefts. So we are saying that between the week 5 to 7 week fusion will take place, then the palate will form from 7 to 12 weeks. So failure of fusion results in cleft lip, cleft palate, complete clefts, incomplete clefts. So as someone who's just doing the ultrasound, you might not necessarily need to know the embryology, but you must understand the sonographic markers or signs for you to detect those orofacial abnormalities. So the types of orofacial clefts. So we have the classification, which is type 1, which is an isolated cleft lip. We have type 2, which is a unilateral cleft lip. Then we have type 3, which is bilateral cleft lip. Type 4, cleft lip with palate. Then type 5, which is isolated cleft palate. So which is the most difficult prenatal diagnosis, because you would the lip is there, but the palate is the one that is got a cleft. So that one becomes very difficult to visualize. So now the normal fetal facial views. The normal facial fetal views. So if you can look at this in the sagittal view, so you can see here the cleft. There's no cleft lip there. There's no cleft palate there. You can see on 3D it looks very normal. So every examination should include a sagittal view, shows the nose, the lips, and the chin. So it should show the nose, the lips, and the chin. So you can see here the eyes there, then the maxilla, and then there's no defect that you are seeing there. There's no defect here that you are seeing there. So now, the coronal nose lip view, it shows the nostrils, the upper lip, the philantrum. So the axial maxillary view shows the alveolar ridge and the maxilla. 3D surface rendering helps you when suspicious defect or parental counseling. So if you need to do parental counseling, then you have to do the 3D rendering, which is the best for us to see the clefts if they are there or not. So normal maxillary line technique, the principle. How do we use this one, or how do you do this? Is now what is very important or critical about this presentation now. So this addressing the core business of today now. So the principle, the maxillary line should appear continuous, smooth, symmetrical, bright echogenic line with a normal appearance. No interruption, no notch, no asymmetry. So what is the maxillary line? So you see this line that we have there, this one, this one, this one. That's the maxillary line that we have there. That's the maxillary line there. This one, you see, it should be continuous like that. It should be continuous like that. You should not see any defects. So on either side, you must see it continuous. So you can see here, we do have got a normal maxillary line there, but you can see here it's broken. So there it's not continuous. So you can see this fragment, this portion there. So you can see here this one is not continuous. So this maxillary line is very, very critical when you are doing your detailed ultrasound scan, or when I want to rule out these clefts. So assessment should include continuity, the width, like you have to measure the width of it to see if it's not too short, the symmetry and echogenicity. Is it echogenic like that? Are there discontinuities? Is it asymmetrical to the other one? So those are the fundamental questions that you should ask yourself when you are assessing the maxillary line for clefts. So normal coronal lip appearance, normal findings, smooth philantrum, continuous lip, equal nostrils, symmetric maxilla, and intact alveolar ridge. So now, let's check the unilateral clefts. So this is the unilateral cleft lip. You can see here it's only affect one side, it's affect one side, it's only on one side. So the classic findings, smooth notch, lip interruption, asymmetric nostril, disrupted maxillary line, and missing soft tissue. So these are the characteristics or the architecture of a unilateral cleft lip. Those are the things that you should be looking at. But what I can tell you guys, it's not always easy to pick these using your 2D ultrasound, especially also when you're not conscientized about, when you are doing a detailed scan, you're looking at a lot of things at the same time. So if you're not very careful, and also the fetal lie, it can really disturb you, so that you will not be it will not be difficult for you to check nicely. So in the event that you have got the 3D and the 4D, so you can use the 3D rendering now to demonstrate your cleft lip and palate. So the bilateral cleft lip, so you can see now on both sides like that. That is what the bilateral clefts are like. So if the findings, wide defect, floating premaxilla. So you can see here this premaxilla is floating there on this side. There it's not continuous. So this one, so here is also floating there. You see this is floating, it's floating there. So it's not continuous there. So are you seeing the maxillary line there? So the maxillary line there is very, very important when it comes to the diagnosis of this cleft. So floating premaxilla, two interrupted maxillary lines. So both of them are interrupted here. The interruption there, there's another interruption there. So flattened upper lip. So you can see this upper lip there it will be flattened. This flap there is flattened, as you can see there. So it can be shown nicely on 3D rendering. So the cleft lip with the palate, so you can see here with the cleft lip with the palate is also wide open. There's a gap there. So you can see here, there. So important clues for you to see the cleft lip and palate. Lip defect, alveolar gap, interrupted palate, missing echogenic palate, and communication with the nasal cavity. So there will be just communication with the nasal cavity there. There will be communication with the nasal cavity there. So isolated cleft palate. So this is the most difficult to make a diagnosis. So you can see here, you can see the lip is there, but there is a cleft there. So there's a cleft there that you can see there on the palate there. So often missed because lip appears normal. Look for missing hard palate, interrupted palate line, abnormal uvula, abnormal swallowing. So you can see this is the uvula there. If you see that the uvula is not there, these lines there, these are the uvula. So they are not there. So detection remains challenging and often requires a dedicated palatal imaging. So some of these things, guys, they are not so easy. But the good thing that if you are armed with the theory now, you know how to pick them, you make an extra effort using these notes, in a sense, the lines, the guidelines. So some of you, they just hold a probe, they go there, they want to make a scan. They don't know exactly what they are looking for. So you can just discover clearly by chance or by mistake, but because you don't know the protocols and what exactly are the landmarks that you're supposed to use to make the correct diagnosis that I can't see that I'm seeing this disruption. So these are the things that you should know before you do a cleft lip and palate assessment. So the axial maxillary view, this one, the axial maxillary view, this one. You can look, you can check this, you can check this, you can check there. You will be checking this line if it is continuous there. So access alveolar ridge. So this is the our alveolar ridge there. That's the alveolar ridge there. So you can see, if you look here, you can see that it's not, there are defects there in the alveolar ridge. You can see there are defects there in the alveolar ridge. You see there's a defect there in the alveolar ridge. So alveolar ridge continuity, maxillary arc, then the palatal integrity, tooth buds, later gestation. So these were the tooth buds. You can see them later with the progression of gestation, not in early stages. So now, the value or the role of 3D surface rendering. The advantages: it confirms diagnosis, it demonstrates defect clearly, it helps parents understand anatomy, it assists in surgical planning discussions. So now, indirect sonographic signs of cleft lip and palates. So look for abnormal nostril shape, the flattened phalanthrum, facial asymmetry, polyhydramnios with significant palate involvement, and associated anomalies. So now, the pitfalls. False appearances may result from fetal hand over the face, umbilical cord crossing the mouth, acoustic shadowing, poor fetal position, maternal obesity, oligohydramnios. Always rescan after fetal movement or use multiple imaging planes. So symmetrical examination protocol, surgical profile, coronal nose lip, axial maxilla, maxillary line assessment, the palate assessment, color Doppler if needed, 3D rendering, and detailed anomaly survey. So now, here is a template of how you report on those clefts. Findings. Fetal upper lip demonstrate a cleft, left side discontinuity, extending through the vermilion border. The maxillary line is interrupted on the left with associated alveolar ridge defect. Findings are consistent with a unilateral cleft lip involving the alveolus. Palatal involvement is suspected but cannot be confidently confirmed on the current examination. No additional facial abnormalities are identified on today's scan. Ladies and gentlemen, you do scans every day, but my worry is, do you go to the extent of writing these detailed reports? Do you do that? Have you ever done that? Should you do that? Or should you stick to traditions? So let us go through the report again, the simple report. Facial upper lip demonstrates a left-sided discontinuity extending through the vermilion border. The maxillary line is interrupted on the left with associated alveolar ridge defect. Findings are consistent with a unilateral cleft lip involving the alveolus. Palatal involvement is suspected but cannot be confidently confirmed on the current examination. So these are the limitations of the exam. So we are also recognizing the limitations of whatever I've done. Ultrasound is not foolproof. No additional facial abnormalities are identified on today's scan. So the impression now. Prenatal sonography features are consistent with a unilateral left cleft lip with alveolar involvement. Dedicated assessment for palatal extension in the detailed fetal anatomical survey are therefore recommended. I hope it's percolating well. So now, it has been a long discussion. What are the key take-homes? The maxillary line should always be smooth and uninterrupted. The maxillary line should always be smooth and uninterrupted. So you see how critical this maxillary line is in the diagnosis of cleft lip and palate. Evaluate the fetal face in 3 orthogonal planes: sagittal, coronal, and axial. Coronal imaging is the most reliable view for detecting cleft lip. Axial views helps assess the alveolar ridge. 3D surface rendering enhances diagnostic confidence and parental counseling. Isolated cleft palate remain the most difficult prenatal facial anomaly to detect, requiring careful targeted assessment. Ladies and gentlemen, I hope I've taken the message home. I hope this forms the foundation of your success journey in the diagnosis of cleft lips and palate. You might not start as a pro, But what I need to start is identify the maxillary line every time you do this sonar, and look at both and for symmetry and discontinuity. Start from there. Then we take it if a step further as we age towards being professionals. Thank you, ladies and gentlemen. Don't forget to subscribe, to share. If you've got a sonography story that you need to share as us, this is a sonography community. We welcome. If you've got your cases that we feel we should also discuss on, we are more than welcome. I thank you so much for your time, for your precious time. Enjoy the rest of your day. Thank you.
Hello and welcome. So today let's talk about improving diagnosis accuracy by correlating ultrasound findings with patient clinical history. So this is a practical guide for every sonographer and ultrasound practitioner. Our introduction. So improving diagnosis accuracy by correlating ultrasound findings with the patient clinical history. So the key message: ultrasound should never be interpreted in isolation. The patient history often determines whether an ultrasound finding is normal, abnormal, or incidental, or life-threatening. So the objectives of this presentation: by the end of this presentation, participants should be able to appreciate the importance of clinical history, recognize history that changes ultrasound interpretation, improve diagnostic confidence, and avoid common diagnostic pitfalls, produce clinically useful reports, and communicate effectively with referring clinicians. So why clinical history matters?
Why is this examination being
Why does it matter in the first place? Why should we bother ourselves with doing ultrasound? Why should we bother ourselves with clinical history?
Examination being performed,
ultrasound is highly operator dependent.
the lab test done,
The image alone does not provide the diagnosis.
Specific clinical question.
The diagnosis is reached by combining the clinical symptoms, the medical history, the physical examination, laboratory results, and the ultrasound findings. So the formula that we use is clinical history plus ultrasound plus laboratory findings is equal to beta diagnosis. So this is an equation. This is a formula that you must master.
Real-time
clinical history plus ultrasound plus laboratory findings is equivalent to the final diagnosis.
So our goal.
So now, the three pillars of diagnosis.
Objectives is
what are they?
Anatomy,
patient,
dynamic protocol,
the history, ultrasound,
interpretation, and
clinical correlation,
the reporting,
and then the final diagnosis. A beautiful scan interpreted without history may still be lead us to a wrong diagnosis. Even if you have got a very beautiful ultrasound scan interpreted without history, it might lead us to a misdiagnosis. So the patient, the history, the ultrasound, clinical correlation, and then the final diagnosis followed.
So capture the event.
So what clinical information should every sonographer collect? The general information, the age of the patient,
the clinical,
the sex of the patient,
the dynamic protocol,
the occupation of the patient, the weight of the patient, the height of the patient. These influence expected pathology, disease prevalence,
our target area,
technical scanning difficulty. Examples: a 19-year-old with pelvic pain is a very differential diagnosis from a 72-year-old with the same pelvic pain. Get that right.
Or focal media border
so,
tenderness.
Presenting complaint,
trauma,
always ask what brings you here today. Examples: pain, bleeding, swelling, lump, infertility, amenorrhea, the trauma, fever. Never rely on the request form. Never. Patients often require important additional information when you're doing the sonar.
Over the posterior ribs.
Pain history. Ask where did it start, constant or intermittent, the severity of the pain, radiation, relation to
trapezius and
meals,
rhomboids
relation
cover
to
the medial
menstruation,
scapular border.
relation to
These
pregnancy,
are reduced
pain
friction
location,
and
direct your
predictable
scan.
interfaces.
So
So
example,
the symptomatic
right upper
structure
quadrant pain,
moves while the
possible
pleura
diagnosis,
remains deep.
gallstones,
So you can see
acute
the
cholecystitis,
area of interest
liver
where
abscess,
we are
hepatitis,
assessing for the
kidney pathology.
snapping
The same
side.
liver lesion means different things depending
The
on
preparation,
symptoms.
the probe,
The
and the
same
patient
liver lesion
position.
means
A
different
high
things
frequency
depending
linear transducer,
on the symptoms.
lower frequency
So,
depth
the
requires
previous medical history
patient seated
always ask
prone
about
or lateral.
diabetes,
Choose the position
hypertension,
that reproduces
cancer,
the symptoms.
liver
So the
disease,
patient must choose
kidney
the position
disease,
that
thyroid
reproduces
disease,
symptoms. So when
HIV,
she or he can say that I'm
tuberculosis,
now feeling the
past
symptoms.
disease often predicts current
Expose the
findings.
entire medial border and compare
So,
both
the
sides.
previous surgery,
Use
critical questions,
generous gel,
previous cesarean
shallow
section,
depth, and one
hysterectomy, cholecystectomy,
comfortable movement produces the
appendectomy,
most diagnostic
myomectomy,
sign low.
thyroid surgery. So initially, I was very stupid.
So
I
build
wrote a report
reproducible
where I was saying that the
baseline
gallbladder was very normal.
So you can see here,
You know, when
we
I'm using
must
the
have a
reports, the
baseline
templates don't
map
edit,
that is
yet the
reproducible
patient had a
that you
cholecystectomy
must
3 years
build.
back. It was
Turn
very embarrassing of me. So you must
superior
always ask
angle,
the history
medial
of
border,
all those
and
previous
the
surgical
inferior
history,
angles. So you can
if
see
all
we
those
are,
organs
we are
are there
scanning the
or they were
whole of
removed.
that region
Otherwise,
there
you embarrass yourself
as
to
the
say that the
region
uterus
of
is normal
interest.
when a hysterectomy was
Sweep
done
in long and short
or
axes
cholecystectomy was done.
relative to the scapular
Example,
edge.
scale
Assess
endometriosis is
soft tissue
possible to
thickness,
suspect without
fluid
history.
masses,
Scale
and
is
cortical
impossible to
contour.
suspect without
Mark the
surgical
patient's
history.
point
You
of
understand this?
maximum
So
tenderness.
it is very difficult for you to
First,
think of scale
provoke
endometriosis
second. So you have to
if you
map
don't have the history.
the area where you're going to
So
scan
obstetric
first.
history
Then
for a
you
pregnant
provoke
patient, ask
the
the
area
LLP,
secondary.
gravidity, the parent, previous miscarriage,
So the maneuver
previous
one,
ectopic pregnancy,
maneuver one,
IVF pregnancy,
slow
previous cesarean
elevation.
section. These
Keep the probe
dramatically
centered
influence
on the painful
interpretation.
scapular edge.
So the example,
Ask for slow forward
positive pregnancy
flexion,
test,
then abduction.
ultrasound,
Observe
no
upward
intrauterine
rotation
pregnancy
and tissue passage
without
over the
history,
ribs. Repeat through the
pregnancy
exact
of
path
unknown location
that produces
with the
the
previous
symptoms.
ectopic
So you can
pregnancy,
see
very
where
high
you are
suspicion
now
for
putting the
recurrent
probe
ectopic.
there, then you can move, you glide your probe
So the menstrual history,
like that. Then the patient
always, you
also
must
can be
always
moving.
document the
The arm
LLP,
is you
cycle
do
length,
the scan. This should be a
regularity,
dynamic maneuver.
menopause. These
So you must
changes
observe
endometrial
the
interpretation.
upward rotation
Example,
and tissue passage over
endometrial
the
measuring
ribs.
12 millimeters,
So you must repeat
normal
through
in
the
secretary
exact act
phase,
that produces the symptoms.
abnormal in
Slow
postmenopausal
motion
bleeding.
reveals the frame
So the medication
immediately
history,
below the snap.
important medications like tamoxifen, oral
So maneuver 2,
contraceptives, hormone replacement therapy,
traction and retraction.
anticoagulants,
Contraction and retraction. So you
fertility
see
drugs.
someone
These
is
explain
holding even to
many
go, then they can move
ultrasound
forward
findings.
and backward, forward and backward.
So the laboratory
As you
correlation,
do the scan.
combine
So
ultrasound
patient
with
reaches
beta
forward,
HCG,
then gently squeeze his
PSA,
shoulder
liver
blades.
function
So you can
test,
squeeze the shoulder blades
CRP,
in and out.
WBC,
Stabilize the transducer
creatinine,
or the scapular moves
AFP,
beneath it.
CA125.
Break the basal
Ultrasound
plane and
alone
the
rarely
medial
provides
border.
a full picture.
Correlate
So now,
wrap movement with
the clinical
palpable
correlation
or
obstetrics,
audible snapping.
history
The
determines
probe stays still.
interpretation.
The scapula
Example,
performs the
positive
stress
pregnancy
test.
test,
So we are moving the scapula now,
pain,
while the probe is in the same
raise suspicion
position
for
as you
miscarriage,
make the observations.
ectopic pregnancy, molar pregnancy. So if
The
someone comes
maneuver
with
number
pain,
3,
then they've
load
got a
the
positive pregnancy
scapular
test. This raises suspicion for
stabilizers.
miscarriage,
Must load the
ectopic
scapular
pregnancy,
stabilizer, like you see
molar pregnancy.
how
Else,
this
if
guy
there's
is
no
putting
pregnancy positive test, it could
the
be
hand there
PID
to stabilizing
or some other
the scapula.
pelvic lesions,
Or
abscesses,
push
for
up,
instance.
expose winning
So,
and
the clinical
control
correlation in
the
gynecology, the
hand
history,
behind the back,
heavy menstrual
position to
bleeding,
widen the medial acoustic
ultrasound,
window,
fibroids,
resisted
the diagnosis,
elevation
symptomatic
only when
fibroids.
safe and
So
clinically
history,
appropriate. So
infertility,
if pain becomes severe
ultrasound,
or neurological
hydrosalpinx,
symptoms appear,
possible
we are saying that
tubal
during the maneuvers
infertility.
that you're doing,
So
when you
history,
feel that the
postmenopausal
pain
bleeding,
is
ultrasound
increasing,
endometrium, that is
then
10
that's where
millimeters,
you have to stop
possible.
it.
That's highly suspicious of
Our
endometrial cancer.
role is not to exacerbate the problem.
Clinical
it's to
correlation
manage the pain,
abdomen.
the problem,
So
or
patient
to
with fever,
diagnose the problem.
ultrasound,
Use the
hypoechoic liver
maneuver
lesion,
that reproduces
possible
the
diagnosis, liver abscess.
familiar snap
Patient without symptoms,
safely. So
same
at
lesion,
times,
possible
the patient knows
hemangioma.
that certain type of
Clinical
maneuver
history
that they
changes
do
everything.
will produce the snapping sound. So you must ask
So
them,
clinical correlation in
do
breast,
those certain type of
patient
movements
age
so that
24,
you can feel the snap and you can
oval
check
lesion,
what will be going
parallel
on at
orientation,
that particular point in time.
likely a fibroadenoma. Patient age 68,
What
same
a
lesion,
positive
needs
dynamic
greater
study may
suspicion.
show.
Age
What
changes
a positive
interpretation.
dynamic study may show.
Thyroid ultrasound, neck
Distended
swelling,
or thickened
ultrasound,
hypoechoic basal
mouth
plane.
nodular
So you
goiter,
can see a
history,
distended or thickened
hyperthyroidism,
hypoechoic
management
basal plane.
changes. Because
You can
now,
see an
history, there's
aberrant
hyperthyroidism,
basal
then management will
or
change.
muscular
If,
tissue
unlike if it's just a
bunching
goiter
at the scapular
without
edge. So you can
hyperthyroidism.
see tissue that will bunch up at the scapular
Doppler
edge.
findings require clinical context.
Focal
Absent
fluid
ovarian
is
blood flow,
placed during
history,
motion. So you can
sudden
see
severe pain.
a
So
focal
it could
fluid
be
that
ovarian
can be
torsion,
displaced during
absent
the
flow,
motions. You can see
large
that fluid,
postmenopausal ovary,
reproducible painful
possible
snap at the
necrotic tumor,
imaged abnormality.
differential
So you can
diagnosis.
actually
So the common
hear
mistakes
the sound,
that are
snapping
made,
sound during the maneuvers
ignoring the
as you are
history,
doing the scan
scanning
at
too
the
quickly,
site of the snap.
reporting incidental findings only,
Temporal
missing symptoms,
concordancy is
not asking
stronger
about
than
previous
in
surgery,
isolated
ignoring laboratory
static
findings,
So
failing to
we are saying
communicate
temporal
urgent findings.
concordancy is stronger than in isolated static
So the case study one,
finding. So
clinical history,
if you
28 years,
if you
pain,
finding in multiple
positive
planes,
pregnancy test,
it
previous ectopic,
gives you
ultrasound,
a better picture of what
empty
is
uterus,
going
as you
on
can see
than
there,
for you to just visualize
adnexial
a single
mass, as you can
static
see there,
image from a
free
single
fluid
dimension,
diagnosis.
and then you say that
This is
you
suspected
have all
of
the answer.
a
That's not
ruptured
the way it should
ectopic
be done.
pregnancy. Without history, the diagnosis may
So
be
you
delayed.
must document the snap for
So case 2,
reproducibility.
history,
You can see the snap
heavy
there, you
menstrual
can see
bleeding,
what is
ultrasound,
happening there,
large
the tissue
fibroid,
bunching up like
hemoglobin,
that, like that.
6
So
grams
save
per
sign loops
DL,
before,
diagnosis,
during, and after the
symptomatic
event.
fibroid causing severe anemia,
Record the maneuver,
requires urgent
arm
management.
angle, and exact problem.
Case number 3, history,
Measure
fever,
focal fluid or
right
mass
upper quadrant
in
pain,
orthogonal planes.
elevated
Add
WBC,
side to side
ultrasound,
comparison
complex liver
and
lesion,
pain
diagnosis,
correlation.
pyogenic
can
liver
compare with
abscess,
the contralateral
not a
A
hemangioma,
labeled
not
sign
a
loop is
hemangioma.
the key
So
diagnostic image. So if
communication
you
with referring
label your
clinician.
sign loop, that will be your
Always
key
communicate
diagnostic image
urgently
that
when
you can
findings
use as
suggest
a reference.
a ruptured ectopic pregnancy, ovarian torsion, placenta
Common
abruption,
mimics
deep
and
vein
alternative
thrombosis,
sources.
abdominal aortic aneurysms,
Physiological,
testicular torsion,
painless epitus or
appendicitis.
scapular
Good communication
dyskinesis can
always saves
mimic the
lives.
same.
So the structured reporting, an
Fibroma,
ideal report
docile,
contains
or other
clinical history,
periscapular masses can also
pelvic
masquerade
pain,
the same.
and positive
Rib or
pregnancy test.
scapular
The
exostosis
findings, detailed
or
ultrasound
malunion
observations,
or
impression,
superior prominence
highly
can
suspicious
also
for
mimic the same.
ruptured tuboectopic pregnancy.
Glenohumeral,
Recommendation, urgent
acromihumeral, or
gynecology
cervical
review is advised.
referred pain can also present like
So the
that.
tips for better
Not
diagnostic
every
accuracy:
posterior shoulder
read
clip
the request
is
form carefully,
scapulothoracic
speak with the patient,
bursitis. So it
review
can be
previous
anything
imaging,
else. So they are
compare
always
laboratory
at different levels.
results, scan systematically,
So when
correlate symptoms with
radiograph,
findings,
CT or MRI
avoid
become essential?
premature
When
conclusions,
do they become
and
essential?
discuss difficult
Suspected
cases.
bone prominency, osteochondroma,
The
fracture,
the
or
diagnostic pills.
malunion. Deep
These are
mass,
the diagnostic pills.
neurological deficit,
Treat the
or
patient, not just
unexplained
the
winning.
image. So yeah, dealing with the
Persistent
patient, not just the
symptoms
image.
despite
A perfect image
rehabilitation,
without history can mislead.
preoperative mapping, or
A modest image with excellent
non-diagnostic
clinical correlation often leads
ultrasound.
to the correct
So
diagnosis.
ultrasound
Ultrasound is both an
explains
imaging science
motion,
and a clinical
cross-sectional
art.
imaging defines
Take note of
extent.
that. Ultrasound is both an imaging science and a clinical
So the
art.
report the clinically
So the
actionable
final
events
summary:
immediately.
clinical history transforms
High the
ultrasound
scapular
from a descriptive
level
imaging tool
and
into a
provoking
powerful
maneuver,
diagnostic
static
instrument.
morphology plus the
By
real-time
integrating patient
mechanical
symptoms,
abnormality,
past medical and
presence,
surgical history,
size,
laboratory data,
vascularity
and
of fluid
image
or
findings,
soft tissue
sonographers
change,
and clinicians can
pain,
reduce diagnostic errors, improve
concordance,
report
and
quality,
study limitations.
prioritize urgent conditions, and enhance
Recommendations for
patient outcomes.
radiograph, CT,
The most
MR,
valuable
or
ultrasound
specialist
examination is
review.
not necessarily the
State whether
one
the
with the clearest
patient's
images. It is the one
familiar
interpreted
SNP was
within the
reproduced
correct
or not.
clinical context.
So this is part
So the
of
key
the
take-home
substance
messages to you,
and
ladies and gentlemen,
information that you should
always
incorporate
obtain
in
a
your
focused
report.
clinical history before scanning.
So the
Tailor your
practical
examination based
dynamic
on the
scanning
patient's symptoms and
checklist.
risk factors. Correlate ultrasound
Watch
findings with the laboratory and
and
clinical
palpate the
information.
movement before scanning.
Recognize
Map
when
the
similar
symptomatic
ultrasound
media border
appearances
at
have
rest.
different
Perform elevation,
meanings depending on the patient's history.
protraction,
Communicate
and
agent
targeted
findings
loading.
promptly and
Capture a
provide
labeled
clinical
signal
relevant
of the
recommendations.
exact snare.
High quality ultrasound
Compare
practice
size
combines
and
technical skill
escalate
with sound
unexplained
clinical
structural
reasoning.
disease. So
Ladies and gentlemen,
reproduce,
I think the message is
observe,
so clear to all of you.
correlate, then record.
Some they think that
You
ultrasound
see the
is
sequence.
only
Record,
about images
reproduce,
and their interpretation,
observe,
but there is something
correlate,
that is
and then
beyond
record.
the
You don't
images,
just
the history of the
have
patient,
to
the
record.
communication that we have
So,
with the
ladies and
patient. At
gentlemen,
times, the patient is not so
this
free to talk to
brings
the
us to
referring
the end
clinician. They can be free
of
to give
this
you more information to
presentation,
you that they
where
didn't provide to
we
the
are
referring clinician.
making
That can help
expert
narrow down the
sonographers
diagnosis.
out of you.
Thank you so much.
You are not just
Don't
there
forget to
to
comment,
memorize.
share, and like.
You are not just there to
And
memorize
also,
images.
if you've
We
got
are
questions,
there
feel free.
to
You
think,
can ask anything
to use
in the comment
experience,
section. Then I'll assist
explore,
you accordingly. Thank you so
and
much.
then document for the good
Welcome,
of practical.
colleagues. How are you?
So
So,
this
what
road
I
needs
am
people who are
giving
dedicated,
you
who are
now,
committed. It's not an easy
this
journey,
is the
but
gold
together
of first
we can do it.
trimester ultrasound scan.
Thank you so much.
I
Don't
am
forget to
giving
subscribe to our
you
channel. Also,
diamonds,
share this educational content
diamond
with your
fields
colleagues.
of first
Let's meet again
trimester
in the
ultrasound
next
scan
episode.
for free.
Bye for now.
These are the diamonds, not emeralds. These are the diamonds. So, this is the atlas of first trimester pregnancy failure. This is the atlas. So below are representative ultrasound appearance of the most common types of first trimester pregnancy failure. So number one, that's a normal pregnancy for comparison. So a normal pregnancy, you are supposed to see the decidual sign, the double decidual sign, that ring that we have. And if you zoom it, you can see the yolk sac there. The yolk sac is present there. So the yolk sac is present there. So this is the standard normal ultrasound scan that you all know of. But that is so good when it is like that. But it doesn't always follow like that, that you're going to see the normal. It is the abnormal that is now a going concern. So let's talk about the abnormal one. So the unembryonic pregnancy, the blighted ovum, So here you can see there, we can't see the gestational sac, neither can we see the embryo. There is nothing there. So there's nothing there. So say the view of an empty gestational sac or blighted ovum. So you can see there's nothing there. But we said you don't just jump and say this is a blighted ovum without measuring the mean gestational sac to be equivalent to or above 25 millimeters. As long as it is below 25 millimeters, you give it the benefit of the doubt. You can rescan it after a week or 2 weeks to see if the embryo start to develop. So this is the hallmark of a blighted ovum, an embryonic pregnancy. There is nothing. Yet the mean sac diameter is above 25 millimeters. So the embryonic demise, which is the so-called the missed abortion, the embryonic demise. So you can see here there's an elongated echogenic something that is here, that is echogenic and elongated there. It's shrunken. So that is the dead embryo. So the embryos died there, the embryos died. You can see there, you can see the dead embryo there, the dead embryo. If as long as it is above 7 centimeters and there's no cardiac activity, then you are confident that you're dealing with a case of what? Of a missed miscarriage or a dead embryo. So you must see an embryo inside with no cardiac activity on condition that that same embryo is got a diameter that is above 7 millimeters. I hope this is percolating well and you are getting it nicely. Okay. Inevitable miscarriage. Inevitable. Inevitable. It means that it can't be stopped. It can't be stopped. So when you see that the pregnancy is now inside the cervix, is on its way out, that is an inevitable miscarriage. You cannot save that. So when the os is closed, is open, and the vaginal canal is now the cervical canal is now open, you are supposed to know that we are in the highway out. So that's an inevitable miscarriage. So now, incomplete miscarriage. So when there is an incomplete miscarriage, there are episodes, there are periods in the first trimester that someone comes, they were pregnant, they started bleeding, then they come for the sonar. You can see retained products. So returned products, they appear like that. You see that there's an echogenic endometrium thickened like that, and then you can see there is hyperemia or hyperperfusion or enhanced myometrial perfusion due to the retained products of what? Of conception. So you must not just rush to say everything that you see is a RPOs or is an incomplete miscarriage. It might be endometrial hyperplasia, it might be endometrial cancer. So the history is very critical. Was someone pregnant? Were they bleeding? Then you can talk of an incomplete miscarriage. A complete miscarriage. So complete spontaneous abortion. So you can see there that the endometrial is there and it's thin. There are no retained products inside. So this is a complete miscarriage. So do not confuse a complete miscarriage with a normal period, because with a miscarriage we must have a history of pregnancy first before someone can miscarry. Otherwise it's a period or it's another type of bleeding, abnormal PV bleeding. So now we also have got what is called the subchorionic hemorrhage. So the hemorrhage on this on the other side of the chorion, there on the other side of the chorion there is what is called the subchorionic hemorrhage. So you can see here the gestational sac there, but you can see that there's another anechoic space there, that ring that you're seeing there. So this is a hemorrhage. That's the bleeding in the subchorionic space. So the hemorrhage in the subchorionic space there, there's hemorrhage in the subchorionic space. You can see in here it seems as if the gestational sac is detached, and then there's a hemorrhage all over here. So you must take note of a subchorionic hemorrhage and the threats that it can pose to the existing pregnancy. So please, this atlas will help you. It will help you to identify those soft markers of pregnancy failure. So the irregular gestational sac. So an irregular gestational sac that is not circular and all that is another sign of a pregnancy failure. You can see this is an elongated gestational sac. Don't see this and see that it is normal, and then you record that is normal, and then you try to measure the mean sac diameter like that. No, you see how it is like. Look, this is an irregular sac. Look how it is like that. Look how it is enlarged gestational sac like that. You see this one. So what we have here, guys, now is another sign of pregnancy that is failing. So it's an irregular gestational sac like that. So also an abnormal yolk sac. You see, look at this calcified yolk sac that we have there, a calcified yolk sac there, and then you can see this calcified rim of the yolk sac there, and which is also irregular. This is also another sonographic feature of a failing pregnancy. The yolk sac is also an indicator of a pregnancy that is likely to fail or that is going to fail. So you must look at the anatomy, the architecture of the yolk sac itself, if it is regular or well outlined at the same time without calcifications. So do you guys do that? Do you really check the yolk sac and analyze it for any sign of pregnancy failure? Yes, probably 19% do, probably 15% do, probably 10% do, probably 5, probably even 1% do. Do not leave these markers. These are the silent markers. That's why you say that I did a sauna today. Then someone comes after a week, they're bleeding, they're already miscarrying. You say, what happened? The pregnancy was very normal, because you overlooked these soft markers. You did not check them nicely. So when the patient comes, then they are now bleeding and all that. Then you say, I did my job, everything was fine. You understand? That kind of stuff. You understand? It is because of that. It is because of this. So the foundation is always very critical. Without the foundation, we cannot have structures. So pregnancy of unknown location. I have discussed about this. A pregnancy of unknown location is not a pathology. It is not a diagnosis. It is a condition, a transitional condition. It's a condition that is happening, but it's just like when you wash your clothes, they are still wet. It's a transition. When they dry up, they will not be wet anymore. Or if you keep soaking them in water, they will keep on being wet like that. You understand? So the condition, we don't know where the pregnancy is. You understand? That's a condition. But after some time, you will know. It was an ectopic. Oh, it was just there in the endometrial cavity. I did not see it nicely. I did not use a TV, so I just used a transabdominal. You know, negligence, incompetence, use of outdated equipment, lack of experience are all confoundings when it comes to the diagnosis of some of these pregnancies of unknown origin. So the due diligence is to repeat. There's power in repetition. So the patient comes again, you check again, the pregnancy test is done again, they confirm the beta ECG if there are changes, you understand, to make sure that it was indeed not a pregnancy, it was a false positive pregnancy in the first place. You understand? So that's how we will get a definitive. When we get the definitive answer, now we are out of the phase where we say that this was a pregnancy of unknown. Now we know it was never there, or it was an ectopic pregnancy, or it was just an early pregnancy that was here to develop. Now it's there. I hope I'm making sense. So ectopic pregnancy mimicking pregnancy failure. So we can have an ectopic pregnancy that can also mimic pregnancy failure. There you can see there it will mimic. An ectopic pregnancy is not always a pregnancy failure because it can be a viable pregnancy, but it can pose risks. You understand? An ectopic pregnancy is not a pregnancy failure. It is a pregnancy outside the uterus. So it can, in the abdomen, if there's enough space and the attachments are fine, it can just reach term. I've seen one case where we monitored an abdominal ectopic pregnancy until the baby delivered a healthy baby in the abdomen outside the uterus. It's very possible. So do not confuse an ectopic pregnancy for a failed pregnancy. But though it poses far-reaching consequences when it's not diagnosed as well, it's life-threatening. I hope I am making sense. So now, early twin pregnancy with a single fetal demise, vanishing twin. So this is another manifestation of pregnancy failure. You can have one fetus is normal, in twin pregnancy, then the other one is vanishing or is dying. So this is another case of a failed pregnancy. We are not saying both failed, one failed, you understand? Then the other one can make it. So in vanishing twin, the remaining or the residual twin just can make it nicely, you understand? So it's a partial pregnancy failure where one fails and the rest continues. So if you are not careful, you do a sonar, you see the twins, you tell your patient that these are twins, but later on when they come, you see that's one. So you are going to be seen like someone who's incompetent. You must know that there is what is called the vanishing twin syndrome, a sign of pregnancy failure. Then the other one may be probably vanished. That's what a professional does. So now, this collection covers the major ultrasound appearance. Welcome, colleagues. How are you? So, what I am giving you now, this is the gold of first trimester ultrasound scan. I am giving you diamond fields of first trimester ultrasound scan for free. These are the diamonds, not emeralds. These are the diamonds. So this is the atlas of first trimester pregnancy failure. This is the atlas. So below are representative ultrasound appearance of the most common types of first trimester